endometrial carcinoma categories, and the results were comparable with the other studies. Coming to my conclusion, stromal invasion was one significant parameter that helps in clearly distinguishing between atypical hyperplasia and endometrial carcinoma. Since identification of stromal invasion is quite challenging on small biopsies, PAX2 immunostain can aid in its differentiation. Hence, it was concluded PAX2 is one of the immunostain that can contribute towards differentiation of atypical hyperplasia and endometrial carcinoma. As the head score was analyzed for cases with heterogeneous staining, it was concluded that lower score points towards a diagnosis of endometrial carcinoma. These are my references. Thank you.
Any questions?
Couple of questions. A very nice presentation. It's an important study because endometrial hyperplasia, especially atypical, is pretty common in young women, infertile women who are in the childbearing age group. I am surprised that your median age is 57, you said?
Yes, in my study.
So your study hasn't probably looked at the younger age group where this is more important. This would have more relevance in practice. At age 57 median, you would end up doing hysterectomy. The question is whether to do hysterectomy or not. That's one point. PAX2, the partial becomes a problem. You would agree with me, partial for you may not be a partial for me. So the interoperable usability and variability are here.
Yes,
Although you have used the H-score, which is a cumbersome thing to use in daily practice. So would you say that a PAX2 loss patient in an endometrial hyperplasia is equivalent to an adenocarcinoma? Would you label it?
No, sir. But if we are looking into PAX2 staining loss in atypical hyperplasia, in such cases, probably we might want to do a hysterectomy in such cases because it is pointing towards endometrial carcinoma. But we can't confirmly say that it is like we can't label it as endometrial carcinoma. So, but yeah, it is pointing towards endometrial. Yeah,
maybe we would put it like that. If you have serially followed up patients of endometrial hyperplasia and they continue to show loss of expression of PAX, so those are the patients who are going to probably have problem in later. They are moving towards endometrial carcinoma.
Yes.
So rather than saying that PAX2 is equivalent or likely to harbor cancer, it's probably the follow-up of these patients of hyperplasia which PAX2 is.
And also some of the studies actually have told in combination with beta-catenin and beta-catenin will help.
So beta and beta-catenin are used in combination. So beta loss and beta-catenin expression is more in favor. So combination of these three would be more
actually. Yes. Thank you, sir.
Why the score is more than 75 and less than 75? What is the reason?
It is a heterogeneous staining, sir. Basically, when we are seeing different intensity, 1, 2, and 3, so in those, we can't say complete or partial loss. So what we do is we categorize it based on that formula. I showed that formula, sir, based on the staining. So that is why, based on that, we calculated a score. And we refer to multiple articles where the cutoff score of 75 helped us in differentiation rather than giving another scoring system. This was helpful for us.
Any cases of atypical hyperplasia show the less than 75?
Yes, a few of them actually showed, but they were not quite significant. Yeah, that was one thing. But in confirmed cases of endometrial carcinoma, they were, most of them showed complete loss. But in atypical hyperplasia cases, few of them showed, but not very significant. Yes. Thank you, sir. Thank you.
The next presenter is FOP7 with the FOP3. The study is a study on evaluation of prognostic significance of cyclin D1 in breast carcinoma.
Morning. I'm here to present my study on cyclin D1 immunostaining in breast carcinoma. a correlation with histopathological prognostic markers and molecular subtypes of breast cancer. Breast cancer is a heterogeneous disease having diverse biological features and clinical behaviors. So the expression of hormonal receptors and the identification of molecular subtypes have important prognostic and predictive roles in clinical management. And the development of new class of anti-cancer drugs have become the game changers now, including CDK4/6 inhibitors, which target the stimulation of cell cycle by cyclin D1. Cyclin D1 is an emerging biomarker which is related to progression and therapeutic response of invasive breast cancer. It's a key cell cycle regulatory protein which is positioned on chromosome 11q13, and amplification and overexpression of gene encoding cyclin D1 has been frequently observed in breast cancers. Although its prognostic value is being studied severally, the use of cyclin D1 as a routine prognostic tool is still under debate. So this study aims to study the histopathological spectrum of breast carcinomas and to study the immunohistochemical expression of cyclin D1 and correlate it with the known prognostic histopathological markers, that is tumor size, grade, and lymph node status, and to evaluate the relationship of cyclin D1 immunostaining with molecular subtypes using hormonal receptors and HER2 status wherever possible. We have included a total of 40 breast carcinoma cases, which was conducted for a duration of 6 months. We included both the biopsies and resected specimen, which were proven to be breast carcinoma on histopathology. And we excluded inadequate biopsies, poorly processed biopsies, and history of prior hormonal or chemotherapy. So H&E stain slides were evaluated, and the minimum of 60 to 70% well-preserved tumor area with less than 10% necrotic area was considered for cyclin D1 staining. And more than 10% positive cells were considered as positive cyclin D1 expression. And that was scored under 3-tier scoring system. And this was compared with the molecular subtypes of breast cancer using the other hormonal receptors. Statistical analysis was done using chi-square test, and p-value less than 0.05 was considered statistically significant. So demographically, majority of them were above 50 years of age, and 98% were females, and there was only one case of male patient. And cyclin D1 expression was seen in 30 out of 40 breast cases, that is 75%. So this correlation of cyclin D1 was done with the size of the tumor, but this was not statistically significant. So we correlated cyclin D1 grade of the tumor with a p-value of 0.04. Majority of them were moderately differentiated. And the correlation of cyclin D1 with lymph node status was done, but this was not statistically significant. So we compared it with the molecular subtypes where majority of the luminal A, B, and HER2 type express cyclin D1, whereas triple negative breast cancers did not express cyclin D1. So this was statistically significant. There was also a correlation done along with lymphovascular invasion and tumor infiltrating lymphocytes, which were not found to be statistically significant. So these are the images of cyclin D1 expression. Figure 1 shows in invasive carcinoma NOS, 2 is lobular carcinoma, and 3 is invasive mucinous carcinoma showing cyclin D1 positive expression. So figure 4 shows positive HER2 expression in NOS, and figure 5 shows ER expression in lobular carcinoma. So our study was concordant with other studies done by Panda et al., Pervin et al., and Mehta et al., which also showed the positive expression in luminal A, B, and HER2 type, but with a statistically significant results. So to conclude, our study confirms the strong association between cyclin D1 and grade of the tumor. High rate of expression of cyclin D1 and strong association with hormonal receptors highlights the independent significance of estimation of cyclin D1 with other prognostic factors. And its negative expression in triple negative tumors also indicates it is a favorable prognostic marker. So these are my references. Thank
you. You took 40 cases.
Yes.
You said you used both biopsies and resections.
Yes.
How many biopsies? Only biopsies were there?
No, sir. Both biopsies and resected specimen.
Of the same patient. So you took paired samples?
No, sir. No, sir. Of different cases. Sir.
So how many were only biopsies and how many were only resections?
We had approximately 26 resected specimens, sir.
And 14 were
biopsy.
And what about your heterogeneity in staining of cyclin D1? I'm just thinking because in a biopsy it might be heterogeneous. It's a small tissue. Your cyclin D1 may not be expressed in that small tissue compared to a resection specimen.
So wherever there was doubt, we confirmed it with the MRM specimen, sir. So
But you said
repeat
14
the-
were only biopsies. No, there were no resections in 14 cases.
Sir, if whenever we got the resected specimen of the same patient, we confirmed it with the MRM specimen, sir.
Then
Resected
that's fine.
specimen.
I'm just saying, were there only cases where only biopsy was subjected to cyclin D1 and they had no resection? There were some cases like that, no?
Yes, sir.
So you said 26 were resections and 14 cases were only biopsies.
So most of them showed positive expressions, sir.
Okay.
So there was no.
That's an important thing because see, most of the IHCs are heterogeneous,
Mm.
may not be expressed in a small biopsy sometimes. So you need to keep that because this is a study, and in a study you need to keep these things.
Thank you. Thank you.
Next presenter, FOP4. The title of the study is Clinical Cytoarchitectural, FOP7, Lymphoproliferative Disorders diagnosed primarily on serous effusion cytology. Cytology rises up to the challenge.
Good morning. My topic is lymphoproliferative disorder, diagnosed primarily on the serous effusion cytology. Cytology rises up to the challenge. Introduction: the involvement of the body fluid by the lymphoproliferative disorder is rare and often associated with a poor prognosis and decreased overall survival. And patient with a malignant lymphoma presenting with a serous effusion as a primary presentation is even rarer. So accurate subtyping is what vital for the proper treatment plans of the patient, has making a timely diagnosis becomes a great essence. And cytomorphological analysis with the aids of various ancillary technique help in clinching the diagnosis and achieving this feat. We have attempted to cytologically evaluate the lymphoproliferative disorder involving serous effusions as the initial presentation and have studied the role of immunocytochemistry. Study design was retroprospective, 8-year duration, and inclusion criteria was all serous effusion associated with the LPD without any primary diagnosis of lymphoma, and all adult pediatric
small cell lung carcinoma and not just plain adenocarcinoma?
Sir, because in the plan, based on if it is done
I once again request the presenters to stick to the time, please. The next presenter, FOP 18, Navigating the Diagnostic Conundrum of Papillary Lesions of the Breast from Benign to Malignant, an Experience at a Tertiary Care Center.
A very good morning to respected jury members and the delegates present over here. The topic of my presentation is Navigating the Diagnostic Conundrum of Papillary Lesions of Breast from Benign to Malignant, an Experience at a Tertiary Care Center. Papillary lesions of the breast are characterized by the presence of arborescent fibrovascular cores that support epithelial proliferation, and it's a heterogeneous group of neoplasms which accounts to less than 5% of the benign breast neoplasms and 0.5 to 2% of all breast malignancies. These lesions show overlapping clinical manifestations and histomorphological features, but may have divergent biological behavior. It encompasses a wide spectrum of lesions ranging from the benign intraductal papillomas to intraductal papillomas with superimposed components, papillomas with DCIS, with ancestral papillary carcinomas and invasive papillary carcinomas. The aim of the study was to study the histopathological spectrum of papillary breast lesions, clinical pathological characteristics, and the diagnostic difficulties encountered in the diagnosis at a tertiary care center. It's a retrospective study of 4 years duration from July 2019 to October 2023. All cases of histologically confirmed papillary breast lesions in the Department of Pathology were included, and all any form of missing data that was present was excluded. All histologically proven primary breast papillary breast lesion neoplastic lesions which were reported with papillary features and cytology were reviewed. Final histological diagnosis was recorded, and IC status was noted wherever available, and detailed history was recorded. Now, coming on to results, these are histological spectrum of papillary neoplastic lesions where we came across 920 cytological breast cases, out of which 210 showed papillary features and 47 were histologically confirmed. And out of 47, we saw that maximum proportion was made by intraductal papillomas with associated features, followed by intraductal papillomas, followed by papillary DCIS, encapsulated papillary carcinomas with invasive foci, solid papillary carcinomas, invasive papillary carcinomas, and inferior intraductal carcinomas with papillary lesions. Coming on to histological spectrum of intraductal papillomas associated with histological components, so we saw that maximally were associated with atypia, followed by usual rectal hyperplasia, followed by DCIS, and followed by atypical rectal hyperplasia and DCIS. Age-wise distribution of cases, maximally confined to 40 to 60 years of age, followed by 20 to 40 years of age, followed by elderly age group. Female was preponderant. And clinical features, maximally, they reported presence of lump, followed by lump with nipple discharge, only discharge, lump with pain, bloody discharge, and nipple ulceration. Coming on to specific cases, 25 years old female with a wide local excision, which came up to us for FNAC. We saw richly cellular smears with papillary fragments, 3D papillary fragments, and on high power, we can appreciate presence of benign ductal epithelial cells and myoepithelial cells also present over here. And on histology, we saw presence of finger-like broad papilla
and which was highlighted by, and the myopathial cells were highlighted by P63 stains and was reported as ductal papilloma. Coming on to next case, which was a case of 32 years old female with bilocal excision of the left lung. We can see presence of circumscribed nodule composed of papillary fragments, and here we can appreciate presence of both ductal and myopathial cells and associated foci of ductal carcinoma in situ component was present in the adjacent area. This was reported as ductal papilloma with DCIS component. Another case of 45 years old female with bilocal excision of left lung, we saw presence of we received a specimen of 4 by 4 by 3.5 centimeters, and on cut open we saw a central solid cystic nodule with a mural attached nodule at one periphery of the lesion, and we on mammography it showed the presence of a heterogeneous lesion, and on histology we saw that there were presence of atypical ductal epithelial cells with apocrine differentiation arranged in the papillary configuration. On high power we can appreciate presence of again the apocrine cells which showed moderate to abundant amount of eosinophil cytoplasm and prominent nuclei in some and presence of Syma body at periphery. Then on IC we saw that these lesions were ERPR HER2 negative, but it stained GCDFP positive 15, which which is associated with apocrine differentiation. P63 was negative both in the central as well as the periphery of the lesion, and HER2 again was negative. So and K67 was approximately 5%, and it was reported as encystic papillary carcinoma apocrine variant, which is a very rare tumor, and it usually presents in the it is a wide age range ranging from 40 to 80 years of age, and usually presents as a solid cystic nodule, which we have just seen the specimen that we have seen. Now coming on to 57 years old female with left breast lump, 3 by 2 centimeters of solid cystic lesion. Cytology showed presence of complex papillary fragments, and here we can appreciate presence of high power, the presence of moderate to aberrant amount of cytoplasm and a plasmacytoid pattern. Now it was reported as atypical papillary lesion. On histology, we again can see presence of circumscribed nodule with lumen containing papillary fragments, and here atypical cells arranged in papilla. And on IHC, we saw that both the periphery as well as lesion was negative for P63 stain. It was reported as encapsulated papillary carcinoma, followed by another case, which was a case of a 51 years old male with bilateral breast lumps. It was an interesting case because in cytology, we saw presence of papillary fragments. And on high power, we again appreciate atypical cells, which was, and on PAP stain, again, we can appreciate papillary fragments. This is a case of a cell block with that we prepared, cell block preparation, where we again appreciate presence of papillary configuration, which confirmed our diagnosis. Now here we can appreciate on wide local excision, we saw presence of a cystic nodule, which contains again papillary architecture, atypical cells arranged in papillary architecture. And at one focus on several exhaustive grossing, we could find a presence of a focus of IDC component, which was present in that adjacent area. And this is again the mastectomy specimen where it showed presence of a residual tumor. And this is a case of IDC residual tumor which was present. It was reported as encapsulated papillary carcinoma with invasive component, invasive carcinoma, no special type. Whereas on mastectomy, there was presence of a residual tumor. And again, a last case of 55 years old female with left breast lump, 5 by 4 by 3 centimeters. It was a solid cystic area where there was again a focus upon IDC component at the periphery, and it was P63 negative both at the in the lesion as well as periphery. It was negative in the lesion. And now it was reported as encapsulated papillary carcinoma with invasive component, no special type. Coming on to discussion, papilla, which are characterized by epithelial cell proliferation surrounding the fibrovascular core, are characteristic diagnostic features of papillary breast lesions. Accurate diagnosis of breast papillary lesion by FNS is problematic due to overlapping features. So therefore, it's given the challenge in stratifying intraductal papillary lesions, and an algorithmic approach has to be was proposed to the diagnosis in which the presence and distribution of epithelial cells is of utmost importance, and it is followed by characterization of the nature of the epithelial component, the judicious application of immunohistochemistry, which is very helpful. Now, recent studies have shown that this algorithmic approach has a superior diagnostic utility when it is applied in adjunct to the use of antibody cocktail consisting of low and high molecular weight cytokeratins, P63, especially on needle biopsy specimens. Limitation of the study is because we don't have a molecular beast presently. Maybe within 4 to 6 months we'll have that. The recent evolution of molecular techniques along with emerging outcome studies has led to the prognostic based reclassification of some of these entities. Additional studies focusing on the molecular signatures are needed to identify potential diagnostic tools, further stratify these lesions with respect to prognostic significance. Concluding my topic that there is scarcity of data and there is heterogeneity in these neoplasms, although definitive classifications of encapsulated papillary carcinomas and solid papillary carcinomas remain controversial and not universally accepted. These entities are generally regarded as variants of intraductal papillary carcinomas for staging and management purpose. So in addition to the difficulty of diagnosing these lesions, different terminologies have been proposed by disparate authorities and variable criteria have been suggested by the given entity. These are my references.
Thank you for the presentation. Very nice photos of FNAC and histology. I think papillary lesions will always remain a problem in breast lesions. So it's an age-old problem of diagnosing these, especially on FNAC and core. So what is the real understanding of your study? Well, do you think that you should be diagnosing papillary lesions on FNAC
First of all, FNAC definitely we cannot clearly diagnose. Histology is diagnostic. Secondly, even when we receive FNAC or we receive true cut biopsies, again it is very problematic. We need a mastectomy specimen to diagnose it, and proper IC markers are a necessity to diagnose it properly, because myopathial cells scarcity, sometimes it is present focally, sometimes it is absent, so it is very difficult, and new entities are coming up. So just to differentiate them, not with based on upon a single technique is very difficult. We need to have a collaborative diagnosis at the end.
Thank you. Thank you.
The next presentation, last presentation, FOP 20, risk stratification of thyroid fine needle aspiration biopsy specimens by application of the TB-SRTC 2023, a tertiary care experience.
The title of my topic is Risk Stratification of Thyroid Fine Needle Aspiration Biopsy Specimens by Application of TBS-RTC 2023, a tertiary care experience. Introduction: a pattern diagnostic method for thyroid nodule is fine needle aspiration cytology. It is a standardized, easy, and practical technique offering management suggestions. Aims and objectives are to study the spectrum and cytomorphology of thyroid lesions in a tertiary care center, reclassification of thyroid fine needle aspiration biopsy specimens by application of TBS-RTC 23, and calculation of risk of malignancy by taking the histopathological diagnosis. Inclusion criteria: all patients aged between 12 to 80 years of age who are visiting the OPD are taken. Exclusion criteria: those patients who are not having histopathology correlation are excluded from the study. Materials and methods: this is a cross-sectional retrospective study conducted over a period of 3.9 years. Thyroid FNAC cases were examined, reclassified, and risk of malignancy is estimated. The cases were correlated with available histopathology. These are the results. Total, we have 44 cases which are having histopathology correlation. The age group 41 to 50 years age group is more number of cases, 15 cases are there. And in 44 cases, 20 cases are category 2 cases. In category 2, the distribution of cases is like this: colloid goiter with cystic degeneration, colloid goiter, and adenomatous goiter are more in number. And this is the table showing the reclassification according to TBS-RTC 23. In this, we have reclassified 2 cases of FLUS, follicular lesion of undetermined significance, to atypia of undetermined significance with architectural atypia. 1 case of suspicious for follicular neoplasm to follicular neoplasm category 4, and follicular neoplasm category 4 to oncocytic follicular neoplasm. 1 case of atypia of undetermined significance is reclassified to atypia of undetermined significance nuclear atypia, and 1 case of lymphocytic thyroiditis with Hurthal cell change is reclassified to lymphocytic thyroiditis with oncocytic cell change. And this is the table showing the cytopathological diagnosis with the estimation of risk of malignancy by taking the histopathological correlation. In our study, total 44 cases are there, in which benign are 20, category 3 are 6, and category 4 are 8, and category 5 are 6, and category 6 are 9. For all these categories, we calculated risk of malignancy, which is comparable to the this is the risk of malignancy in our study, which is comparable to the standard values. And this is the overall table showing the cases. In category 1, there are no number of cases which undergone histopathology resection. And in benign, we have 3 discordant cases, in which 1 case widely invasive follicular carcinoma is reported as colloid goiter in FNAC, and invasive encapsulated follicular variant of PTC. 2 cases are reported as adenomatous goiter, and 1 case of microinvasive follicular carcinoma is reported as dominant nodule of MNG. And this is the continuation of the table. In category 3, 1 case of papillary carcinoma thyroid is reported as atypia of undetermined significance in FNAC. And in category 4, 1 case of infiltrative follicular subtype of PTC and 1 case of follicular variant of PTC are reported as follicular neoplasm. And in category 5 and 6, the cases are concordant only. And these are the results. We calculated sensitivity, specificity, positive predictive value, and negative predictive value. Our study showed a similar correlation with Gupta et al. Study. And in addition, we have calculated diagnostic accuracy, which is 85.71, and Cohen's kappa value, which shows the agreement, which showed the good agreement 0.7. And these are the few cases with concordant with discordant. This is the discordant case in which histopathology we have reported as a classic papillary microcarcinoma. High power shows the PTC features. We have reported it as ATP of undetermined significance in FNAC. This is the another case with discordant results. In this histopathology, we have reported it as a diffuse follicular variant of PTC. And in FNAC, we have reported it as a follicular neoplasm. And this is the another discordant case. In histopathology, we have reported it as invasive encapsulated follicular variant of PTC. But in FNAC, we have reported it as adenomatous goiter. And this is the another case which is reported as the minimally invasive follicular carcinoma in histopathology and dominant nodule of MNG in FNAC. And this is the case, concordant case. We have reported it as colloid goiter with adenomatous hyperplasia in histopathology and follicular neoplasm in FNAC. And this is the concordant case. We have reported it as oncocytic adenoma in histopathology by seeing more than 75% of oncocytic cells. In FNAC also, we have seen oncocytic cells, so more than 75%. So we have reported it as oncocytic follicular neoplasm. This is the another case of concordant case in which histopathology we have reported oncocytic follicular subtype of PTC. In FNAC, we have reported it as suspicious of PTC by seeing the papillary pattern and these calcifications and thyroid follicular cells. This is the table depicting the discordant cases overall. In category 2, there are 4 cases discordant, and in category 3, 1 case is discordant, and category 4, there are 2 cases discordant cases. And this is the table showing the non-neoplastic and neoplastic lesions, showing non-neoplastic lesions more when compared to the neoplastic lesions. And this is the table showing the incidence of Bethesda categories, showing the category Bethesda 2 and Bethesda 6 are more. And this is the table showing the malignancy rates, which are comparable to the other studies and TBS-RTC 23, standard TBS-RTC 23. And coming to the limitation, sample size is limited. We have 44 number of cases. All FNACs are not guided. In some FNAC cases, we have done from the lesion adjacent to the lesion. Conclusion, as a first line of diagnostic method, thyroid cytology has proven accurate, reliable, and affordable method. The Bethesda system for reporting thyroid FNAC showed good sensitivity, specificity, positive predictive value, negative predictive value, and diagnostic accuracy and Cohen's kappa value. Risk of malignancy is comparable to the TBS-RTC 23. These are my references. Thank you.
Nice presentation. Your study in category 2 have risk of malignancy 20% in compared to standardized method.
Risk of malignancy in category 2 is little bit more than the risk of malignancy which is calculated standard.
In other study, they have less risk of malignancy compared to your study.
One of the reason is all the FNACs are not ultrasound guided, sir. We have taken in some of the cases we have taken the FNAC sample adjacent to the lesion. Microcarcinoma is there. In one case, we have taken adjacent area.
Okay. You have compared the Bethesda 18 with 23. That's one of your objectives, no? So you've reclassified your old reports according to Bethesda, and you found very little differences. Actually, there are only 4, 5. Very little. There are only 3, 4 cases, I think.
Yes, sir.
So do you think you should have continued with Bethesda 18 only because things are getting more and more confusing in here? Although FNAC remains the current gold standard of sort of managing these FN masses. So I could make out that your 18, 23, pretty much similar. The results are similar in that case.
The confusion, some of the terminology is removed from the TBS-RTC 23.
Thank you, judges, for judging the paper presentation under faculty category. I now request Dr. Jyotsna, HOD Pathology, to felicitate the judges.
Okay. Don't worry. You get. Absolutely, photo.
Thank you, judges. We are very thankful for your time. Next, we move on to the oral paper presentation for the postgraduate category. Now, we request judges of oral presentation category of postgraduates to join us on the dais. We request judges of oral paper presentation of postgraduate category to join us on the dais.
We'll start with the oral presentations under postgraduate category. I now call upon the first presenter, PGOP1. The title is The Good, the Bad, and the Ugly Extranodal Lymphomas, a 7-year study at a tertiary care hospital, 2017 to 2023.
The Good, the Bad, and the Ugly Extranodal Lymphomas, a 6-year study at a tertiary hospital from 2017 to 2023. Overview consists of objectives, introduction, materials and methods, results, discussion, conclusion, and references. Coming to objectives, to enumerate different types of extranodal lymphomas at different locations, to explore the clinicopathological variables, and to determine the prognosis. To introduce, non-Hodgkin lymphomas are a heterogeneous group of lymphoproliferative malignancies. A substantial percentage of NHL arise from tissues other than lymph nodes and even from sites which normally contain no lymphoid tissue. 1/4 of all lymphomas are probably of extranodal origin. Lymphomas arising primarily in extranodal sites can be diagnostically challenging due to their morphological differences and lack of uniformity in histopathological classification system. Extranodal NHLs have been reported to originate from almost every anatomical site of the body, such as GIT most common, followed by other sites. Coming to materials and methods, our study included 22 cases of biopsies and dissected specimens of extranodal lymphomas from various specialties at tertiary hospital. Cases were collected from year January 2017 to October 2023. Data was collected through medical records from various specialties as well as with patient directly. Paraffin embedded H&E stained tissue sections were analyzed by a group of histopathologists to reach at a morphological diagnosis. IHC were performed for all cases using a panel of monoclonal antibodies. Coming to results, out of 22 cases, 7 cases occurred in the CNS majority, followed by other sites, 1 case each seen in breast, lung, and testis. Males were most commonly affected in my study. Most of the cases were immunocompetent. This is the table showing extranodal site, number of cases, age, sex, HIV status associated with any autoimmune diseases and cell of origin. In my study, majority of the cases originated from CNS, and the most of the patients were in between 60 to 75 years majority, and most of the patients were male. And out of 22 cases, 2 cases were HIV positive, and 1 case associated with Hashimoto thyroiditis. Most of the cases are B cell origin, except 2 cases T cell origin. This is the picture showing anatomical distribution. Majority of the cases are from CNS. This is the picture showing sex distribution. Most of the cases were males. This is the picture showing immune status of cases. Most of the cases are immunocompetent. 2 cases were HIV positive. This is the picture showing cell of origin. Majority cases were B cell origin. This is the picture showing based on prognosis, out of 22 cases, 16 cases were of high grade, 2 cases were of intermediate grade, and 4 cases are low grade. This is the picture showing table showing histopathology and its prognosis. Out of 22 cases, majority of the cases were diagnosed as DLBCL, and 4 cases are diagnosed as maltoma, 2 cases are diagnosed as primary cutaneous lymphoma, and 1 case diagnosed as Burkitt lymphoma. This is the table showing application of International Prognostic Index for 22 cases, and most of the cases, that is 10 cases, showed high intermediate risk scoring, and other cases showed a low risk scored. This is the table showing follow-up of cases. Out of 22 cases, 11 cases were in follow-up, and 11 cases lost their lives. Coming to cases, first CNS lymphoma, the CT image shows a contrast. Under microscopy, the tumor arranged in diffuse sheets, and it shows the CD20 positivity. And this is the case of thyroid lymphoma in a 17-year-old girl. Microscopy shows a colonization of follicles by neoplastic lymphoid cells and malt balls. And the gross image shows characteristic fish flesh appearance. And the IHC shows CD20 and CK positive, BCL6 and CD10 negative. And this is a case of Burkitt lymphoma in a 42-year female, known case of HIV positive, presented with bilateral massive pleural effusion. And the smear shows tumor arranged cells with pleomorphic nuclei and cytoplasmic vacuolations. And this is a case of primary cutaneous T-cell lymphoma. And Dowmish shows tumor arranged around periadnexal structures, and IHC shows CD20 negative. This is a case of testicular lymphoma. It shows as a remnant of seminiferous tubules surrounded by mononuclear cells. This is a case of lung lymphoma, tumor arranged in diffuse sheets. This is a case of GIT lymphoma showing CD20 positive. Coming to discussion, ENL is a heterogeneous disease in regard to geographical, ethnic, anatomic, etiological, and morphological diversities. In this study, majority of the cases were males compared to females. Few of the patients show B symptoms. As maltoma patients' prognosis expected to be good, in this study, 1 patient diagnosed as ileal maltoma died on 15th POD due to post-surgical complications. DLBCL accounted for the largest proportion of ENLs. This is a table showing comparison between present study with published series. According to Somnath Padi et al. And present study, CNS forming the major here, and DLBCL is the most common histopathological diagnosis. According to Chen et al. And Lal et al., GIT is the most common site. In conclusion, lymphomas can have various extranodal presentations. DLBCL is the most common subtype in this study, followed by March lymphoma, while CD20 IHC marker is significant in all cases. Patients with aggressive type of lymphomas, DLBCL and Burkitt-like lymphoma shows poor prognosis. Cutaneous primary T-cell lymphoma shows intermediate prognosis, and Malt lymphomas are doing well, except 1 patient died due to unknown reasons. These are my references. Thank you.
What were the common differentials which you had? You did not discuss about the differential. Any case you found difficult to diagnose?
DLBCL,
Yeah.
diffuse large B-cell lymphomas.
What were the differentials, or how did you exclude? You have done ISC also.
Yes, sir.
So was it straight NHL you had the diagnosis, then you went on to subcategorize the NHL?
Yes, sir.
Okay.
It was good presentation.
Thank you.
Title is catchy. What made to title this name?
To differentiate based on prognosis, ma'am. Maltomas do well. Compared to DLBCLs, ma'am. Those are aggressive.
Thank you.
Thank you, ma'am.
The next presentation by abstract number PGOP2, an innocent face can mask an ugly nature, grading of Pitnet.
Good morning, everyone. That my title of my study is "An Innocent Face Can Mask an Ugly Nature" in grading of Pitnet. Introduction: pituitary neuroendocrine tumors, that is Pitnet, constitute about 10% of all the CNS tumor. According to old classification, these are clinically classified into functional and non-functional based on apparent clinical hormone production that are clinically. So pituitary angiomas, which were recently renamed as pituitary neuroendocrine tumors, Pitnet, according to recent WHO classification, because although they are mostly benign, these adenomas will present invasive, aggressive, and metastatic behaviors. So objectives of my study include to explore the clinicopathological variables of Pitnet, that is age and sex, to classify the Pitnet based on the clinical data available, and to grade the Pitnet using the Ka67 proliferation marker labeling index. Coming to materials and methods, this is a 5-year retrospective study done at a tertiary hospital, and our study included cases of pituitary tumors that were sent from neurosurgery department for histopathological examination. Cases were collected from July 2018 to June 2023, and all other relevant clinical data and hormonal data of all the cases was collected from the medical records. So paraffin-embedded HNG stain tissue sections of all the cases were analyzed, followed by the immunohistochemical analysis for the Ka67 was done. So Ka67 labeling index was calculated for all the cases of Pitnet using manual counting method. So statistical analysis was done and variables are represented as frequency and percentage. So coming to results, our study included total number of 34 cases which were diagnosed as Pitnet initially on HNG. So most of the cases were in the age group of 40 to 60 years, except one case in a 6-year-old girl, which was represented in figure 1. And males were most commonly affected, represented in figure 2. Figure 1 showing age group distribution with most common age group of 40 to 60 years. Figure 2 showing sex distribution with males more common than females, with males 20 number in case and females is 14 in number. So again, based on clinical data available, pituitary tumors were divided into functional and non-functional tumors. Functional tumors include 28 cases, and they are further divided into following functional tumors, which include corticotrophs, lactotrophs, thyrotrophs, gonadotrophs, and somatotroph. And in my study, for corticotrophs are more in number with 14 cases. Somatotroph, it is seen in a 1-year, 6-year-old girl. So table 2 showing sex-wise distribution of functional and non-functional tumors. So out of 28 cases of functional tumors, 15 were males and 13 were females. And out of 6 cases of non-functional tumors, 5 were males and 1 case was female. So table 3 showing age group distribution of functional and non-functional tumors, where functional tumors were mostly in the age group of 40 to 60 years, and non-functional tumors were in the age group of 40 to 70 years of age. So following immunohistochemistry for Ka67 and counting Ka67 labeling index, total cases were divided into 2 groups, which was represented in figure 3. So in this study, mainly about 29.4% of total cases, which were appearing as initially benign on histology sections, were with high Ka67 index. So this is the figure 3 showing grading of Pitnet, where total cases were divided into 2 groups, group 1 and group 2. Group 1 include 24 cases with low Ka67 index that were graded as low grade, and group 2 include 10 cases with high Ka67 index that were graded as high grade. So table 4 includes distribution of functional and non-functional tumors based on Ka67 index. So out of 24 cases of low Ka67, 19 were functional and 5 were non-functional. And out of 10 cases with high Ka67, 9 were functional and 1 case was non-functional. So coming to histopathological examination of one of the case of my study of Pitnet, where low power shows tumor tissue arranged in solid sheets, nuts and pseudorosette pattern. High power shows monotonous population of cells with moderate amount of cytoplasm and stipple chromatin. And this is the immunohistochemical expression for Ka67 case of the same case, where each field shows positive cells in the range of 0 to 1. So the overall calculating Ka67 index will be less than 3%. And this is the picture showing P53 expression, where the positive cells are in the range of 0 to 1. So the overall calculated positive cells will be less than 10 per 10 high power field. And this is another case where the histopathological examination shows tumor tissue arranged in solid seas, and high power shows monotonous population of cells, and occasional foci showing a samoma body. And this is the immunohistochemical expression for Ka67 of the previous case, where each field is showing more than each field showing positive cells in the range of 10 to 15. So the overall calculating index will be greater than 3%. And this is the picture showing immunohistochemical expression of P53, where the positive cells are in the range of 10 to 20 per high power field. So the resultant positive cells will be greater than 10 per 10 power high power fields. So coming to discussion, pigments are generally benign on HND, but few tumors can behave aggressively. So aggressiveness of the tumor is determined either by the presence of at least two of the following three markers. That is mitotic count greater than 2 per 2 millimeter square, or Ka67 index greater than or equal to 3%, and P53 detection that is greater than 10 strongly positive nuclei per 10 high power fields. So in this study, Ka67 proliferation marker labeling index is used to know the aggressiveness of the tumor along with the P53 positivity. So this index is generally high in functional tumors than in non-functional tumors. As already discussed, out of 10 cases of high-grade tumors, 9 cases were found to be functional tumors. So according to a study conducted by Astroli et al., out of 68 cases conducted in a period of 5 years, 32.4% of cases were with high Ka6 index and have worse prognosis. In our study, 34 cases, that 29.4 cases were with high index and have worse prognosis. So tumors with high Ka6 index are quickly after initial treatment, difficult to manage and have poor prognosis. Furthermore, a high Ki index may prompt a closer follow-up early radiation therapy. So coming to conclusion, our study summarizes that pigments which are initially diagnosed on HNE need to be graded by using the proliferation marker, preferably Ka67, as the ugly nature of the tumor can be masked by a benign histology. So grading of pigment will also provide better follow-up of the patient and early treatment. These are my references. Thank you.
That is a good study. You told the aggressiveness depends upon three factors: mitotic figures, K67 and P53. In your study, you have shown data about K67 and P53. What about mitotic figures?
I only took two parameters, sir. Mitotic count was less than in histopathological examination. Mitotic count was less than 2 only, sir. So I excluded that criteria and only took 2 criteria, sir.
Even in aggressive cases also,
Yeah,
it
yes,
was less
sir.
than 2.
Yes, sir.
Okay.
Picture quality is very good.
Thank you.
Do you face any diagnostic challenges?
Yes, ma'am. All of the cases which were diagnosed as benign only, ma'am. So based on only mitotic count, we can't decide whether it is high yet or no. So we proceeded with IHC. So, thank you.
The next presentation, PGOP3, clinicopathological parameters and significance of human epidermal growth factor 2 receptor expression in gastrointestinal malignancies, a tertiary care center study.
A very good morning, everyone. Title of my study is Clinicopathological Parameters and Significance of Human Epidermal Growth Factor 2 Receptor Expression in Gastrointestinal Malignancies, a Tertiary Care Center Study. Introduction: Gastrointestinal carcinoma is one of the leading causes of cancer-related deaths worldwide, especially in gastric and colorectal carcinomas. HER2 is an oncogene which is located on chromosome 17q21. It is a member of tyrosine receptor kinase family. Activation of HER2 leads to initiation of signaling pathways essential for cell proliferation and differentiation. Overexpression of HER2 has been reported in many epithelial malignancies, including cancers of breast, lung, prostate, bladder, etc. The role of HER2-directed therapy and its success in breast cancer patient has led to evaluation of protein overexpression, gene amplification, and anti-tumor activity of Herceptin or trastuzumab in multiple tumor sites, types including colorectal and gastric adenocarcinomas. Aims and objectives include to study the clinicopathological parameters in various GI malignancies, to score the expression of HER2 in various gastrointestinal cancers, and to determine the association between various clinicopathological parameters like age, sex, tumor grade, stage, lymph node metastasis, and HER2 expression. Methodology: after obtaining approval from the Institute Ethics Committee, a cross-sectional study was carried out in our department. All biopsy-proven gastrointestinal adenocarcinomas for a period of 18 months were collected. Histopathological grading and immunohistochemistry for HER2 expression were carried out on all biopsy-proven gastrointestinal adenocarcinomas. IHC was done using primary antibody HER2 clone SP3, secondary antibody, and positive control was HER2 positive breast carcinoma. So the scoring is given according to this: 0 and 1 plus were negative, 2 plus were equivocal, and 3 plus is positive. Inclusion and exclusion criteria include all GI malignancies which are diagnosed as adenocarcinomas in histopathology were included. Exclusion criteria is inadequate biopsies and autolyzed specimens and histological grade other than adenocarcinomas were excluded. So this pie chart and the bar graph showing the distribution of various GI malignancies based on the site. Upper GI accounts about 40% of the cases, lower GI about 60% of the cases. Based on the specimen type, we have about 60% of biopsies and 40% are resected specimens. This table showing the age-wise distribution of the cases. Around 13 cases, that is 52%, were in the age group of around 51 to 70 years. Next, coming to the gender-wise distribution of the cases, around 18 cases, that is 72%, were in males. This table showing the association between tumor grade and HER2 expression. Out of the total 25 cases which we have taken in this study, 5 were in the well-differentiated category and 1 is in the poorly differentiated category, which is showing statistical significance. The same in the bar chart representation. So here we see the diagram showing the HER2 3+, which is a strong membranous staining in more than 10% of the tumor cells. This is a higher magnification view. Next is HER2 equivocal, which is a moderate staining in more than 10% of the tumor cells. This is a higher magnification view. Next is HER2 negative, which is no membranous staining. Coming to discussion, in our index study, we have around 51 to 70 years, which were seen in the most common age group, and gender is mostly we have seen males. Out of the total 25 cases, 6 were positive in our study, which is in coordinates with other studies. In our study, we have most of the cases, that is 5 cases in the well-differentiated category, which is in coordinates with other et al. Like Suchitra et al. And Madani et al. While Fazan et al. Showed most of the HER2 positive cases in moderately differentiated category, but still tumor grade is significant in all the studies. Tumor stage and lymph node metastasis, they showed no significance in our studies, which is also seen in other studies. So coming to conclusion, most of the gastrointestinal cancers in our study are in the elderly males with advanced cancer. There was a significant association between tumor grade and HER2 positivity. The clinicopathological parameters like age, gender, stage, and lymph nodal metastasis showed no significance in our study. In these patients, surgery alone is not curative and other forms of therapy may be required to prolong the patient's survival. Since HER2 positivity is associated with poor prognosis, these patients may be a potential subjects for targeted therapy against HER2 receptors like trastuzumab. So the limitations of my study are small sample size, single center study, inter-observer variation, no further evaluation of equivocal cases by FISH. Thank you.
So one limitation I find in your study is you're not subjected to FISH. The 2+ score 2+ should be subjected to FISH to clarify. Another thing is, do you, this trastuzumab is being given in your institute? The anti-HER2 therapy, is it being given?
Yes, actually we have one case, sir, which showed metastasis, sir. Out of all the cases, we have one case which is in stage 4, sir. So in that we have started trastuzumab therapy, so we are in coordinates with medical oncologist, ma'am, sir. So one case we have started trastuzumab therapy. We are in follow-up with that case.
Okay, so they didn't insist on fish for 2+ cases.
So
The medical oncologist didn't insist for fish for 2+ cases.
yes, sir, they have insisted. Few we have sent for fish, sir.
Okay.
Actually, I also supposed to ask the same question. So it is good tumor marker study.
Yes, ma'am.
So my opinion also, why you have not done fish?
Yes. So most
Any few cases have you done for the further confirmation? Like
yes, ma'am. We have sent, ma'am, few cases we have sent which we have diagnosed as equivocal. We have sent them for fish, ma'am. So the results are yet awaited. But for one case, we have started on trastuzumab therapy, ma'am, which is diffuse positive or 3+. We have started on trastuzumab therapy.
Next presentation, PGOP4, histopathological study of urinary bladder tumors with immunohistochemical expression of Ki67 marker.
Good morning, everyone. My study is on histopathological study of urinary bladder tumors with immunohistochemical expression of Ki67 marker. Coming to introduction, urinary bladder cancer is the 10th most common cancer worldwide. Bladder cancers are more common in industrial areas, and the incidence is increased with exposure to cigarette smoking and array mines. Array mines are usually used in leather industries and painting industries. So people working there should be cautious. Urothelial neoplasms can be classified as benign and malignant tumors. Malignant tumors are further classified as non-invasive and invasive tumors. The recent classification of urothelial tumors can be subdivided into urothelial papilloma, papillary urothelial neoplasm of low malignant potential, non-invasive papillary urothelial carcinoma of low grade and high grade, and infiltrating urothelial carcinoma. Non-invasive urothelial neoplasm accounts for major proportion of all bladder tumors. Ki67, a cell cycle-related nuclear protein, is expressed by proliferating cells. Ki67 is increased in high-grade carcinoma with or without muscle invasion. Rate of recurrence, aggressiveness, and progression can be indicated by tumor cell proliferation. Aim and objectives of my study is to study the histopathological spectrum of urinary bladder lesions and to determine the expression of cell proliferative marker Ki67 and its association with histopathological features. A cross-sectional analytical study was conducted at a tertiary case center. All histopathologically confined cases of urothelial neoplasm diagnosed from September 2021 to September 2023 were included. All histopathologically proven transurethral resection of urinary bladder tumors, cystoscopy biopsies, and excisional biopsies received in Department of Pathology were included. Excluded when specimen not received in formalin and inadequate specimens. Coming to methodology, formalin-fixed paraffin embedded tissues were taken and sectioned by using microtome with 4 microns as thickness. Immunohistochemistry was performed using BioCare declocking chamber with heat-induced epitope retrieval. Ki67 immunohistochemistry done with Ki67 antibody, which is sp6 clone, followed by secondary antibody, and lastly DAB chromogen added and counterstrained with hematoxylin. Ki67 expression and Ki67 labeling index were calculated. High immunoreactive areas were chosen and examined under high power magnification, counting a mean of 1,000 tumor cells per case. Ki67 labeling index is expressed as the percentage of positive nuclei per 1,000 tumor cells. It is followed by stratification into low versus high expression, that is less than 13% and more than 13%. Coming to results, out of 20 cases, 45% of cases are non-invasive urothelial neoplasms and 55% are invasive urothelial neoplasms, out of which 40% showed more than 13% of Ki67 expression. This pie chart shows distribution of cases. This slide shows age-wise distribution of cases, out of which 45% showed less than 65 years of age and 55% of cases are more than 65 years of age. This slide shows distribution of cases based on gender. Out of 20 cases, 70% of cases are males and 30% of cases are females. This showed significance. This image shows 10x view with Ki67 expression more than 13%. This image of 40x shows Ki67 expression of more than 13%. This image of 4X shows K67 expression more than 13%. This image of 10X shows Ka67 expression less than 13%. This image of 10X shows negative Ka67 expression. Coming to discussion, the urothelial neoplasm was more in males and in higher age greater than 65 years. A comparable result of gender distribution in urothelial neoplasm was attained in a study by Thakur et al. And age distribution was found in the results of other studies by Gupta et al. And Viswas et al. A high and low Ka67 labeling index was correlated in urothelial tumors and its histopathological parameters. This study shows maximum high Ka67 expression in invasive cancers, that is 40%, whereas low was seen maximum in non-invasive cancers, that is 19%. These results were correlated with study done by Kaur or et al. This table shows conclusion with other studies. Coming to conclusion, Ka67 expression is used as a prognostic marker in urothelial tumors. Thus, Ka67 expression is associated with features of aggressiveness and used to identify patients who are at risk for disease progression and may benefit from adjuvant therapies. Thank you.
So that was a good presentation. What is your correlation with mitotic figures, Ka61 with mitotic figures?
Mitotic figures are increased in invasive cancers more compared with non-invasive, that is like papilloma, and in that it is very low, sir. But in invasive and non-invasive also, low grade and high grade shows high mitotic index.
What I'm asking is comparison of mitotic with Ki67.
Usually it will be equal, but mitotic activity we may miss through. We may miss. That's why Ka67 expression is done.
Okay. Thank you.
Thank you.
Parallelly, you have done any other tumor marker study?
No, ma'am.
For further confirmation?
No.
Not done. Okay.
Thank you.
The next presentation is titled Pancreatic Carcinoma Associated Chronic Pancreatitis, an observational study of 6 years. PGOP6.
Introduction: pancreatic cancer is biologically aggressive tumor from the time of onset, clinically quiescent for a long time, and hence present in the advanced stages. Pancreatic cancer is caused by damage to the DNA, and this damage leads to abnormal and uncontrolled growth of cells in the pancreas. Chronic pancreatitis is a chronic inflammatory disease involving fibrosis and loss of acinar and islet cells. The incidence of pancreatic cancers in chronic pancreatitis is increasing. Carcinogenesis in chronic pancreatitis is likely multifactorial phenomenon. And my objectives of this study is to identify the number of cases showing chronic pancreatitis and pancreatic carcinoma in Whipple specimen, and to know the association of chronic pancreatitis with pancreatic carcinoma. Materials and method: this is a 6-year observational study done at Tertiary Hospital, and the Whipple specimen sent by Surgical Gastroenterology Department for histopathological examination were included in this study, and the cases were collected from January 2017 to August 2023. The clinical history and the results of the relevant investigations done was collected from the patient case files, and paraffin-embedded hematoxin and eosin stained tissue sections of all the cases were analyzed. Statistical analysis was done, and variables are represented as frequency and percentage. Our study includes 28 cases of Whipple specimen from Surgical Gastroenterology Department, and most of the cases were in the age group of 50 to 70 years, except 3 cases which are in the age group of 20 to 40 years, and females are most predominantly affected. In this figure, it is shown that predominant age group was 50 to 70 years, and the 3 cases are below
40 years and one case is above 70 years. And in this figure, we have shown that females are predominantly affected. Results. This study has 28 cases of Whipple specimen and all the cases are diagnosed with pancreatic carcinoma. In 28 cases of pancreatic carcinoma, 64% of the cases, that is 18 cases, are showing chronic pancreatic features, and in 10 cases, chronic pancreatic features are absent. And types of pancreatic carcinoma with showing chronic pancreatic features. Pancreatic ductal adenocarcinoma was 24 cases. In these 24 cases, 17 cases are showing chronic pancreatic features. Cystic ductal carcinoma case was 1 and no pancreatic features are observed. Neuroendocrine tumor was 2 and features of chronic pancreatic features are absent, and mucinous adenoma carcinoma was 1 and chronic pancreatic features are present in this case. Picture showing pancreatic ductal adenocarcinoma with chronic pancreatitis showing fibrosis and also inflammatory cells, and pancreatic ductal adenocarcinoma with dense inflammatory infiltrates and loss of acinar cells and fibrosis. And this picture shows tumor purple with panning changes and focal pancreatic changes, and pancreatic ductal carcinoma with dilated ducts and with chronic pancreatic features showing dilated ducts and focal inflammatory infiltrates. And this picture shows neuroendocrine tumor, as we discussed in these tumor cells arranged in sheets and cords, and chronic pancreatic features are absent. Discussion. Most of the pancreatic cancers are seen in elderly patients. It can occur in younger patients also who are less than 40 years. In this study, we have seen 3 cases. Chronic pancreatitis is progressively inflammatory disease with irreversibly functional and morphological changes. When there is a chronic inflammation, inflammatory cells secrete toxins and growth factors. Accumulation of these toxins will cause DNA damage. This DNA damage finally progresses into oncogenic mutation, resulting in a malignant transformation. According to study conducted by Kirk et al., there is a relative risk of evolution of chronic pancreatitis to pancreatic carcinoma. And according to study conducted by Jenna George study et al., female gender and an advanced age has more association of pancreatic carcinoma with chronic pancreatitis, and this has correlated in this study with female predominance and the age group above 50 years. Conclusion. Since inflammation is one of the major risk factors for carcinogenesis, it was quite logical to hypothesize that chronic pancreatitis was more susceptible to pancreatic cancers. And in our study, it has observed that there is an association of pancreatic carcinoma with chronic pancreatitis. These are my references. Thank you.
So did you find any other risk factor apart from chronic pancreatitis in your study?
Elevation of CA-125.
That is a tumor marker, I suppose. No, I was asking about any other risk factors, like chronic pancreatitis is one. Diabetes. So how many cases were diabetes?
Sir?
How many cases had diabetes?
More than 50% of the cases, they have diabetes.
But in general, also diabetes is a quite common disease. So will you associate it as a risk factor for pancreatic carcinoma?
In this study?
Yeah. Okay.
So, sir asked about diabetic patients. See, how many cases you have seen chronic pancreatitis patients developed diabetes? You have any data?
We have seen 13 cases with chronic pancreatitis and diabetes.
No, after getting pancreatitis, patient developed diabetes, or from the beginning they are having?
From the beginning, they are having diabetes.
Okay. Okay.
The next presentation is PGOP8, neuroendocrine differentiation in prostatic adenocarcinoma and urothelial carcinoma, transdifferentiation leading to aggressive behavior, a single institutional experience. PGOP8. Presenter is not there. I'll call upon the next presenter, PGOP11, a cytological study of mass lesions of lung in correlation with trust pathology and immunohistochemistry. Good morning. The title of my study is a cytological study of mass lesions of lung in correlation with histopathology and immunohistochemistry. Coming to introduction, neoplastic and non-neoplastic pulmonary lesions account for majority of mortality and morbidity worldwide. The lung carcinoma is a leading cause of cancer-related death all over the world, despite the advances in treatment, for which a histological or cytological confirmation is essential, and the categorization of malignancy is required before treatment. So fine needle aspiration cytology and small biopsies are the first step diagnostic modalities. Cytological smears form important tools for lung cancer diagnosis, and early diagnosis helps in the better management of the patient because of availability of targeted therapy. So aims and objectives of our study is to evaluate the efficacy of cytology in comparison with biopsy, and to compare and correlate the cytological diagnosis with corresponding histological diagnosis, and to assess the role of IHC in the diagnosis of lung masses. Materials and methods. This study was conducted for a period of 19 months in the Department of Pathology with a sample size of 40, and it's a prospective observational study. And the patients with CT diagnosed lung masses and clinically symptomatic patients were included, and chronic debilitating illness and patients with bleeding diathesis were excluded. And the materials obtained were using the cytological techniques we used are endobronchial ultrasound guided FNACs, bronchial washings, bronchial brushings, and bronchoalveolar lavage. The obtained material was smeared, fixed, and stained with HND, PAP, and MGG for cytology. And the biopsies obtained are through endobronchial biopsies and transthoracic biopsies. Biopsy slides were stained with HND, and the ancillary techniques we used were IHC and molecular studies. Coming to the result analysis, in our study, males are commonly affected when compared with females, accounting for about 72.5%. And the age group were mostly affected were 51 to 60 years, followed by 61 to 70. And the extremes of age group are less commonly affected. And the categories on cytology where we gave was 60% was malignancies, 27% were acute inflammatory pathologies, and 13% were granulomatous conditions. And the categories in cases with histopathological correlation was 22 cases were true positive and 16 true negative, 1 false positive and 1 false negative. So this graph depicts the distribution of sex in different histopathological findings. So overall, adenocarcinoma is the most common lung mass. Metastatic deposits were mostly found in women, and squamous cell carcinoma in males. And 31% of male patients have showed adenocarcinoma in our study. And this is a distribution of diagnosis of different types of lung masses in cytology and histopathology. Both adeno and squamous carcinomas are categorized differently on cyto and histo, while non-small cell, which was falsely diagnosed on cyto, required histo for confirmation, and metastatic deposits diagnosed on cytology also required histological categorization and clinical correlation. The correlation between cytology and histology revealed an intra-class correlation coefficient of 0.83, indicating the inter-rater reliability between the two procedures is good, and the p-value less than 0.009 indicated that it is statistically significant. The sensitivity and specificity in our study for cytological diagnosis 95.6 and 94.1 respectively. When compared with the other studies done by JSJ et al., Ahmad et al., Razia D et al., Mullan C et al., our study sensitivity was correlated with Mullan CP et al. And specificity with Razia et al. Closely. Our study showed better sensitivity and specificity because of rapid on-site evaluation of the procedures and checking for the cellularity and procedural accuracies. So these are the images showing the granulomatous lesions. Here, cytology, you can see the collection of epithelioid cells and inflammatory cells and well-formed granulomas, and AFB staining showing the first bacilli and corresponding histological images with granulomas and Jane cells. This is squamous cell carcinoma showing prominent intercellular bridges, and PAP staining showing nuclear architecture, and the corresponding biopsy images showing tumor cells with the keratinization. And this is a signet ring cell type of adenocarcinoma with eccentrically placed nucleus and clusters of cells and vacuoles, and corresponding histology images. And this is a colloid type of adenocarcinoma with abundant amount of colloid in the background and corresponding histology image. And this is a mucinous type of adenocarcinoma. And this is Eisner type of adenocarcinoma with irregular arrangement of the glands. And this non-small cell carcinoma, which was poorly differentiated. So we followed up with IHC with TTF
and P40, which showed TTF1 positivity favoring adenocarcinoma, and the small cell carcinoma showing tumor cells was followed with IHC using TTF1, synaptophysin positive, chromogranin, and CD56 positive, showing neuroendocrine tumor. And 2 cases were followed up for molecular studies, which showed EML4 ALK fusion and TP53, and others showed EGFR mutations, which helped in targeted therapy. So coming to a discussion, in our study, most common primary was adenocarcinoma, followed by squamous cell carcinoma. Mets of squamous cell carcinoma are common in male, while in adeno it's female. And immunohistochemistry was done only in few cases, and for in few cases, molecular study was done. Mostly morphology was helpful in giving the diagnosis. And conclusion, present WHO classification emphasizes the importance of small biopsies and cytology specimens for early detection. The study proves that cytology and biopsies are helpful in diagnosing lung lesions with high sensitivity and specificity, which helps the clinician for planning the treatment early because of availability of targeted therapy. So these are my references, and thank you.
That was a good study. Have you done cell block in your studies?
Only few cases were done, sir.
So was it helpful?
Yes, sir.
So that you could have put that data there. Another thing is, you didn't tell anything about the discordant cases. How many were discordant and what were the reasons when you went back and saw the slides?
Yes. Only one case we were unable to give the diagnosis on histopathology because of an tissue unavailability. Proper tumor tissue was not taken out, only fragments of tissue were taken, sir.
No, I'm asking about cytohistocorrelation. What were the discordant cases?
Only one case only on histo we couldn't get, sir.
No, on cyto you got something, and on
cyto
biopsy you got something else.
Yes, sir.
How many were such
One
cases?
case.
Only one case. What was that case?
On it was a small cell carcinoma, sir. We gave on cyto, but histo, the biopsy was not from the lesion itself, so we got only fragments of tissue.
So you could not diagnose on biopsy.
Yes.
Remaining all cases, cyto and histo were same.
Yes, sir.
Very good. That is excellent results.
That's because of rapid onset evaluation we did, and we checked the cellularity, and we called the pulmonologist and asked for repeating the procedure.
Okay, but that is fine. But even only cellularity is not an issue. Even if you have cellular smear, sometimes we face problems in diagnosing, and then the biopsy comes something different. That's good that you got all 100% cases right. Thank you.
Slide picture quality cytology, especially it is very good. And thank you.
Thank you.
The next presentation is PGOP12, evaluating the efficacy of imprint cytology in diagnosing thyroid neoplasms.
Good morning, everyone. So my topic for today is evaluating the efficacy of imprint cytology in diagnosing thyroid neoplasms. So thyroid nodules are very common, but while thyroid cancer is a rare condition, thyroid nodules range from 4% by palpation to 67% by ultrasonography. But thyroid cancers account for only less than 1% of all these malignancies. Since only malignant nodules or large symptomatic nodules need surgery, so a systemic approach is necessary to avoid erroneous surgical treatments. And to avoid these unnecessary surgical treatment, usually intraoperative frozen section is performed. But imprint cytology can also be used as an alternative to frozen because imprint is more cost-effective, simple, rapid, and an easy diagnostic modality for quick intraop decision-making. So in this present study was undertaken to determine sensitivity, specificity, and diagnostic accuracy of imprint cytology. And the aims and objective was to study the age, sex profile in the spectrum of various thyroid lesions and to assess the efficacy of imprint cytology by comparing it with frozen section and histopathological diagnosis. It was a retrospective study conducted over a period of 18 months on all the patients who underwent thyroidectomy in my institution with a sample size of 42. After surgical removal, the fresh thyroidectomy specimen was thoroughly inspected, clean, and
we obtained a imprint smear by a touch and withdraw movement. This was followed by fixation by 95% isopropyl alcohol and a rapid H&E stain. These smears cytodiagnosis was offered, and later the normal, these specimens were fixed in formalin and embedded in paraffin for a conventional histopathological diagnosis. Both cytodiagnosis and histopath diagnosis were correlated, and they were classified based on the new WHO 2022 classification. Based on that classification, we have categorized into benign, low risk, and malignant neoplasms. So the results of my study were that most of the cases, they range from 20 to 69 years, with mean age being 40 to 1.9 years. And majority of the patients were female, with male to female ratio of 1:13. Benign cases on imprint, frozen, and histopathology, 30 cases were of thyroid follicular nodular disease, 4 of follicular adenoma. On imprint and frozen, we got 2 cases which were low risk. The malignant cases on imprint and frozen were 6, but on histopathology, we got 8 cases. So discordance rate in my study was 2. The imprint cytology in this study had a sensitivity of 75%, specificity of 100%, with positive predictive value of 100%, negative predictive value of 94.44%, and accuracy of 95.24%. This is the first case showing papillary thyroid carcinoma, gross and imprint smear showing papilloid pattern. The first picture is the frozen section showing papillary structure, and in third picture, the histopathological confirmation showing all the nuclear features of papillary thyroid carcinoma. This case is of benign thyroid follicular nodular disease. The gross specimen and imprint was done showing benign thyroid follicular cells. On frozen and histopathology, we had benign thyroid follicles with lymphocytic infiltration is seen here. This is the third case which showed discordance. On imprint smears, the cells were showed mild and isonucleosis. On frozen section also, mild and isonucleosis with some papillary-like nuclear features were there. So we gave it as low-risk neoplasm. But on histopathology later on, it was diagnosed as a proper papillary thyroid carcinoma with all the nuclear features, a follicular variant. So my study on correlation comparable with the other studies, this has an age distribution of 20 to 69 years and male to female ratio of 1:13 in comparison with other studies. Benign lesions 81% and malignant also 14.3%, which is comparable to other studies which were already done. Sensitivity, specificity, positive predictive value, negative predictive value, everything was in comparison with the other studies which were done earlier, and diagnostic accuracy also in comparison with Anjali PV et al. So imprint cytology, in conclusion, I would like to say that imprint cytology is a simple, reliable, and cost-effective diagnostic technique. It can be a useful guide in making intraoperative therapeutic decisions quickly, and imprint cytology could prove to be an invaluable alternative for intraoperative diagnosis of thyroid lesions in the centers with lack of frozen. These are my references. Thank you.
That's a very excellent study. I think for resource poor centers, it will be definitely very helpful. So what problems you encountered in interpretation or any in stains, which stains you have done?
The rapid H&E we have done for imprint smears, sir. We didn't have any problem like that, but only 2 cases which showed discordance, but they showed discordance on frozen also. So even if we
the nuclear features you told.
Yes, sir, nuclear features.
So did you find it on the frozen section?
No, sir. On frozen also we had given low risk only, sir. On histopathology, we finally gave it as papillary thyroid carcinoma. So on comparison with frozen, it's an excellent study. So we missed it on frozen also. So imprint and frozen have same accuracy.
So you want to say you couldn't find the nuclear features on imprint?
On imprint as well as on frozen also, sir.
Yeah, that's fine.
Yes, sir.
Okay.
Good presentation.
Thank you, ma'am.
Have you come across multinodular goiters turning into any malignancies after taking imprint cytology?
No, sir. No, ma'am. In my study, multinodular goiter, we
Not included.
No, sir. We didn't miss it on.
Okay, whatever nodules removed, that specimens you are taking, na? At that time, any cases you come across?
Sorry, ma'am.
After receiving the specimens, nodules, thyroid nodule specimen, so have you come across some nodules, means multinodular specimens?
Ma'am, not
It
in
is detected as
pathology.
cancers.
Not in this study. The FNACs which I have come across there, sequence of FNAC we have diagnosed as multinodular
Morning.
pathology. It is termed as cancer.
What?
Water
For
level.
differentiating adenoma from carcinoma on imprints.
Carcinoma.
Adenoma.
On imprint,
Jaggi Karavundu.
if once the papillary structures, if it's there, in one of the case we had proper
Hmm,
papillary
Kade-
pattern. So that goes in favor of papillary thyroid carcinoma. Along with it had nuclear features also with mild and isonucleosis.
I'm talking about follicular adenoma versus carcinoma.
Adenoma will have bland nucleus, no anisonucleases.
That is based on capsular and vascular invasion, I suppose.
Sir, capsular invasion we cannot see on
So
imprint.
that is a problematic area which you cannot
Yes,
diagnose.
that is one limitation. Capsular invasion and vascular invasion is not seen on imprints.
Okay, thank you.
Thank you.
The next presentation, PGOP 13, clinicopathological study of mesenchymal tumors of gastrointestinal tract.
Hemat. వచ్చారు వాళ్ళు బయట.
Good morning. Today my topic is clinicopathological study of mesenchymal tumors of gastrointestinal tract. Coming to introduction, mesenchymal tumors of GIT is a group of rare tumors with overlapping histological features. They include conventional soft tissue entities like lipoma, leiomyoma, or nerve sheath tumors, and entities entirely restricted to gastrointestinal tract like GIST, plexiform fibromyxoma, schwannoma, and inflammatory fibroid polyp. Though GISTs are rare, accounts for 1 to 2% of gastrointestinal neoplasms, but they are most common mesenchymal tumors of alimentary canal. This study was undertaken to evaluate clinical, histomorphological, and immunohistochemical features of mesenchymal tumors in a tertiary care hospital. Coming to materials and methods, this study was conducted in our hospital over a period of 31 months, that is from Jan 2021 to July 2023. All cases with histopathological diagnosis of mesenchymal tumors of GIT were included. A detailed clinical and histopathological features of these cases were analyzed. Coming to results, this study comprised of 24 cases, among them 15 are male and 9 were female, with histopathological diagnosis of mesenchymal tumors of GIT. Table 1 depicts the different investigative procedures for obtaining various biopsy specimens. Total, we received 20 wide excision specimens and 4 small biopsy specimens.
Hello?
Chart 1 shows age and sex-wise distribution, and chart 2 shows site-wise distribution of mesenchymal tumors of GIT. The age range of these tumors was found to be 33 to 81 years, with the mean age of 56 years. This is the chart 1 showing age and sex-wise distribution of mesenchymal tumors of GIT. Maximum number of cases are seen in 41 to 60 years of age group with male predominance. This is the site-wide distribution of mesenchymal tumors of GIT. Stomach is the most common site to be involved, followed by large bowel, small bowel, large bowel, omentum, and mesentery. These are the types of lesion. In benign, we are having benign gist, leiomyoma, lipoma, angiofibrolipoma. In malignant, we are having malignant gist, leiomyosarcoma, and pleomorphic sarcoma. Out of these 24 cases of mesenchymal tumors of GIT, maximum number, that is 18, that accounts for 75%, revealed gist, followed by leiomyoma of 2 cases, leiomyosarcoma, lipoma, angiofibrolipoma, pleomorphic sarcoma, each seen in 1 case. Among 18 gist cases, mean age is 56 years. The common site is found to be stomach. The most frequent histological subtype is spindle type, and majority of cases present with tumor size of more than 10 centimeters and of high grade type. This is histomorphological patterns of GIST. Stomach is the most common site to be involved, and we are having 7 cases of tumor size more than 10 centimeters. and maximum cases are of spindle cell type. High risk category, we are having 12 cases of high risk category. Now coming to IHC, 10 cases shows CD117 positive and 6 cases show CD117 and DOG1 positive. 1 case shows CD117 negative and DOG1 positive, and no IHC data available for 1 case. This is a gross appearance of partially resected jejunum. On cut section, it shows solid gray white tumor with trabeculated pattern. This is a specimen of sleeve gastrectomy with attached large gray brown solid ovoid mass measuring 20 into 16.5 into 9 centimeters. This is a gross appearance of leiosarcoma. Is a mass from small bowel mesentery. On cut section, it shows solid gray white with cystic space. Now coming to microscopic appearance of mesenchymal lesions of GIT. Figure 4A and 4B shows spindle cell type of GIST. Here the tumor is showing the tumor is made up of spindle cells at places showing storiform pattern. This is a mixed type of GIST. It shows both spindle and epithelioid cells. This is a leiomyosarcoma photomicrograph showing pleomorphic spindle cells with abundant eosinophilic cytoplasm, nuclear hyperchromatic and prominent nucleoli. Figure 7A shows pleomorphic sarcoma photomicrograph showing spindle cell tumor arranged in storiform pattern, having elongated to plumb pleomorphic nuclei. Some have prominent nucleoli. Multinucleated giant cells are seen, and brisk mitotic activity is seen. This is a picture of lipoma. Here the tumor is made up of lobules and sheets of mature adipocytes separated by thin fibrous septa. And here is a picture of angiofibrolipoma. Photomicrograph showing tumor shows adipose tissue forming lobules separated by fibrous septa of variable thickness. Many thick and thin-walled, dilated and congested blood vessels are seen. Now coming to IHC, this is a CD117 for GIST. It shows strong and diffuse positive for membrane and cytoplasm. And this is a moderate and patchy positive for GIST. And this picture shows CD117 negative. And this is IHC DOG1 for GIST. It also shows positive. This is the IHC done for leiomyosarcoma. This shows SMA positive. Now coming to discussion. In this study, mesenchymal tumors were observed in age range of 33 to 81 years with a mean age of 56 years, which differs from study conducted by Norman Janhari et al., who observed mesenchymal tumors with median age of 43.28 years. The most common mesenchymal tumor in our study was GIST, 18 cases out of 24 cases, which is similar to other studies. In our study, stomach is the most common site, followed by small bowel, but Norman Janhari et al. Reported stomach followed by colon. The present study revealed GIST to be the most common mesenchymal tumor of GIT, and spindle cell type was the commonest.
It's 10:58.
Most common microscopic type, with the maximum cases being CD117 positive, which corroborate with other studies. Jumninsek et al. Has reported most of the cases are of low risk category, but in our study, most of them are of high risk category. Coming to conclusion, this study enlightened on clinical histopathological and immunohistochemical features of mesenchymal tumors of gastrointestinal tract, which often causes diagnostic dilemma. However, correlation of histopathological findings with imaging and immunohistochemistry findings leads to accurate diagnosis, which can enable the clinicians to take optimal decision for therapeutic management. These are my references. Thank you.
Thank you.
A good presentation. You have mentioned benign GIST and malignant GIST. So how benign GIST, you have done any confirmatory immunomarkers or other diagnostic tests?
We done only CD117, ma'am. We didn't perform any Ka67, ma'am. According to mitotic figures only, we differentiated it into benign and malignant.
Thank you.
Thank you.
Next presentation, PGOP14, a 6-month study on cytomorphological examination of serous effusions, employing Indian Academy of Cytologists guidelines for reporting serous effusions at a tertiary care center.
Good morning, everyone. My study is about a 6-month study on cytomorphological examination of serous effusions, employing Indian Academy of Cytology's guidelines for reporting of serous effusions at a tertiary care center. Introduction. Serous effusion is the accumulation of fluid in the body cavities due to various causes, and malignancy being one of the most important causes. The most common sites from which fluid can be tapped and sent for analysis include pleural, peritoneal, and pericardial cavities. Cells which may be present in the serous fluids are mesothelial cells, macrophages, erythrocytes, lymphocytes, neutrophils, and malignant cells. The IAC has set certain guidelines to provide a standardized format for reporting of serous effusion cytopathology right from the sample reception to its ultimate sign out. Aims and objectives. To assess the plausibility of applying IAC reporting guidelines to various categories of effusions and to determine their frequency. Materials and methods. All the samples of serous effusions received during the period from February 2023 to August 2023 were taken for cytological evaluation. A total of 160 properly collected and labeled samples were received from various wards and departments. The samples were processed as per guidelines of IAC and reported as per the suggested proforma. This is the sample proforma by IAC for reporting of cytology fluids. Volume, color, and consistency of the fluid are noted. Representative volume of the fluid was centrifuged under 2000 rotations per minute for 10 minutes, and the sediment formed was made into smears. A minimum of 1 air-dried and 2 wet-fixed smears were prepared. Air-dried smears were stained with Leishman stain, and wet-fixed smears were stained by HND and PAP methods. Results. A total of 160 samples were received during the study period, which included pleural fluid, ascitic fluid, and pericardial fluid. The age range spanned from 11 years to 78 years. This is a table showing the number of fluids we received. Pleural fluid, we received 108 samples, ascitic 50, and pericardial 2 samples. This is the distribution according to gender. We received 105 samples from female patients and 55 samples from male patients. This is the IAC classification. Category 1 non-diagnostic, Category 2 benign, Category 3 atypical cells, Category 4 suspicious of malignancy, and Category 5 malignancy. Category 1 smears that do not contain sufficient quantity of cells for evaluation are placed under this category. In this study, we received 7 such samples. Category 2. This category represents a diverse array of effusion causes that do not involve malignancy. The reports of the fluids in this category included reactive mesothelial proliferation, acute inflammation, chronic inflammation, lymphocytic effusion, and specific infections. Out of the 160 cases, 115 were classified into Category 2, emerging as the predominant etiology of effusion, irrespective of the site in our study. This is the subcategorization of Category 2. The most common was reactive mesothelial proliferation, and the least common we received were from infections. Category 3, cells with cytological atypia that quantitatively or qualitatively do not favor malignancy are placed in this category, and in our study, we received 12 such samples. Category 4, smears that show cells with cytological atypia that are enough to warrant suspicion of malignancy come under this category. In the present study, 9 such cases were placed under this category. Category 5. This category represents smears that show unequivocal malignant cells. A definitive diagnosis of malignancy was made in 17 cases. This is the different volumes, color, and consistency of various serous effusions we have received during the study period. These are the microscopic images. Figure 4 shows cytosmear showing pleural fluid with hemorrhagic background, so it is placed under Category 1 and unsatisfactory for evaluation. Figure 5 shows cytosmear showing benign mesothelial cellular changes, Category 2. Figure 6 shows cytosmear showing scattered lymphocytes and few degenerated cells. Figure 7 shows cytosmear showing benign mesothelial cells on Leishman stain. Both of them are placed under Category 2. Figure 8 shows cytosmear showing mesothelial cell hyperplasia, and Figure 9 shows cytosmear showing predominantly neutrophils and lymphocytes along with few mesothelial cells. Both of them are placed under Category 2. Figure 10 shows cytosmear showing atypical cells arranged in sheets having high NC ratio. This is placed under Category 3. Figure 11, cytosmear showing atypical cells with hyperchromatic nuclei arising the suspicion for malignancy and hence placed under Category 4. Figure 12 shows cytosmear showing 3D ball structure with pleomorphism, hyperchromatic nuclei, and scanned cytoplasm. And figure 13 shows cytosmear showing malignant cells with pleomorphism, high NC ratio, and scanned cytoplasm. Both of them placed under category 5. These are the immunohistochemistry on cell blocks. Figure 14 shows the EMA positivity, and figure 15 shows cytokeratin positivity. This is the table representing the frequency of cases categorized into various reporting categories in accordance with IAC. A total of 115 cases were from category 2. This is the bar diagram representing the same of the three fluids we received. Discussion: serous effusions account for a considerable share of annual caseload in cytopathological laboratories. In the present study, the most common effusion was pleural fluid, followed by peritoneal and pericardial fluids. The present study had a female preponderance with a male is to female ratio of 1:1.9. This is a comparison table of different studies. Kundu et al. And Pergaris et al. Were in concordance with my study, being pleural fluid being the most common, while the study conducted by Nagos et al. Had ascitic fluid as their most common fluid. This is the comparison table according to IAC, showing all the 5 categories. Kundu et al. Had the most common category in category 2, and in our study, the most common was also category 2, while Nagos et al. Had the most common category in category 5. Conclusion: the IAC guidelines for reception, preparation, and reporting of serous effusion cytology samples are ideal and in consonance with other reporting systems like Bethesda system for gynecological cytology, and if followed by all laboratories, ensure uniformity in reporting and quality in laboratory cytopathology practice throughout the country, which in turn will have impact on patient care and management. The sample is small and the period of study is less, and hence continued research and evaluation with larger samples over a longer period of time will be useful to assess the long-term impact and effectiveness of IAC guidelines. These are my references. Thank you.
So that was a good study. How many cases you could get biopsy samples and how many you could confirm your diagnosis?
Out of the 160 samples in our 17 were malignancies, which were detected on serous effusions. Out of the 17, adenocarcinoma we had from lungs, a few cases. Only those we could confirm histologically. The others were sent for outside biopsies.
How many cases?
Out of the 17, we had 10 adenocarcinoma from lungs.
Lungs you got.
For lung, that was the most common malignancy we received, sir.
Okay, and cell block was done?
Cell block, because of the limited resources, only for a few cases we could do cell block, sir, which I've added 2 images showing
for those
EMA and cytokeratin positive.
ISCs. Okay. Okay.
It was good study. Out of all 3 types of fluid aspirations, which means inflammatory lesions you have come across, and common malignancies?
The common malignancy was, as I've told, adenocarcinoma from lung, ma'am. The inflammatory lesions were mostly from the peritoneal fluid and pleural fluid. We got inflammatory lesions, ma'am. Few of them were of lymphocyte rich, so which indicated which arise suspicion for tuberculosis etiology, and the other were inflammatory, acute and chronic inflammations.
Peritoneal fluid?
Peritoneal fluid also, we got similar results, peritonitis, and post-op infections, we got few fluids, ma'am. Like that.
Thank you.
Thank you.
Is the presenter with abstract number PGOP8 present? PGOP8.
If not
we can
available,
conclude.
declare absent.
Yes, ma'am.
PG paper 8 not available means
We can conclude, ma'am.
yeah. Absent, no?
Yes, ma'am. He's not there. I thank the judges for judging the session. I request Dr. Josna ma'am to hand over the mementos.
Without further delay, we move on to the scientific session. The session is Genomic Basis and Mutational Landscape of Myeloproliferative Neoplasms. I'm immensely pleased to welcome our chairperson, Dr. K. Maruti Devi ma'am, Associate Professor, Department of Pathology, Government Medical College, Ongole. Ma'am has published multiple research articles in various national and international journals. She has won the third prize in Young Scientist category in paper presentation in IAPM Andhra Pradesh State Conference in 2017. Ma'am is being recognized as Joint Organizing Secretary, first IAPM State Conference in 2016, Treasurer IAPM State of Andhra Pradesh from 2017 to till date, and she also acting as Deputy Editorial for 2018 to 2023. Welcome, sir. I request sir to take over the session and introduce about the speaker.
Thank you, organizers, for giving this wonderful opportunity to introduce the speaker of this session, Dr. Ram Naval Rao. Is a professor in from Sanjay Gandhi Postgraduate Institute of Medical Sciences, SGPCI, Lucknow. Some of the achievements of Dr. Ram Naval Rao are: he was invited as national and international faculty speaker in European Congress of Cytology Conference in Geneva, Switzerland, Milan, Italy, an international conference of cytology, Tokyo, Japan, and Madrid, Sydney, Australia, and also in ECC, Poland, and ICC 2022 at Baltimore, Maryland, USA. He served as secretary of Indian Academy of Cytologists, UP chapter, since 2022 to till date. And to his credit, he has many publications, about 90 publications in national and international index journals, and also authored chapters in 5 books in MBBS pathology and BSc nursing pathology books, and some of his other academics and research activities. He completed seven intramural and extramural projects and was a guide and co-guide for PhD, MD, DM, and MCH students, and thesis evaluator for many MD pathology candidates. And he has, to his credit, he has many awards like Best International Research Paper Award, RCP Sri Lanka and ICC 2019 Sydney, Australia, and Best State and National Oral and Poster Paper. About 8 awards he got in those categories, and various memberships. He's attached to, I mean, he has membership affiliation as in to Executive Council of Indian Academy of Cytology, IAC, member of Indian Academy of Cytology, IAPM, South Asian Academy of Cytology and Histology, and also International Academy of Cytology 2019. So this is the brief introduction of today's speaker, Dr. Ram Naval Rao.
Hello. Hello. Thank you, Chairperson. I would like to thank to Dr. Josna and Nigam and Dr. Jyoti Verma, who given the opportunity to present these topics. So our topic is the role of cell block, immunocytochemistry and molecular study in the cytology samples. So cytology are the increasing being used and adjunct to smear to improve the diagnostic accuracy of the FNA cytology in comparison with the traditional smear cytology. So cell block are the preferred choice for the immunocytochemistry and molecular study as they are comparable with the surgical biopsy, can use the same control site. So the FNA is a simple, efficient, and cost-effective technique for the evaluation of the superficial and deep-seated lesions, and accurate method for the diagnosis of solid and cystic lesions. So rapid on-site evaluation of the FNAB direct smear the provide reduction in the insufficient rate as well as a reduction in the atypical and suspicious rate and concomitant with the increase in the benign and malignant diagnosis. So ancillary technique, especially cell block, immunocytochemistry, fluorescence C2 hybridization, RT-PCR. So what is the cell block? Cell block is a microorganism. So it's without the cytology.
এই যে ল্যাপটপ ঘাটছে ঘাটবে
Immunoexcellence are the IST, and this is the fully automated method for the immunocytochemistry. This is the Dana method. It takes 4 hours for the immunocytochemistry. So it can make a cell block by so many steps, maybe breast cancer, pancreatic disease, lung cancer, thyroid, and other cellular. So this is the we have done the cell block website. This is the scheme of our cell block. So immunocyte cell block. So determination of the hormonal receptor like the ER/PR and HER2 important primary assessment of the time at the breast cancer diagnosis. So the strong biomarker associated with the response to the tamoxifen treatment and PR strategy known to the associated with the disease-free and overall survival. So patient with the ER/PR positive had a better prognosis than patient with the ER positive and PR negative tumors who have the better prognosis than patient with the ER/PR negative tumor. So EGFR HER2 is the testing of sample from the recurrent of the metastatic breast cancer recommended by the 2013 update. So coming to case, the 60-year female presented with the left breast length 6 to 9 months. FNAC was done. The FNAC so smear so the cluster of the malignant cell. The cell block was made in this case, showing sheet of malignant cell. The ER/PR HER2 also done. ER and PR are positive. In this case, HER2 is a 3+ positive. So this is the infiltrating duct carcinoma. Coming to the second case, the 50-year female presented with the left breast lump. Now this is the case second, showing the round oval cells, monomorphic cells, the cell block made and also tissue block also made. The ER/PR positive, HER2 positive, E-Catherine is negative in this. That means it is the lobular carcinoma. So this is the lobular carcinoma. So case 4, this is the sheet of malignant cells showing round oval cells, some showing the spindle round oval cells and the stipple chromatin. The cell block showing the sheet of cells, round oval cells, the scan to moderate cytoplasm. The HER2 is also positive in this case, and synaptophysin is also positive on the cell block. So this is the neuroendocrine tumor of the breast. So case 5, the 58-year female presented with the right breast lump since 7 months. So the tumor cell has the highly pleomorphic cells, some showing the giant cell formation along with the area of the squamous differentiation. So immunocytochemistry was done on the cell block. Vimentin positive, ER positive, PR negative, HER2 negative, P63 some showing the negative, but Ki67 is high. So this is the case of metaplastic breast carcinoma. So case 6, this is the FNAC smear showing the round oval cell, monomorphic cell, along with the secretory material. So cell block and tissue block both are made. The cell block showing the some globule like secretory material, the PR and positive on the both cell block and tissue block. So histopathology also show the similar finding of the cell block. So this is the HER2 negative in both cases. So this is the case of secretory carcinoma of the breast. So case 7, the 62-year female presented with left breast lump. So this is the tumor cell in the mucin background abundant, cell block, tissue block both showing the positivity for the ER/PR and HER2 negative. So this is the mucinous carcinoma breast. So this is the 40-year female showing the singly dispersed cell. The cell block were made. This is the non-Hodgkin lymphoma breast. So case 9, the 42-year female presented the right breast lung 7 months, showing the sheet of cells, abundant cytoplasm, look like some oncocytic apocrine like cells, cell block were made, HER2 are the strong positive. So this is the case of the histopathology was also done, showing the PR positive, HER2 strong positive. So this is the case of apocrine breast carcinoma. So case 10, this is the FNA smear. So 60-year female presented with the right breast lump since 1 year. It has also the retroperitoneal lump since 18 months. So FNA was done. The smear show sheet of cells, some showing the moderate cytoplasm, abundant cytoplasm on the background of mucoid background, and some showing the vacuolated cytoplasm, hyperchromatic nuclei. So can you make what is the diagnosis? Anyone in the breast lump showing the moderate to abundant cytoplasm, vacuolated cytoplasm, cell block made, what will be the diagnosis possibility? So immunocytochemistry was done, CK positive, Vimentin positive, CD10 positive, and MA negative. So our ER/PR HER2 negative, GATA is also negative. So this is the case of metaplastic renal cell, metastatic renal cell carcinoma in the breast. So histopathology also done in the kidney. So showing the renal cell carcinoma, renal cell type. So we had done the ERPR happening on the so many cases, showing this according to the 3+, 2+, and 1+. So this is the ERPR happening on the cell block. So according to we have used the rabbit monocular antibody. So these are the Hartini positivity. So correlation with Hartini and ISC stain score for the cell block and tissue block. So 50 cases positive for the 20 cases in 50 cases, 20 cases were positive for the 15 are the 3+, 4 are the 2+, and 1+ for, and 30 is the negative. So diagnosis accuracy is the sensitivity in the ERPR and Hartinu. This is the 95.6.5, 95.5, 100%. These are our sensitivity, specificity, and the positive and negative predictive value. So coming to the miscellaneous some cases, the 3-year female presented with the left upper lip mass extending to the left angle of the mouth. So CT show the mass in the upper lip. So cell block made, FNS smear also shows round to oval cells, some showing the scan to moderate cytoplasm. So cell block were made, similar finding. So clinical diagnosis was done with PNET, lymphoma, neuroendocrine tumor, and rhabdomyosarcoma. So immunocytochemistry done, desmin myogenic positivity. So this is the case of rhabdomyosarcoma. So 3-year female presented with the liver SOL, 3-year male. So this is the round to oval cells, scanned cytoplasm. So immunocytochemistry done, alpha fetoprotein and alpha protein was positive and HEPAR was negative. So this is the case of hepatoblastoma. So 55-year male presented with a liver SOL since 2 months, alpha fetoprotein level was elevated. So cell block were made showing the positivity for the HEPAR and alpha fetoprotein. So this is the case of hepatocellular carcinoma. Now coming to how to make the cell block from the EUS-FNA. So EUS-FNA as emerging as a primary diagnostic method of the choice for the patient with a pancreatic solid and cystic lesion. So pancreatic carcinoma, unfortunately, usually a fatal disease. So collective median survival time of all patients is 4 to 6 months. Patient with the pancreatic cancer receive only the palliative therapy because it's advanced stage of presentation. So this is the US guided FNA instrument. So this is the video of US guided FNA showing the CBD and portal vein, and there is a mass in the pancreatic. So needle by transdural aspirate by the oral route. You can see the needle here. This is the needle, how to take the sample by the transdural method. This is the US-FNA. So this is also the another case showing the US-FNA. Video showing the nicely in the how to do the US-FNA from the pancreatic lesion. So we did the US-FNA from the pancreatic solid and cystic masses. There are 250 cases ultrasound guided and 50 cases from the US guided. So in this case, US-FNA done from the pancreatic mass. So showing the FNA smear round to oval cells, some showing the oval cells, scanned cytoplasm, moderate cytoplasm, some cell block were made. MUC1 was the naturally positive in the strong part in this case. So this is the case of well different a well different adenocarcinoma. So in the other case, MUC1 were positive, US guided FNAC was done, showing the moderately differentiated adenocarcinoma. So the third case, FNA smear, US-FNA was done, tumor cells show the dispersed pulse, round to oval cells, singly scattered cells. So cell block made, MUC1 were positive. So this is the case of poorly different carcinoma. Now the other US-FNA was done, smear showing the mucin background along with the tumor cell. So cell block were made, there is nicely positive for the MUC1. So this is the mucinous carcinoma. Here is the case of adenosquamous carcinoma. Now the US-FNA smear done from the pancreatic mass, showing the round to oval cell, stipple chromatin, the cell block were made, the MUC1 were positive in this case, along with the synaptophysin chromogramin. So another case, 40-year female presented with a large pancreatic mass, the US show pancreatic mass. The FNS smear show the some papilloid front, round layer by the round to oval cells. This singly dispersed cell block were made. This is the MUC1 negative and CD10 positive. So this is the case of solid pseudo-papillary tumor of pancreas. This is the gross finding. This is the histopathology, and this is the histopathology on CD10, chromogranin, vimentin, and positive in this case. So this is the important how to differentiate from the solid pseudo-papillary tumor, neuroendocrine tumor, and mesophoneal tumor. These are the markers to differentiate from each other. So this is the NHL non-Hodgkin case from the pancreatic mass. This is the acinar cell neoplasm. So the 11-year-old male presented with the pain in the left hypochondrium. So CT scan revealed the large mass in the pancreatic tail. So this is showing the pancreatic tail mass. The smear show the spindle cell, abundant cytoplasm, cell block were made. So beta-catenin bimentin positive. So this is the diagnosis of desmoid tumor of pancreas. This is a very rare diagnosis. So another showing the mass in the pancreatic hair. Sometimes the tuberculosis show the pancreatic mass, hypoechoic pancreatic mass. This is showing the degenerating granuloma. The clinical diagnosis was the lymphoma and carcinoma. The nicely in cell block showing the giant cell and necrosis. So FD positive. So this is the tuberculosis, the pancreatic, primary pancreatic tuberculosis. So PCR were also done in this case, showing the positivity for the RT-PCR. So another case for 52-year male presented with the pain in abdomen. The smear showing the some pigment-like lesions, brown to pigment. So HMB45, H100 were positive. So this is the case of metastatic malignant myeloma to the pancreas. 40-year male presented with the periportal mass. Smear show round to oval cells, sheet scattered. So cell block were made. Immunocytochemistry shows chromogranin synaptophysin positive, negative for the LCA and CD19. So diagnosis the neuroendocrine tumor of the periportal mass. So in case of pancreatic cancer, the strong membranous staining of the MUC1 was noted in the apical and luminal region where there are gland and luminal formation. So we have the study showing the 50 and 20 to 50 cases in the pancreatic mass. So coming to the EUS TBNA. So EUS TBNA is a novel, rapidly growing diagnostic modality that allows the precise sampling of the intrathoracic lesion, including the mediastinal masses, lung lesion, and peribronchial lesions. So it is a minimally invasive, safe, and cost-effective techniques with high diagnostic yield. So this is the EUS TBNA instrument. Now coming to case 1, the 55-year male presented with the upper lobe lung mass, showing the cretinized squamous cell block were made. So immunocytochemistry also does CK cytochronic positive, P63 positive, and CK566. TTF is negative. So squamous cell carcinoma. So case 2, 59-year male presented with the left lung mass, EUS TBNA was done. So smear show the PAD positive. That is the important feature to diagnose the adenocarcinoma. So this is the CK7 TTFR positive. So this is the case of adenocarcinoma. So another case, the squamous cell adenosquamous carcinoma, coming to the 56-year male presented with the mediastinal mass. So the cluster of round oval cells, cell block were made. The smear show the cell block show synaptophysin, chromogranin, and LCA and TTF are negative. So this is the case of small cell carcinoma lung. So 52-year male presented with the mediastinal mass. Some tumor cell arranged in the papillary architecture, round to oval cell, monomorphic cell, PS positive. The cell block were made, positivity for the immunocytochemistry vimentin, CD99, NSC, and negative for LCA. So this is the diagnosis of primitive neuroendocrine tumor. So coming to the 6th case, this is the case of NHL Burkitt lymphoma. This is Hodgkin's. This is another case of leiomyoma. So immunocytochemistry done, vimentin positive, desmin positive, SMA, and H100 negative. So this is the case of leiomyoma. Coming to the 9th case, showing the metastatic ductal carcinoma to the lung. So another cases, this is the 75-year male presented with the mediastinal mass. The tumor cell arranged in the papilloid front, some showing the internuclear growing. So cell block were made showing the colloid material, colloid follicle, thyroid follicle. In this, the CK19 show the strong positivity. So that is the case of metastatic papillary carcinoma. Now, in the 70-year male presented with a lung mass, ibastibine was done. The tumor cell cytology showed the gland formation, predominantly gland formation. So, synapto CD19 CK20 was negative. The PSA were positive. So, this is the case of metastatic prostatic adenocarcinoma. So, we have also the cases of sarcoidosis and tuberculosis. So coming to the EGFR and ALK mutation, so lung cancer is the most common cause of the cancer-related mortality worldwide. The lung cancer is broadly divided into small cell and non-small cell. So non-small cell count approximately 85% of lung carcinoma. So it further classified the adenocarcinoma in squamous cell. So we can see the EGFR mutation on the exam 18, 19, 20, and 21. So this is the ALK positivity showing the immunohistochemistry ALK D5F5 F3. This is the ALK positivity. So in other ancillary technique, the liquid-based cytology. So literally means the cytology through the liquid medium, cells collect are placed directly in the liquid preservative. So rather than transfer to the slide in the conventional method. So what are the advantage of the liquid-based cytology? It improves the fixation, decrease occurring factor and infectious organism, retain and the beta preserve. So quicker to the screen and report, multiple slide can be produced along the further setting. So what are the disadvantages? More costly than the conventional pap smear. So this is the maybe two types, thin and sure path. So we have purchased the fully automated thin sure path, the fully automated LBC. So these are the instruments for the prepare and vertex centrifuge. So in sure path, there is a clean background and there is a very nicely seen the LBC. So these are, we have attended the international conference on this topic in the Japan. So coming to the fluorescent C2 hybridization. So fluorescent C2 hybridization is the cytogenetic technique, utilizes the fluorescent tag probe and that bind to the chromosome specific DNA of the interest and identification of the structural and numeric abbreviation. So this technique Immunocytochemistry and FISH and other for the triazole. So this is the qRT-PCR. This is the method. This is the method. FNA sample, RNA isolation, cDNA amplification, denaturation, annealing, and extension. These are the process of the RT-PCR. These are the method for how to do the RNA isolation from the FNA sample. So these are the conditions, primer and proof for the 13 new genes. This is the RT-PCR machine. So this is the amplification plot. So this is the left side showing the herniation mRNA positive, and left side is the right side is the negative for the herniation. This is the positive control and negative control. So these are our study correlation between FISH and RT-PCR. Coming to the case one, the 55-year-old female left breastline. In this case, RT-PCR, immunocytochemistry, and FISH were done. So showing the expression of the level. So RT-PCR, this is the RT-PCR. So this level, red level, if the blue level, this is low expression, high expression. If the level is low, below the line, that is the RT-PCR is negative. So in this case is the 2+, the RT-PCR and FISH both are negative in this case. So in this case, the second case, 65 female presented left breastline, cell block and immunocytochemistry naturally positive 3+. So FISH also show the more than 2+ positivity, and RT-PCR show the higher level of expression of the RT-PCR. So this is the 3+ positivity. So coming to the molecular testing the cell block from the thyroid FNA. So use of the FNA from the evaluation of thyroid FNA has resulted in the 50% decrease in the surgical intervention with the threefold increase in the finding cancer in the surgical resected specimen. So in thyroid neoplasm, only a small percentage is the malignant, which can histologically mimic the benign nodule. So BRAF mutation, gene that encode the protein called the BRAF involved in the sending the signal inside the cell, which are involved in the detecting the cell growth. So FNA was done from the thyroid nodule. cell block were made, so the thyroid follicles, benign. So galactine, in this case, galactine are the negative. Galactine is the negative in this case. So this is case of the thyroid, papillary thyroid carcinoma. Here in the case of galactine is the strong positivity. So in the case of follicular neoplasm, here histopathology show the capsular invasion. So it is follicular carcinoma on the histopathology, but the follicular neoplasm on the cytopathology. So in this case, importance of the galactine show the weak positivity. So in compare to papillary thyroid carcinoma and benign and follicular carcinoma, so it show the weak positivity and focal positivity in the benign and follicular carcinoma. So this is the case of follicular variant of PTC. So galactine show the strong positivity. This on the basis of galactine, we can differentiate on the immunocytochemistry. So if you do the RT-PCR on the BRAF mutation by the RT-PCR, we take the sample from the thyroid FNA. So FNA samples take in the trial by the DNA RNA expression. So BRAF mutation is V600E specific ICC was performed using the Ventana benchmark XT automated staining system for 64 minutes. So how to scoring this BRAF mutation? So there is no staining, that is the negative. If the 1 plus less than 30 cells, that is 1 plus positivity, that the 2 plus, that is the 30 to 80% cells, the 2 plus, and 3 plus is the 80% strong positivity, that is the 3 plus. So true BRAF mutation kit, we can process true PCR BRAF mutation kit to detect the BRAF mutation in the thyroid lesions. So this is the true PCR BRAF kit. So after the doing the so many cases, this is the plot like this, RT-PCR, how to check the RT-PCR, some showing the curve of the RT-PCR, positive and negative controls. So we had did the 60 cases. This is our result. So RT-PCR done in the benign cases. So none of the case showing the positivity for the BRAF mutation. So 60-year male presented with the multiple subcutaneous nodule in the chest and swelling. So FNA smear was done showing the cluster of malignant cells, some showing the papilloid frond-like structure, cell blocks showing the nicely papilloid frond, BRAF mutation showing the 3 plus positivity on the cell block. So RT-PCR was done showing the nice curve for the RT-PCR for BRAF positive mutation. So on the cell block. So in another case, 26-year female presented the polythyroid nodule. Since 1 year, FNA smear was done showing the moromorphic cell, some showing the cell block were made. So this is also case of the papillary thyroid carcinoma. So this is the showing the BRAF mutation by the RT-PCR. So in the third case, the 65-year male presented with the multiple anterior neck nodules in 3 years, showing the follicular cells in the cluster. So cell block were made. So this is the case of follicular variant of PTC. So in this case, the BRAF mutation is negative on the immunocytochemistry. But in the RT-PCR, this is the showing the BRAF mutation on the RT-PCR. So this is sometimes can be in 100% cells that does show the immunocytochemistry positivity for the BRAF mutation. So 22-year female presented with the right thyroid nodule. So this is the case of PTC, also showing the low level of BRAF amplification. So 50-year male presented with the left thyroid nodule. So in this case, the cluster of the cells, thyroid follicular cells, mild pleomorphism, some showing the papillary-like features, but a nuclear feature of PTC not seen. So this is the case of non-invasive follicular thyroid neoplasm with the papillary-like nuclear feature. So in this case, we had done the PCR. So this is the negative RT-PCR by the BRAF mutation. So 6, this is the case of Aphelibus and the follicular neoplasm. All these show the negative for the RT-PCR and BRAF mutation. So in the case of follicular carcinoma, also show the BRAF negative. So the 50-year male presented with the left thyroid nodule. This is the case of poorly differentiated carcinoma of the thyroid. This is the nicely positive for the BRAF mutation, and RT-PCR also show BRAF mutation by the RT-PCR in the case of poorly differentiated carcinoma thyroid. So this is the colloid nodules, and this is the negative for the BRAF mutation on the cell block. So this is I have attended the international conference in the Baltimore, America. So the next step is the Sanger sequencing and next generation sequencing. So we can run the extraction by the PT in the papillary carcinoma, BRAF mutation by Sanger sequencing, showing this the BRAF codon 600. So these are the positivity files. So our study summarized as if you take the fluid and FNA tissue sample, we can make the cell smear, frozen or cell block by the plasma thrombin method or Sandan method, auto method. We can do the cell block, FISH, RT-PCR, and also do the Sanger sequencing. This is the important. It depends on the experienced cytopathologist and adequacy of the material. So take home message, ERP or Hertinu can be done on the cell block, and BRAF mutation also done on the cell block. MUC1 CK19 also done on the cell block from USFNA, and CK90 is done on the, and CK7 5C TTF also done on the cell block. So thank you for all that time.
Thank you, sir, for the excellent compilation of so many varieties of cases of different organs and giving a very complete picture of all the possible investigations from the cell block. So I think questions. So because the sessions are running behind schedule, so it's not open for discussion to the audience. Before closing, just a quick question from my side. Okay. Sir, is it a routine practice in your institute to do cell block for all the cytology cases?
Not all,
or only few?
Not all.
Only some selected.
Selected.
Okay, it's not mandatory that every case.
But we are doing on the thesis and project.
Okay. Any challenges you face, sir, in some cases in collecting, depending on the quantity of aspirate to do the cell blocks? Any difficulty?
No, any difficulty. Depend on the aspirator.
Aspirate only. So it's not all the cases, only some cases.
Okay.
Thank you very much, sir.
Thank you.
Wonderful. Any questions? Anyone can discuss with him personally, individually. Thank you.
Now I would request Dr. Kiran Kumar sir to felicitate our speaker.
Now I would like to call upon Dr. Alvina, Associate Professor, Department of Pathology, Institute, to contribute the chairman. Thank you, sir, and everyone. We are not ready in the session for the feedback as we have various sessions planned up for today. So delegates who are in are requested to grab their tea and come back. The next session is on genomic cases and mutational landscape of myeloproliferative neoplasms. For this, I would like to invite our chairperson, Dr. Maruti Deviman, Professor and HOD Department of Pathology, Government Medical College, Martha.
Up next, I would like to invite our next chairperson, Dr. Rakesh sir, Associate Professor, Department of General Medicine, AIIMS Mangalagiri, onto the stage. Welcome, sir.
Now I request our chairperson to take over the session and introduce about the speaker.
A very good morning to one and all. I am privileged to read out the biodata of Dr. Babura Unninti, Senior Scientist, ICMR National Institute of Immunohematology, Mumbai. Sir has done his PhD in genetics and his areas of research are human genetics, cytogenetics and molecular genetics. He had undergone various trainings and fellowships in national and international institutes. He has awarded with the prestigious award of IC.
I thank chairperson for their kind introduction. And also I thank organizers, particularly Dr. Josna and Dr. Jyoti Wama for inviting me to deliver a talk. So seeing all the abstract and presentations and brochures, I thought it is it's a pathology conference and most of the medical personalities in this area and various diseases and cancers. Since yesterday we are discussing, there are lots of discussions, I believe, and treatment protocols to management of the diseases. The pathology is a very interesting subject for the management of several diseases, particularly the cancers. So recent advances in genetics has improved the management of the diseases. So today I am going to talk on genetic basis of myeloproliferative neoplasms. And it is a very heterogeneous diseases. Particularly, I am going to focus on genetics. Mutations, we all know the driver mutations or whatever mutations. But what is the understanding of the genetics in this research area? So if you see the myeloproliferative neoplasms, these diseases overlapping with many diseases. So we call it as a heterogeneous disease. Many diseases means it is it's associated with aplastic anemia, myelodysplastic syndrome, and CMML, MDS, lots of diseases. But how to diagnose MPN diseases, which is very important. So with this, observational overlapping. There is a clear-cut definition for this MPNs. It's a group of clonal hematological disorders that arise from transformation of a multipotent hematopoietic stem cell. So it is a blood disease. So in this a good classification, you may be knowing very well that chronic myeloid leukemia is a well-known disease and it is included in MPN diseases. So CML is chronic myeloid leukemia is easy to diagnose. Genetically, it's a translocation between 9 and chromosome, 9 and 22 chromosome. We also call this a Philadelphia chromosome. So it is characterized through the Philadelphia chromosome. If you molecularly, if you see that the fusion of BCA or ABL gene. So this is little excluded from the MPN classification because it is well characterized. So whatever the CML negative or Philadelphia chromosome negative, BCR-ABL fusion negative, those cases are considered as a myeloproliferative neoplasms. So what are the the pH negative MPNs? So they are subdivided into polycythemia vera, PV, essential thrombocythemia, and primary myelofibrosis. These are the three categories we see in MPN disease. So there are the pre-fibrotic or early fibrosis, myelofibrosis. It occurs in the absence of the reticulum fibrosis. The megakaryocyte changes must be accompanied by increased marrow cellularity, granulocytic proliferation, and decreased erythropoiesis. So there is always a classification. If you see the myelodysplastic syndromes, there is a WHO classification. So like that, MPN also has a classification, WHO classification. The major criteria is the megakaryocyte proliferation and marked dysplasia with either reticulin or collagen fibrosis. WHO exclusion criteria for CML, PV, MDS, or other myeloid neoplasm, presence of JAK2 V617F, which is a famous mutation, or other clonal marker or absence of reactive marrow fibrosis. So there is a minor symptoms, some category also you see, that is leukoerythroblastosis, increased serum LDH, anemia, palpable splenomegaly. So this is the criteria used to define the MPNs. So there is a lots of disease burden assessing in MPN disease. There are vascular events, cytopenias, progression, MPN symptoms, splenomegaly. So this is not enough. The WHO criteria is not enough to diagnose the MPN diseases. There is a recent classification, that is international consensus classification guidelines. They are categorized into myeloid neoplasm into different categories like acute myeloid leukemia, myelodysplastic syndromes, myeloproliferative neoplasm, and MDS MPN overlap syndromes, myeloid neoplasm with germline predisposition. This category is very important because the recent studies, they say that the somatic mutations also inherited like germline. So there are classification. Then further, this is they are classified as the myeloproliferative neoplasm into different categories like chronic myeloid leukemia, BCR-ABL positive, chronic neutrophilic leukemia, polycythemia, essential thrombocythemia, and primary myelofibrosis divided into PMF, pre and overt fibrotic stages, chronic eosinophilic leukemia, NYS, myeloproliferative neoplasm, unclassified. So last two categories are very important. There are different investigation to diagnose properly. Again, it is further classified. The MPN classification is now very clear. That is, they are into three categories like polycythemia, where we already said, essential thrombocythemia, primary myelofibrosis. So if there is no, see, any pathology conference without pathological slides, it has no means definition. So these are the bone marrow means a smear pictures, how to diagnose the subcategories of MPN. In essential thrombocythemia, majorly cellular marrow with the proliferation of giant megakaryocyte. You can see the very hyper lobulated nuclei scattered or loose clusters. Polycythemia vera is characterized by hypercellular marrow with erythroid proliferation and scattered pleomorphic megakaryocytes. You can see the right picture. Pre-fibrotic PMF. Hypocellular marrow, it is common in all subcategories with granulocytic proliferation and large megakaryocytes with atypical bulbous nuclei. This is very separate from the other the subcategories. Overt PMF, hypocellular marrow, you can see proliferation of atypical megakaryocytes forming dense clusters and dilated vessels with intraluminal hematopoiesis. Overt PMF, that is collagen fibrosis, mainly bonds of collagen fibrosis within hematopoietic lichen. If you see the epidemiology of myelofibrosis, it occurs at a frequency of 0.5 to 1.5 per lakh. Median reported survival in various studies ranging between 3.5 to 5 years. So this is the average the survival, but studies to studies, the average survival rate is different. Post-MR is found to be developed 25 to 50% of PV. This is common in PV, and 2 to 3% of ET, that is essential thrombocythemia, after approximately 15 to 20 years of follow-up. So the disease they develop, and in long follow-up, this will post MF the main subcategory changes. The PMF has been reported rarely in infants. However, it is common in adult patients. Clinical features, if you see, signs and symptoms are the patients usually present with splenomegaly or hepatomegaly, profound constitutional symptoms such as fatigue, weight loss, night sweats, and fever are common. Just generally we see in the patients. 30% of patients are asymptomatic. This is important category. How to where to put these patients, how to diagnose the patients, and are detected by incidental abnormal blood picture or enlarged spleen. So undiagnosed patients are common in many leukemias or cancers. So initially they may not be presenting the whatever the clonality, but later as age increases, as the disease progresses, many molecular changes we see, and on the basis of molecular changes, the patients can be diagnosed. The disease gradually evolves from the early pre-fibrotic phase to the fibrotic phase with increasing bone marrow failure. This is one of the characteristic feature of myeloproliferative neoplasm. So this is very means means explanatory symptoms by disease type. So there are all symptoms are common with a high frequency. Some are in the low frequency. There are fatigue, early sweats, and abnormal discomfort, inactivity. There are lots of symptoms, but these are all are seen in the all categories of MPN. So again, the symptomatic burden in myelofibrosis. So there are again inactivity, fatigue, and itching. There are many symptoms we can see across the subcategories. So the MPN is overlap in clinical presentation and progression. For example, erythrocytosis, if you see, this is seen in all the categories like thrombocytosis, splenomegaly, and these are the symptoms. Only ET and PMF, there is no erythrocytosis, but this is seen in some other groups also. So this sometimes means challenging in diagnosing the patients. What are the causes and effect? Organomegaly, this causing the elevated red cell mass, extramedullary hematopoiesis, elevated cytokine levels. Erythromegaly or ocular imagine fever that is leads to or cause to thrombocytosis and fever, elevated cytokine levels. This is one important. Weight loss and hyperuricemia, gout, renal stones, and fatigue. These also leading to several causes. What are the indications for the laboratory? So presented with anemia and hemoglobin level below 100 gram per liter. So the patients are frequently required the blood transfusions. Other laboratory findings include leukocytosis, leukopenia, thrombocytosis or thrombocytopenia, and circulating myeloblast, increased serum lactate dehydrogenase, and low cholesterol also observed. Abnormal discern blood film, that is leukoerythroblastic blood film, left shifted granulocytosis, and red cell erythropoiesis. So these are the many indications are given. A vast increased number of CD3/4 cells are also present in the peripheral blood relative to both normal and individual and other MPN. So this is one of the important the indication. An increased number of circulating endothelial progenitors and increased vasculature, although not specific to PMF, is a notable feature. So there are many laboratory indications, so which can help in the diagnosis of the MPNs. So if you come to the molecular aspect of the disease, that is MPN, if you see the molecular data, the JAK2 is the major gene playing a role in the MPN diagnosis. In all these categories, the JAK2 is playing a role, but in PV, it's a 90% cases JAK2 mutation is seen. So many mutations, hundreds of mutations we identify after introduction of the Sanger sequencing or more next generation sequencing. How to correlate with the disease, how to understanding the disease is very important. So myeloproliferative neoplasms are many, but with the gene mutations are playing a role in abnormal presentation. As you are seeing, there is a load, but gene mutation is stopping their function. Okay. So this I am going to skip it. So the studies, every literature says that JAK2 mutations plays an important role in the diagnosis of means MPN. However, understanding of the genetic basis of clonal evolution is important. So mutation we identify, several mutations we identify, but understanding of the genetic basis of MPNs are important. There are few definitions which are very important when you are talking about the genetics. So there are driver and clonal driver mutations. What are the driver mutations? So in driver mutations, they defined as their pathogenetic to the particular disease. For example, JAK2 mutation, we call it as a
What
driver
will happen if
mutation.
fallopian tubes of the women are blocked?
It is associated with the MPN phenotype. A large proportion of MPN patients carry mutation solely in 1 in 3 disease like driver genes, that is JAK2, KLR, or MPL. These 3 mutations in MPNs, these are called the driver mutations. The clonal driver mutation do not cause the MPN phenotype. What are the clonal driver mutations? The mutations other than the driver mutation like JAK2, KLR, or MPL, we call it as a clonal driver mutation. Why the clonal? These clonal mutation present in very low number. So there may be alterations or mutations, the variation in the gene that may not be causing the MPN phenotype. The modified the disease driver mutation, as I said, this modify the phenotype. If they are combined with the one of the means other genes, the severity differs. That is called the clonal driver genes. The most frequently mutated in MPN, the clonal driver mutations are TT2, DNM, T3A, and SXL1 and EZH2. These mutations also seen in myelodysplastic syndrome. When these are seen in the MPN, but they are not presenting with the myelodysplastic syndrome presentation. So the main phenotype causing is JAK2 mutation. Along with the JAK2 mutations, if they are the alteration in the sequences or gene, so that also means causing the MPN presentation. The MPN disease driver mutation in particular JAK2 mutation can also be clonal driver. So the studies says that JAK2 is a driver mutation. It is a force for to develop MPN. But again, the study says that this is a clonal driver mutation. Means it plays an important role, not only somatic mutation, it is a germline mutations. Or there may be in JAK2 gene, there may be variation in the other loci. So when whole genome sequencing, whole exome sequencing, recently we talk a lot about these. These identify several variants, not the driver mutation. We call those are variants of unknown significance. VUS, shortly we call. So I'm working on NGS. We get the huge data. We analyze the data. Then some of the mutations are variation. I don't say the mutations. Some of the variations I identify.
What
These
does the embryo develop,
associated
sir?
with some cancerous
Later,
pathways.
the embryo develops
So
until it is
we
ready
take that,
to born
but
in
we don't know
human
their
beings.
function. So variant of
ఎక్కడ ఉంటుందిరా బయటకు
unknown
వచ్చినంత వరకు కూడా
significant, we
embryo
call it as. For
అదే ఎక్కడ
VUS, what we have to do? So functional studies.
పిచ్చి కదవా
Functional studies are very important to
దాని
make
పేరేంటి
them as a pathogenic
ట్యూబ్ అవరియా యుట్రస్ రా
sequences. So the
ఎందులో
several
ఉంటది
variants we come across during the next generation sequencing. So those variants should be studied functionally to associate with any disease, particularly in MPN. So these are the genes list. You can see the JOC2, MPL, and KLR. These are the driver mutations. So several
Advantages of
other
cloning
genes which are
అవన్నీ చెప్పు.
seen in the AML, MDS diseases also. So they are also found in the MPN disease. So what is the genetic basis? So if you see the
పిచ్చబడుకు తినేస్తున్నాడు.
clonal evolution in general, this is
ఇలా
a
ఎవరైనా
general
చదువుతాడ్రా?
hematopoiesis. So there are two daughter cells, for example, JAK2 is formed, they multiply and they give rise to the mutant cells in the blood. So this is a general a timeline. This may takes a long time also, several years also to develop the clone. So this is what the genetic, this is a general model. So clonal hematopoiesis, one of the important is clonal hematopoiesis of indeterminate potential chip, nowadays we call, and the evolution of MPN. The chip potentially pre-malignant in individuals without a hematological malignancy. So this clone may be present in the small fraction, so that it is in the pre-malignancy condition. So in the expansion, they may develop the clone mutant, means the cancerous clone. Most frequently found markers in chip also represents mutation in known cancer associated genes, DNM, T3, and these are the MDS generally we see. The threshold for chipset at variant allele fraction, that is 2%. This is also very important. In chip, when you see the allele frequency, there are different percentage of frequency abnormal variants we observe. So more than 2%, the allele fraction or allele frequency, we consider it as a clone evolving. The measured percent of allele frequency is influenced by the source of the cells. This is very important. So this observation, whether it is a somatic mutation or it is a germline. So to decide the source of the cells also important. The fibroblasts are a good example. You can differentiate the somatic mutation and germline mutation. Some studies, some researcher, they take the buccal smear also, but there is always contamination with the leukocytes. So there may be a chance of the the germline in that cells. So the appropriate selection of the tissue to confirm the allele frequency is very important. 4% of peripheral blood cells carry heterozygous mutation. for the predisposition have been identified in only few cases. There are few genes, how these are inherited. Maybe somatically they are originated and germinally they have transmitted and spreading in the population. So what are the determining factors in the mutational landscape of MPN? A diagnosis and during follow-up. Detection of large number of additional gene mutations in MPN and median number of somatic mutations by whole exome sequencing in PV and ET is 6.5 and 13 per patient respectively. Few mutations acquired during the follow-up. So if the treatment is not properly given, a disease diagnosis delayed. So during follow-up, several other mutations also develop. So the challenges in differentiating in the somatic and germline origin mutations. This is very important in the management aspect. Functional consequences or functionality is silent. When functional studies are not showing any abnormal of expression like proteins and all, then again it is a question mark. Mutations with means variant allele fraction is 50%. You can say this is a germline. So large data we receive from the sequencing that is the next generation sequencing. So if you go through the data, there are 2% and 4%, 5%, 10% and all. When we identify the 50%, you can say it is a means a germline origin. And to confirm this variant, we cannot say it is a mutations. After functional studies only we can say these are the mutations. The functional assays are essential to prove that there is an abnormal expression of the proteins. The chromosomal aberrations, when I am reviewing the literature, there are only few chromosomal aberrations have been reported in the MPN cases. But surprisingly, one study, they reviewed comprehensively and said 9/8/2013 frequent in MPN. So we have studied large cohort of MPN, but we have not identified any chromosome aberrations. But further, we have attempted with the comparative genomic hybridization, there are any losses, gains, loss of heterozygosity. There is a very interesting unpublished data we have generated. There are some loci are associated with the MPN presentations. So there are some variations or sequence alterations about 20 to 30% outside the hotspot mutation. For example, JAK2, there is a V6 is a hotspot mutations. So other than V6, there are other losses also. There is a sequence alterations. These also what is the role and what are the functionality thus need to be studied in every case. Additional genes should be sequenced in suspected hereditary erythrocytosis and thrombocytosis. This is also very interesting research area that it may not be MPN, but erythrocytosis you can see. So there are any genes or variation associated with with the hereditary of this disease. There is a very interesting reviews in this area, so one can read this hereditary erythrocytosis. So what are the relevance of gene mutation for prognostic stratification? Disease driver mutation, as we said, this is very important in the prognosis and overall survival particularly. So if you see the KLR mutations in our data also, other studies also, they are showing good prognosis and triple negative PMF least favorable outcome. This is also one of the area. All mutations you have studied driver mutations and you are in dilemma. They are presenting with the MPN. There is no mutation. What is the molecular mechanism? These are called the triple negative myelofibrosis or myeloproliferative neoplasms. So what is the molecular mechanism or molecular function in this triple negative patients? Why we call it a triple negative patients? Because their mutations are absent in major three genes. So these are triple negative genes. Sorry, triple negative myelo proliferative neoplasms. So additional genes we need to see, or additional loci we have to check whether there are any other loci other than the hotspots are involved. The presence of mutation in one of 18 genes, when we see the in the MPN diseases, chromatin or splicing regions, short survival in ET and PV and progression to ML. So we cannot ignore the additional mutation. You can follow up this whether they are influencing the short survival or how they are playing an important role. That is very important. There are high risk molecular mutation that is called high molecular risk mutations. This is very well as established in other neoplasms like myelodysplastic syndrome and acute myeloid leukemia. So these are also very high risk in myeloproliferative neoplasm. These are the ASXL1, IDH1, IDH2, and SRSF2. But some studies, the splicing factor mutations like SRSF2 has no role in development of MPN. But the other literature says, recently published data in Blood Journal, they say that they have also role in the MPN development, particularly in overall survival. Chromosomal aberrations, there is not much data, but the literature says they have the adverse prognosis, bad prognosis. So one has to develop systematic study in this area. Not many people worked cytogenetic in the myeloproliferative neoplasm. I suggest, I feel comparative genomic hybridization to identify the losses gains, particularly loss of heterozygous, is very important to support this statement. The mutations of NRAS, KRAS, CBLTP3, they are well known for other neoplasm as a high risk mutation. In this also, if additionally they are identified, they have the worst prognosis. So that disease driver mutations in first event, JAK2 can be identified. Genotyping of hematopoietic colonies from single HSC or progenitor is very important. So when you are conducting the research and all, what is a single cell is doing in MPN, whether they are causing any mutation or expression or pathways disturbing, the single cell DNA sequencing is upcoming technology to identify single cell level and understanding the pathways in the disease development. Now the people are researcher focusing on SNPs in various diseases and also in MPN. A haplotype located in the JAK2 gene contributes to a 2 to 6 time increased risk. So this is other than the JAK2 means the loci. If there is any haplotype or SNP change in the nucleotide, single nucleotide base, that is a single nucleotide polymorphism, also causing the means the disease. So there are different genes, SNPs are identified in the NPN, such as TERT, it is a telomere related genes, MECOM, that is bone marrow failure diseases, generally we see, check to generally we see on the cancers. So they are weekly risk of MPNs. So they are not much contributing to the development of the disease. The SNPs may increase the conversion rate by synerging with the driver gene mutations and facilitating the expansion of mutant sequence. Why these SNPs are important? This is the reason. The acquired disease driver mutation JAK2 can be a germline mutations. Many studies are there. Germline can be the means the JAK2 maybe in the in other diseases. Individual variability of risk of chip. The when you see the clonal hematopoiesis, this varies the patient to patient or individual. So these are the just data. These are pan cancer data. How they are showing that how the mutations are together and how that they what is the risk there. There is a if there are two mutation, there is a positive association. Then if we are coming down, there is a not much positive association. So various genes, variation combinations, how they are means influencing on the disease. This is well described in one study. So when you are talking about the myelodysplastic syndrome and myeloproliferative neoplasm, the leukemia transformation is well discussed. So MDS also, it's a pre-leukemia condition. So we also talk about how they are means transforming into the leukemias like AML and very severe AML diseases. So this leukemia transformation also seen in MPN cases. Transformation to secondary AML is rare in MPN. Cumulative incidental of leukemia transformation in PMF is 20%. ET and PV very less, that is 2.5%. The mutational profile post-MPN AML differs from de novo AML. So these are the different diseases. MPN AML are their different profile compared to the standard AML. The AML origin can be common mutated ancestry or true biclonal disease also seen in MPN. P53 is the most frequent mutated gene post MPN AML. So P53 is known for all the leukemias, but the post MPN, this also causing the AML like disease in 50% of the PV or ET cases after several years diagnosis, maybe the average 8 years. Other mutations not identified at chronic phase. So MPNs clinically needs oriented current therapy. There are means disease means symptom wise there are many means the therapies are available. I am not going to into the details. So this I am skipping. This is one jump. So recently there are JAK2 inhibitors for myelofibrosis. These are the developments. Lastly, in 2022, that is a Pactino is FDA approved drug is there. This is working better in MPNK diseases. So there is a risk stratification in PV, that is low risk and high risk always more than advanced age group patients. So these are the various symptoms in essential thrombocythemia. What model to be used and when? This is one model for the risk stratification and treatment goals. So there are different models are used. Survival for myelofibrosis is known for ruxolitinib. And these are the some of the how the disease is managed and effect of rusfertide and reducing phlebotomy frequency. So some data is given. In conclusion, so what I'm not focusing on the treatment part. First, we should know the what of the driver mutation, what are the clonal mutation or passenger mutations, how the disease is progressing. So for that, next generation sequencing is very important. So this capture the information. This information can be used for the management of the proper management of the disease. So thank you. So if there are any questions, please.
Thank you, sir, for your lucid presentation. Any questions from audience? If questions are not there from audience, sir, I have few questions from my side.
Yeah.
Okay, sir. Sir, JAK2 mutations is emphasized in the polycythemia vera and all those things. But
Yes.
coming to the management, they are not the first line drugs used for the treatment plan, in the treatment plan. What is the reason for that? So we are going to use hydroxyurea, we're going to plan phlebotomy, we're going to use aspirin, but JAK2 inhibitors are not the first line drugs in management of polycythemia vera.
Yeah, there are lots of literature on that. Maybe for the management, the initial therapy, whatever available given, the inhibitors later this comes. I think I am also not clear with the treatment part. Okay.
Okay, sir. Okay. So another question I have regarding the essential thrombocythemias. Most of the times, physicians and pathologists are saying thrombocytosis in most of the cases of iron deficiency anemia. When we are supposed to suspect essential thrombocythemia in those patients?
So there are signs and symptoms of this essential thrombocythemia. So that is the means a very basic information for diagnosis. But there are several laboratory investigations that has to be ruled out for proper diagnosis of the.
Okay, sir. Thank you, sir. Okay, sir.
Thank you.
I request our chairpersons, Dr. K. Marjati, sir, to honor our speaker for his timely contribution. Now I would like to call upon Dr. Josna ma'am, Organizing Secretary, Head of the Pathology Department, AIMS Mangalagiri, to felicitate the chairpersons. Thank you, sir, and thank you, ma'am. Up next, we get ready to listen diagnostic updates and molecular advances in renal tumors. To take over this session, I would like to invite our chairperson, Dr. Kumba Nagalakshmi, ma'am, Senior Consultant Pathology and Medical Superintendent, BHEL Power Sector, Southern Region, Chennai. Ma'am has multiple publications in national and international journals and recipient of several awards with many more achievements. Welcome to the stage, ma'am. I feel privileged to invite our next chairperson, Dr. Bhavana Gandhi, ma'am, Professor, Department of Pathology, Narayana Medical College, Nellore, Andhra Pradesh. Ma'am has about 60 publications in national and international journals. She has received awards such as Gane Subbalakshmi Young Scientist Award at IAPM Andhra Pradesh State Conference conducted by Guntur Medical College in 2016 and also received second prize in the same category in the State Conference conducted by MIMS Vijayanagaram in 2018. Her area of interest are cytopathology and histopathology. Welcome, ma'am. Request our chairpersons to take over the session and introduce about the next passionate speaker.
అమ్మ ఏగుచ్చుకుంటున్నా అదే అడుగుతాడు తేవలేదు కదా.
Good afternoon. I would like, first of all, thank the organizers. And I am reading out speaker Dr. Santosh Menon. He is professor of pathology and uro-oncology disease management group and Department of Pathology, Tata Memorial Center, Mumbai. And he is having 19 years of experience on oncopathology, uro-oncopathology, gynec oncopathology and immunohistochemistry. And his major achievements, editorial board of WHO classification of male GU tumors 2021 fifth series, Leon WHO and Secretary Society of EU Pathologist of India, Secretary Urological Cancers Foundation, and external reviewer for ESGO and ISTRO ESP document on cervical cancer management guidelines, external reviewer for quality indicators of cervical cancer surgery, ESGO ISTRO ESP document, and external reviewer of ESGO endometrial carcinoma surgery quality indicators, and nominated member for Genitourinary Pathology Society USA and more than 75 publications, and ex-sub-editor Indian Journal of Cancer, and reviewer of several international journals, including Human Pathology, BMJ case reports, Journal of Ovarian Research, Indian Journal of Urology, and IJMR. Thank you, sir. And you can proceed.
Thank you, Chair.
ఇప్పుడు నీ ఇంటి దగ్గరికి వెళ్ళాలిగా.
Thank you, chairpersons, for that very kind introduction. At the outset, I would like to thank Dr. Jyotsna and Jyoti Verma and her wonderful department people who have invited me here to this beautiful campus. It's a very uncanny topic on a Sunday afternoon, and there is an India-South Africa match to happen, and people are busy program for that. But yes, the topic today is renal cancer pathology. I have 45 minutes, and I promise you I won't take 45 minutes, definitely. So I have ample time, and there are certain declarations I would like to make. I declare I have 123 slides, but I hope I'm not going to bore you with this, because most are images and they're for PG students. The topic given to me is a bit theoretical, but probably we may want to discuss something which is more practical in day-to-day practice, so that we go home with some thought process on how to tackle these tumors when we come across. And you may stop me anywhere. You can raise your hands or you can stop me and you can ask questions. And if you don't ask, I will stop and ask you questions. So that's going to be a program. It's going to be a discussion Sunday afternoon. Let it not be a lecture and let it be a discussion. Let us have some kind of a dialogue. So with that, we go to that some theoretical aspects. We know that WHO 2022 has made a world of a difference in renal cancers. You all have gone through the text and the classification, the different categories which have come up. This is going to increase in the coming years. So the next series will have more entities. The next is going to have more entities. Thankfully, not as much as we have in hematology. I think hematology has gone really over the top with molecular, but we have to understand that as more and more molecular work on all tumors is going to happen, we are going to have to deal with this in our situation. The major emphasis in all is histopathology. Again, the WHO emphasizes that we have to look at the HND, make a working diagnosis, then use our ancillary techniques like IHC and molecular to get a diagnosis. And the main idea of this presentation is, do we even really need to get to the bottom of these things? Is it practical? Does the clinician really need to know those 1,000 names of tumors which we as pathologists want to tell? So that practicality, let us see if we can reach somewhere. So in keeping with other volumes and other systems, the tumors of the GU systems, which are mesenchymal or neuroendocrine, are treated in separate categories and separate chapters. So say if you have a neuroendocrine tumor of prostate or of kidney or a bladder, they are all grouped under a chapter of neuroendocrine headings. So if you look at renal cancers, the earliest classification was the Heidelberg classification. Then we had the Rochester. So there have been several classifications. The easiest and the oldest one was clear cell and a granular cell hypernephroma. That was the oldest one. And we have come a long, long way from the initial classification to make so many different entities in this 2022 book. I think the major, this image is very, very important. And I'm sure even the PG students would recognize. This is a clear cell renal carcinoma. That's a papillary, that typical papillary renal cell carcinoma with a lot of foamy histiocytes in the core. This is a chromophobe. You can make out. This is not working now. This is chromophobe with its binucleation, the nuclear abnormalities, the perinuclear halo, and this is an oncocytoma. So why am I showing you this? That's because 80 to 90% of renal tumors will still belong to this category. So tomorrow when you go and see a renal cancer case under the microscope, even before you put the slide on your microscope, you can be pretty sure you're going to have these 4 entities on your table. Because these are the common things are always common. They cannot become uncommon tomorrow. You understand? We may try to split up these oncocytic tumors and chromophobe into different categories or molecular, but the basic remains the same. 90% of your tumors, even tomorrow when you see, are going to belong to this category. So what are we going to do? We are going to probably learn about the less 10% which have come up in recent. So this is the 2004 and classification, just to begin with. Lot of entities, again, new names came up during that time. The MITF family translocation RCCs, the carcinoma associated with neuroblastoma, which is no more an entity. It was there in 2004. Hello. And then there were several provisional and proposed entities about which the evidence was not there. And you can see that there were certain emerging entities like the thyroid-like follicular and the succinate hydrogenase deficient RCC, which have now become entities because we have got evidence to say that this entity is a separate entity, and that's why it needs a separate chapter. But 10 years before, it was an emerging entity. There was more evidence to be generated. Similarly, we will have more and more entities when we get more evidence to say that, okay, this tumor looks different, has got a different molecule. So this was what came in the last WHO is the mucinous tubular spindle, very tubular kind of pattern. The tubules get compressed by the mucinous stroma to become spindly, and you have this mucinous background, and you call it a mucinous tubular spindle cell carcinoma. Again, these can have different nuclear features, but generally, you have to take good sampling to find these mucinous areas to call it a mucinous tubular spindle cell carcinoma. The tubulocystic, very, very characteristic under the low power. You have got this very spongy bubble paper kind of appearance, so bubble appearance under the microscope. So it's a tubulocystic carcinoma. Generally, the nuclear grade is high in these tumors. They have got this hobnail kind of pattern around the cyst. So these are different entities which were recognized in the previous WHO classification. So there are certain pathology pearls which have been put up by WHO that there are several new entities which look like clear cell. You understand? Your first and foremost thought process is this renal cancer a clear cell? But there are several tumors which may be looking a little eosinophilic. What we used to call as granular clear cell RCC. So clear cell may not be always be clear. You understand? As the grade of the tumor in clear cell increases, the clear cell cytoplasm decreases. It becomes more eosinophilic rhabdoid. And so we have to be aware that there can be a lot of variations in the same common entity which we have. The spectrum of eosinophilic oncocytic papillary patterned RCCs is completely blown out of proportion. So that is what has happened majorly in the current RCC classification. The eosinophilic tumors, the oncocytic tumors, the papillary tumors, which we see commonly, are become very, very mixed up and have caused a lot of problems. But all of this towards better prognostication. Once we start delineating these tumors, we will understand that how one behaves differently from the others, how we can target some specific markers, how we can target and give different therapies to these tumors. So the idea of classification is not for fun. At the end of the day, there is a patient who gets treated differently in some of these cases. So this is the WHO classification, a long list. I'm not going to cover all of these. I'm going to highlight a few of them. This was what the WHO did in 2020 August during the pandemic. We had a good time online with this program of coming out with the book. And then there are certain emerging renal entities. So look at the thyroid-like follicular RCC. It is still emerging. There is still not enough data to call it as a separate entity. It is still emerging now, even after 10 years, 15 years of its description. It is still emerging, but not an entity as yet. So I'll say RCC, if you follow MasterChef Australia and MasterChef India, there is something called blind tasting. You put a blindfold and you eat something and you say, okay, it's got some ginger and it's got some salt and some pepper. And so that's what RCC has become. You look at a slide, you feel you know it, and then you start thinking, oh God, it looks different. Then you do a couple of ICs, it looks even more different. And it becomes more and more confusing as it goes. So it's kind of a blind tasting which you are going for in an RCC. So just for awareness, all that glitters is not gold in RCCs. Clear cells may be seen in a spectrum of tumors. The pinks, eosinophilic RCCs are expanding links. And thankfully, the bottom line is the management currently is still very limited. So you have a clear cell RCC managed in a certain way, non-clears managed in a certain type of a way. But time is going to come in the next decade when the clinician is going to call you and tell you, please tell me what exactly this is. Because we have a specific therapy for certain tumors. And that's going to happen and we need to be ready for that. So why the category of molecularly defined tumors came up? Because they can be only confirmatively be diagnosed by molecular testing. So you have a TFE3 associated RC or TFE3. You can do an IHC. But for confirmation and to categorically call it a TFE, you have to do a FISH test or a molecular PCR testing to call them. So this category means that certain entities cannot be diagnosed without molecular. You may have a screening test in IHC, but for confirmation and for genetic testing, these need to go for molecular. So these are the list of molecular defined tumors. We will take on one by one all this. The new entrant in the WHO RCC is a eosinophilic solid cystic RCC. So this was described in 2016 by Tripkov et al. From University of Calgary. They said this occurs only in females. So when they described 16 cases in females, which were solid and cystic. Under the microscope, they look very eosinophilic oncocytic. They have solid areas, cystic areas. And the characteristic IHC, they said, is CK20 positive. So you don't have tumors in, you don't even include CK20 in the panel of RCCs. But they did and found that there is a certain set of tumors which have oncocytic and eosinophilic appearance. They are solid cystic, occur generally in young adult females, and they are CK20 positive. So they called this name as eosinophilic solid cystic RCC. So this is how they look. So even in this picture, you can make out that there are some clear cells. You see that? There are some clear cells here. And you might confuse them with something. But there are most of them are eosinophilic. If you look at high power, they have got very granular cytoplasm. It's called the basophilic stippling or the LD body-like appearance. Everybody has seen LD bodies. So something which looks like LD body-like stippling in the cytoplasm, a basophilic bluish stippling, you should think of an eosinophilic solid cystic RCC. And if you do a cytokeratin 20, if it turns out to be positive, that would be a classical case of eosinophilic solid cystic RCC. So something which looks indolent, low grade, not very high grade, has got eosinophilic cytoplasm, but when you look carefully, a basophilic stippling kind of appearance, you do a CK20, if it comes positive, you are happy and you are confident to call it eosinophilic solid cystic RCC. So this was this case, Amakar was positive, 7 was negative, and CK20, look at this, it lights up. CK20 strongly and diffusely positive. So this was awesome. Coming to papillary conundrum, there is a papillary. So till the last WHO, we had papillary type 1 and papillary type 2 RCC. You understand? Now papillary type 1 and type 2 are out. You just call it papillary RCC, which is the old papillary type 1. So it's the classical blue looking papillae, nice, beautiful, benign looking cells, not very highly malignant looking cells, no nucleoli, core showing foamy histocyte, which you classically see in papillary RCC. That's called now papillary RCC. The type 2, we will come to that later. So there is no type 1 and type 2 RCC. So you don't write your report as this is type 1 papillary RCC, this is type 2. You don't write that in your report anymore. There are several entities. I will not go into details, but this is from a publication which have Warthin-like and biphasic type of papillary and papillary RCC with reverse polarization. So these will get delineated and refined in the next WHO. So it is now very well understood that there is no type 2 papillary RCC. It's a histology. So there is a papillary type 2 histology. You have papillae. The papillae have stratified tumor cells, nuclei. The nuclei look higher grade. They have nucleoli. They have more eosinophilic cytoplasm. They don't look like the classical, what we used to call as type 1 papillary. So any papillary looking RCC, which has got nucleoli, a lot of cytoplasm, stratified nuclei sitting on the papillae, you are dealing with a type 2 histology. And type 2 histology encompasses several entities. So once you have seen the slide and you say, okay, this looks like papillary type 2 histology, you should think that it belongs to these categories. All of these, almost all of these, or not all of these, may belong to that type 2 histology. So then you need an armamentarium of IHC or molecular testing to finally arrive at a diagnosis. But it is fair enough if you don't have IHC, if you don't have molecular, please put down on your bottom line impression that this is a type 2 histology RCC. You understand? That is fair enough to put in the report. The clinician should understand it is not the old type 1 typically low grade indolent RCC. It is an aggressive, because most of this list of molecular RCCs are aggressive. So if you look at TFE3, TFEB, the fumarate hydratase, the ALK, all of them are very, very aggressive RCCs. So once you write a bottom line of type 2 histology, you are probably telling the clinician, this tumor is going to come back, this is going to be aggressive. And that information is important for management of the patient, for the follow-up of the patient. ALK arrange RCC, very, very rare. I've seen only single case of ALK RCC, very, very heterogeneous kind of morphology. So if you have an RCC under the microscope, which has got variable morphology, papillary in one area, little clear area, rhabdoid looking cells in another area, you should think in your mind, probably it might be an ALK associated RCC. So again, you have to diagnose it by using the D5F3 clone of which you use in the lung ALK, and you have to do ALK FISH to prove that this is an ALK associated RCC. So this was the case which we had. You can see that generally you would have a lot of mucin in these tumors. So this mucinous material with vacuolation, rhabdoid looking cells in a same tumor, when you see, you should start suspecting ALK associated. See again, clear looking cells. Some of the cells look bland, but there is a lot of mucin, there is a lot of stroma in this. Same tumor also had thyroid-like areas. So different kind of areas in a given tumor, you should think that you are probably dealing with ALK-associated RCC or some other kind of RCC, not the run-of-the-mill RCCs. SMARC-B1 deficient. We classically have learned that medullary carcinoma of kidney is deficient in INI1. So SMARC-B1 is nothing but INI1. INI1 IHC generally most of the departments have. So if you suspect something like looking like a collecting duct carcinoma and you do an INI1, if INI1 is deficient and lost, then you are probably dealing with a medullary RCC. But mind you, many high-grade RCC, including clear cell RCCs, when they become very high-grade, they may lose INI1. So INI1 is not a sanctum sanctorum equated to medullary. It may be lost in many high-grade RCCs also. Coming to the MITF, this is very important because 70 to 80% of pediatric RCCs belong to this category. So if you have a 25-year-old patient, 18-year-old patient, 23-year-old patient, 35-year-old patient, the first thought process should be, is it an MITF, TFE3 or a TFEB RCC? Because these are the commonest ones which occur in pediatric age group or a young adult. So that's the thought. So there are certain clinical, molecular, morphological features which may drive you to some diagnosis. So that's what I'm trying to tell you. So these are generally aggressive types. In pediatric, certain pediatric patients, they may have indolent course, but generally when they present, they will present with nodal mets and distant mets. But they may have an indolent course in pediatric age group. But in adult, when they present these translocation RCCs, they usually have a very aggressive course. I will not again go into the details. So this is a core biopsy. Look at this. This is a core biopsy from a young patient. Looks so much clear. You would immediately jump and call this a clear cell carcinoma. You understand? You would call it a conventional. But keep in mind the age of the patient. It's 23, 25. You do a TFE3 and TFE3 will come strongly positive in this. But mind you, in our practice, we have done several cases of TFE3. IHC doesn't correlate many times with FISH. So that's why you need to do FISH in these cases to confirm your diagnosis. Again, a translocation RCC looking very much like a conventional clear cell RCC. And that's the mistake which we made become. This is the FISH which shows the break apart FISH of TFE3. And now we have done in almost 70-80 cases we have of TFE3 RCCs. So like I said, TFE3 are maybe indolent in children, but when it comes to adult, they have a very aggressive course. TFEB RCCs are recently described. Again, WHO 22 has recognized this for the first time. There are two types of TFE. They either rearrange or amplified. Amplified gene of TFEB3, TFEB is an aggressive tumor occurring in adults. And TFEB rearranged occurs in children, but has more indolent course. So if you see this basement membrane kind like material, this kind of material in the center of these. So you see these cells have very little cytoplasm, whereas the other cells have more cytoplasm. So when there is a mixture of cells with less cytoplasm and more cytoplasm, along with this basement kind of material in bed, eosinophilic material, you should think of a TFEB renal cancer. So that's an important clue on morphology to pick this up. Again, you can have these papillae kind of appearance, but again, look at this. These nuclei have nucleoli, more eosinophilic cytoplasm. They don't classically look like a type 1 papillary RC, what we used to call as type 1. FH deficient RCC, some pictures to show that very papillary and cystic. So if you have a lot of papillary type 2 histology, again, with associated with collecting duct-like histology, very high-grade looking tumor, that's when you start thinking of a FH deficient RCC. Look at this. I think this is a very classical feature. You have large cyst, and within the cyst, you have a lot of papillary growth. That's a very important clue to pick up FH deficient RCC. And obviously, you have very, very prominent nucleoli. The nucleoli are so prominent, they are called a CMV inclusion-like nucleoli. So something which looks like CMV inclusion and is looking at you or staring at you, you should start thinking of FH deficient RCC. So that's when you do a fumarate hydratase staining, and loss of FH will help you in sort of sifting out this and calling this as FH deficient RCC. There are other IHCs which I'm not going into detail, but for confirmation, it is important that you do a molecular testing in these cases. Why should you do molecular testing? Because this may be a germline mutation and the whole family might be at risk of developing. So as a pathologist, you might be the first person to tell them this is FH deficient RCC. And then the whole family may need a germline testing. The whole family is at risk of getting renal cancers, leiomyomas, skin cutaneous leiomyomas. So those are the risk factors. So the role of pathologists in genetic disease is also increasing in that way. Some other recent entity is described as a clear cell papillary tumor. So in the last WHO, this was called as real clear cell papillary carcinoma. So you understand, it's a very confusing term, clear cell papillary carcinoma. So now they have changed it to tumor because most of them are indolent. What is the classic morphological feature? The nuclei are towards the lumen. You see this? They are regimented towards the lumen, not towards the basement membrane. So very low grade nuclei, grade 1 ISUP nuclei, the nuclei are towards the lumen, not towards the base membrane. That's a classical feature of this clear cell papillary tumor. Is it important to distinguish this? The answer is a big yes, because this is a benign tumor. You understand? None of the clear cell papillary renal tumor have ever metastasized, documented. But you may end up calling this conventional renal cell carcinoma. You understand? It's all clear. So you may say it's a ISUP grade 1 conventional renal cell carcinoma, which is a malignant tumor and highly malignant tumor. You understand? So it is important. So there are certain IHCs like CA9 and CD10 and all that which you can do to delineate. But first and foremost, pick up this morphology of regimented nuclei towards the lumen of these tumors of a low grade tumor. I think I'll not go into treatment. This is the SDHP deficient. Again, very classical picture of flocculent cytoplasm. Look at this, very, very flocculent. It's almost, you have that cotton candy kind of appearance, cotton candy in the cytoplasm. If you see something like a cotton candy in the cytoplasm of cells, but again, mind you, you have some clear cells that mix with this. So you may again mistake them for clear cell carcinomas. So you have to keep some features in mind. And classically, again, you have to show the absence of SDHP staining in these tumors. Any questions up to now? Because I need to break the monotony here. Any questions? Because again, chromophobe, and this is also very complicated. Questions? No questions? We use them interchangeably, but they are generally categorized as MITF. But the WHO now clearly says TFE3 and TFEB tumors. They are separate chapters actually, TFE3, TFEB. Many people use them interchangeably with translocation associated RCCs. Many clinicians now know they are translocation RCCs. And MITF is a difficult term for the clinicians to remember. So they don't generally understand MITF word. Yes. Yes. So these translocation tumors, they occur in previous patients who have received chemotherapy also. So if a child has had a malignancy in childhood, he has received chemotherapy for any malignancy, and they develop a renal tumor, it's likely to be translocation. But generally, the morphology would be like a clear or a papillary and that kind of admits.
But sometimes it may give mixed pattern in translocation, papillary, solid, or a clear cell. So in that case, morphologically, it's very difficult to say it is a
I think
genetical.
age becomes a very, very important feature. Age and previous history of chemotherapy would be a very important point to pick up translocation.
Okay, history is very important. Previously, whether it is.
And obviously, confirmation will need an IHC in fish. Without that, you cannot.
Okay. Because we are facing morphologically, so we give.
Yes, I can understand.
Thank you.
So next category is the chromophobe oncocytic. Again, a big conundrum. You have an oncocytoma, everybody diagnoses oncocytoma. You have a chromophobe, everybody can diagnose chromophobe. But now you have some tumors which have mixed features. They were called as hybrid oncocytic tumors. So you have some areas which resemble oncocytoma. There are certain areas which are mixed areas of oncocytoma with chromophobe. They are put under category of other oncocytic tumors. Some of these mixed tumors with oncocytic hybrid features have the Burt-Hogg-Dubs syndromes. So you have to do a follicle and gene mutation in those cases. But then there are certain other tumors like low-grade oncocytic tumors. So again, this is an emerging entity, not an entity. This looks very, very bland oncocytic. But when you do an IHC, it will be diffusely CK7 positive and c-KIT negative. So that is a low-grade oncocytic tumor because oncocytoma are never CK7 diffuse positive. And a chromophobe has to have the classical nuclear features of chromophobe to call it chromophobe. So something which is low-grade oncocytic shows diffuse CK7 positive, does not have the nuclear features of chromophobe, and does not show c-KIT positive is a low-grade oncocytic tumor. So we had a couple of cases, and this is from one of our own publications. Thyroid like RCC, again an emerging entity, very, very classical. I've seen only one single case which is completely looking thyroid. Obviously, you have to rule out a metastasis from thyroid first and foremost. So you do a TTF1 on this and they are negative. This was that case which had sarcomatoid areas also. So just a summary before we go into a couple of cases. The first question when you look at an RCC is it a conventional RCC? The first question you need to answer, the first question the clinician needs to know, are you dealing with a conventional RCC? It may look clear, it may not look clear. It may look papillary, it may have papillae, it may have eosinophilic cells. But is it still a conventional RCC? So you look for classical features of blood lakes, vascular lakes, large islands, varying grades within the same tumor. It's a very, very subtle but definite sign that you are probably dealing with a conventional RCC. Conventional RCC can have a grade 1 area, and within that large grade 1 area, in the center of it, you may have completely grade 4 areas with rhabdoid cells. So that happens in conventional. It doesn't happen generally in any other RCCs. So that's a certain subtle clue. CA9 is the best stain. You do a CA9 staining, if it comes diffusely positive, you are probably dealing with a conventional RCC. So CA9 is a must stain for RCC. People who practice urology, uropathology, and a lot of renal tumors have to have a CA9 stain. Next question is the tumor papillary in architecture? Does it have clear or eosinophilic cells? If it has clear cells, is it a clear cell papillary tumor? Because that's a benign tumor. You have to sift out a benign tumor from a malignant tumor. So if you have papillary tumor, which is all clear, is it grade 1 nuclei? Are the nuclei towards the lumen? That is very, very important because that is a clear cell papillary tumor, possibly it's a benign tumor. Tumor is papillary in architecture. There are a few eosinophil and few admixed clear areas. Very, very common scenario. We get stuck with this every day. Is it a papillary RCC, which we used to call it type 1? Is it a translocation RCC or is it something else? Then comes the biggest question. Is it a type 2 papillary RCC? Is it stratified? Do they have nucleoli? Are the papillae clearly visible? Do they have a lot of eosinophilic cytoplasm? That's the type 2 papillary histology. And a type 2 papillary histology can be any of these. It can be FH deficient RCC, it can be ALK RCC, it can be TFE3 RCC, it can be ESK RCC, anything can be this. You will have to do the IHCs and molecular. Unfortunately, that's the current status of RCC if you really want to delay. Otherwise, you just put them in your bottom line. This is not a clear RCC. This is not a complete papillary RCC. This is a type 2 histology. That's the bottom line of your report. And then you have the oncocytic. We have just discussed about the oncocytic tumors. So I'll just show you a couple of cases and let's see if you can guess what is happening. So this was a 73-year-old male with hematuria of short duration, and there was a large mass on CCT with seen arising from the posterior cortical surface of the kidney. They have a suspicious tumor thrombus in the right renal vein, which is a very good sign to say that probably this is RCC, not urothelial cancer. And there are multiple enlarged lymph nodes. So it was a metastatic RCC at presentation as per radiology and clinically. This is the gross picture. You can see that there are a lot of septae and fibrous septae between this tumor, but it looks a little mahogany brownish kind of appearance in this tumor. So low power picture, even at this low power, you can probably say this doesn't look like a conventional RCC. It's got a very pink appearance. There are some floating papillae. This is definitely looks papillary. So everybody sitting here would agree that this at least looks the papillary, going the papillary way, not a clear way. Then you start looking at higher power. You look at the cell, very vesicular nuclei, prominent nucleoli. The nucleoli are actually looking at you. Look at this. Look at the nucleoli. And look at the papillae. They are multi-stratified. So this is a type 2 histology. This is a classical type 2 histology. You understand? Eosinophilic cytoplasm, prominent nucleoli, stratified nuclei, and looking very high grade under the microscope. This is type 2. So once you see type 2, you have to start thinking of ALK, FH, TFE3, TFEB, all those findings. And you have to do your IHC. CMV like nucleoli. Everybody agrees? CMV like. Very, very CMV like inclusions in the nuclei. See this, look at this. Perinucleolar halo also. So that's a classical, generally a classical feature described in FH deficient RCCs. So CK7 was focally positive, but very strong and focal positive. Again, you can see that cytokeratin 7 is positive. You can see the control that in the normal ductules. CK20 turned out to be very diffuse positive. This is CK20. So CK20 is a marker for eosinophilic solid cystic RCC. FH was retained. So this is FH staining. There is no loss of FH. So this, we thought it was FH RCC, but finally it came at 20 positive. It looked very high grade. Generally, SCRCCs, generally they are indolent. They don't look high, but there are descriptions of high grade SCRCCs. So this is one of those cases. My point is, when you are doing IHCs, it's better to do a whole panel. There is no point doing one IHC. You understand? Because single IHC, reliability of single IHC in RCC, especially type 2 RCC, is currently very, very dicey. HMB45 was also focally positive. So many of these have these melanocytic markers also. Another case, renal mass nephrectomy with nodal mets, 33-year-old male patient. So this is the histology. You have got eosinophilic clear both cells. You have got both types of cells. Very, very clearly you can make out. They got a little alveolar kind of pattern. There are definitely clear looking cells, but not that clear looking what you see in a conventional RCC. See this? So the little pattern, admixture of clear and eosinophilic RCCs, clear and eosinophilic cells. And one stain came diffusely positive. This is TFE3. See this? So my point is, you will have to do this to pick these up. There is no other way out. So there is no mantra to say that this is. But generally, look at the age of the patient. If it is young patient, you are probably 70% of the time dealing with a translocation of TFE3 RCC. Third case, 41 male patient with mass, renal mass in one kidney and cyst in the coronary. So if you have bilateral kidney masses or bilateral cyst, you are probably dealing with something hereditary. That's a clue to you. So the clinician says there is a mass in one kidney, the other kidney is showing some cyst, which we are not able to categorize. But if there is some bilaterality, start thinking of syndromic associations. That's the clue to it. So this is low power to show the tumor is here, and that's the normal kidney there, and this is the tumor here. Again, at this power, can't make out anything much about this. All looks very oncocytic. So it looks a little eosinophilic oncocytic. I don't think anybody would consider this to be a conventional RCC. But my take for this is, please do a CA9 in this. So begin with a CA9. So that's what the Western world is doing now. On all cases, irrespective of histology, they would end up doing a CA9. You understand? Because they have picked up some cases which don't fit into anything but have turned out to be CA9 diffuse, and they've called it conventional. So the beginning and starting point is here. Here you may skip CA9 sometimes. Look at this morphology. Very, very monomorphic, monotonous cells, and they're looking very bland, but eosinophilic oncocytic kind of appearance. Very, very bland. So this is probably going the oncocytic kind of way, probably that way you might think. And this is a stain which we did. You can see the control in the endothelial cells is positive, and some of the mast cells are also positive. You can see the endothelial cells very nicely positive, but tumor cells are negative. This is a fumarate deficient RCC. So not all fumarate deficient may look very high grade. You understand? There are some low grade looking fumarate deficient. The point I'm trying to show again, you have to have this in your armamentarium. Otherwise, the diagnosis is just a thought process. For confirmation, you have to have IHCs and molecular in these cases. Another case quickly, large renal mass, very, very vacuolated looking tumor. Low power, you might think these are all clear cells. But if you look at it, generally gives an impression of a very pink looking tumor. So pink histology, very vacuolated, bubbly kind of appearance here. And then there are areas which are more solid and looking more oncocytic, more eosinophilic. And look at the cytoplasm. What does the cytoplasm look like? Cotton candy? Looks like cotton candy. Yeah, it's very classical cotton candy kind of appearance here. So this is how it looked like, but other areas were looking very bubbly and vacuolated, absolutely not looking your flocculent or cotton candy-like appearance. So my point is, many of these syndromic tumors like FH, SDHB deficient, they may have variable areas within the tumor. That's a clue that you are probably dealing with a different looking tumor. So the idea is first to pick a different looking tumor. So this is how you start practically looking at the morphology. This was again the same tumor, more tubulocystic kind of appearance. Same tumor having different areas. Start thinking of SDHB, FH, ALK. Those are tumors likely to have variable appearance in the same tumor. That's an important clue to pick up. Some of the areas had very prominent FH like nucleoli. Paxate was positive, very nicely, strongly positive Paxate. SGHB was deficient, very nicely depicted. You can see the internal control in the endothelial cells are granular positive, tumor cells are negative. So this is how it I think I'll end my talk here. I've got good, nice 10 minutes for discussion in this. So this is our Euro DMG. We have a very good time. You can see we are having beer most many of the evenings. But when we sit in the clinics, we do discuss very, very seriously about patient care. And these are very, very pertinent issues. And mind you, in the next decade, pathologists are going to have a very tough time because it won't be enough just to say this is clear versus non-clear. You may have to give them real bottom lines in the next decade because there are going to be therapies tailor-made for different therapies. Currently, FH deficient RCCs have targeted therapies, different target, and they've got good results with it. So as and more you start picking, you will realize that they are probably not as rare as we think. So we thought that they were 5-10%, maybe they are 15-20%, maybe they are 25% of the cancers. Because as and when we start using IHCs and molecular, we will realize that what we used to call rare is probably not rare. I'll end my talk here. Thank you so much for your patience. I would encourage people to ask questions. I've come from far. Please ask questions. Yes, ma'am, please. Sorry. Metanephric. Metanephric adenoma has got a pretty classical appearance. It's got tubules, it's blue-looking tumor. It's got small rounded acinar-like tubules and large tubules can be there. And in the next WHO, you will definitely find that metanephric adenoma is classified as BRAF, V16 mutated tumors, because they mostly carry the BRAF mutations in them. Yeah, but they can look papillary. They can be tough to distinguish from papillary if you don't consider and remember them. Questions, please. Which Tarun sir, which? I told you it doesn't. So currently the clinician in an organ confined kidney tumor, they are going to operate. After they operate, you call it FH deficient. The FH SDH will have a genetic reference and the whole family might need. So you will be the first person to tell them that this is probably a genetic disease. Understand? So there is the importance of pathologists. You are made the first person to tell them. They may consider it, okay, this is RCC. For them, for the surgeon, it's okay. They remove it and they go off. But when you give a report of which, then they call back the patient, they call back, there is a counselor, there is a counseling, there is a hereditary clinic. In a metastatic setting, their main matter is between clear versus non-clear. They just want an answer whether you can distinguish a clear, because clear has got some 10 different therapies at currently. Non-clear, those same therapies are given, but they may not be that effective. So they would just want to know clear versus non-clear. But time is going to come when they're going to tell me, okay, this I'm going to target at the FH with this. I'm going to target SDHB like this. So you have to be specific in that scenario.
We start the show.
Yes.
Thank you.
Yes.
So
like I said, type 2 I told you it can be ALK, FH, ESC. So earlier, Tarun, the IHC panel used to be CK7, CD10, AMACAR. I think we have hardly used, we start in type 2 with a CK20, FH, we do ALK. So this, because the panel has completely changed, TFE3. So those would be included in your HMB45 done in almost all cases now. HMB45 melanocytic. Many of these MITF RCCs have melanocytic markers. Even the ESC have melanocytic markers. So the whole panel has simply, so CD10, I don't remember the last time I did a CD10 on RCC. Completely stopped, almost completely stopped. Once in a blue moon, I do CD10 in RCC.
Yes, sir. And for all these markers for the genetic syndromes like SDH and FH, so are most of the clones equally performing in IHC, or is there any clone specificity when we have to keep in mind?
We have not done a comparative study, but I can tell you we had a good working clone of FH. Okay. Last whole year we worked on it. We found some 11-12 cases. I think we have now 15-17 cases of FH. It has suddenly stopped working now. Completely stopped working. So we are trying different protocols and it's not working. So the problem is once it goes from a reliability state to a non-reliability state, you are not sure. You are not confident of reporting on that IHCs. So I've at least told the IHC lab not to do FH currently. But they have some aliquots left and they want to use it because they paid the money for it. So they want to use it, but we have to look at it very carefully. So not all companies and clones are giving you these correct
But there is no consensus as of now, which is the clone of
You may find in different EQUAS programs, if you go, they will, so if you go to Nordic Quiz QC and all, they may give you some suggestions that you see. Generally, those main companies which supply with you BioSBs and all those stuff, say Cellmark and all that, they generally work well. The problem comes when it stops working. What do you do? So it may work initially like it worked for us. For a year and a half, 2 years, it worked very well. We got a lot of cases. We did even on leiomyomas, we did it because you can have FH deficient leiomyomas also. It worked very well. But suddenly, last 1.5 to 2 months, it stopped working. We are struggling with this.
And at the end of the IHC, is the IHC result itself enough to confidently say it is a deficient tumor, or do we have to?
Yeah, we write in the report, kindly confirm with molecular testing. We do write, but for practical purposes, FH loss is a very specific test. The 2SC stain, which I did not mention, is a sensitive test. But again, the reliability of 2SC is not great. So FH loss in a good control setting, when you have positive controls, internal controls, is a decent, especially with the morphology, age group, presentation and everything, is pretty okay.
Thank you.
Yes, sir.
Actually, I thought of asking you about succinylcysteine, but you answered it. Sir, what's your take on RCC?
Sorry?
RCC with smooth muscle stroma.
We don't see them very often here. I don't know. So if you look at it, if you look at Western literature, all these RCC associated stroma and the clear cell papillary tumor, they also have leiomyomatous many times. It is the third most common tumor in the West. How many have you seen clear cell papillary tumors? We don't see them. Don't seem to them because so they belong to the same profile. So the clear cell with leiomyomatous, many of them have TSC1, TSC2 mTOR mutations. They say that. We are not doing the mutational studies on all cases. So it's only in metastatic setting the clinician would want a NGS profile on these patients. So we are not seeing those many cases. Yes, madam.
Sir, in your experience, how many metastatic tumors have you seen, sir, in the kidney, which are mistaken for RCC?
From Mets to kidney? Very few, I think. Because they don't operate first and foremost. So if it's a known case of, say, thyroid or squamous carcinoma, esophagus, they will probably just do a biopsy in these cases. They will not resect it out. If it's a widespread metastasis, they will not even biopsy the kidney in this way. They will take it as a metastasis. But I have seen a few cases of thyroid mets to kidney, and definitely one prostate mets to kidney I've seen because that was resected. And then a couple of esophageal mets and oral squamous carcinoma metastasis to kidney. Kidney has got a lot of vascularity, so it does have chances of developing mets. Yes, please.
Renal pathologist, I'm a hempath guy, but still lots of curiosity by listening your talks. Just a wild thought: is it really any panels or any particular mutations for clear versus non-clear? Because as for your view, it is the clear versus non-clear what the clinician wants. It's the only IHC. Like when I used to do all pathology, that's CD10, and almost you told it's not. I also don't know what our people are using. So it's the IHC reliable, or still there are some molecular markers you like to do when you have a doubt to say clear versus non-clear?
For a type 1 papillary, what we used to call a trisomy 717 can be done on cytogenetics to call it papillary. But I think typical type 1 papillary RCC is not a problem issue. We generally would be able to diagnose on morphology with CK7 strong positivity, MKR positivity. The problem comes in the eosinophilic looking clear cells. So you are not sure whether it's clear or not. So that's where a CA9 is very.
ஜவான் ஜவான் படம் போட்டு விடுங்க.
கரியெல்லாம் வேஸ்ட் பண்ணாதீங்க, நல்லா சாப்பிடுங்க. பீச் போறது
ஏன்னு கேக்குறீங்க? அந்த பழக்கம் ரொம்ப மோசமா இருக்கு. எல்லாத்தையும் எழுதிக்கிட்டே உட்காந்துட்டேன். அப்ப ஏன் அப்படி போய் எடுத்துட்டு இருந்தேன் கைப்பகுதி? எவ்வளவு நேரம் அப்படி எடுத்துட்டு வந்தீங்க? இது அதே ஹிட் பண்ணுங்க. ஹிந்திங்க ஒன்னா போகணும்.
வரலையா? பாஸ் பண்ணி பாஸ் பண்ணி பாரு. மறந்துச்சுதான் ஒண்ணு மறந்துட்டோம். படம் பார்த்தா ஃபுல்லா பாருங்க. நமக்கு தேவையில்லாம செலவு பண்ணி தேவையில்லாம பார்க்க
of Pathology, Astram Medical College, Elluru, Andhra Pradesh, to chair the session. Ma'am has multiple publications in national and international journals. Ma'am has received Ghana Subbalakshmi Young Scientist Award at IAPM Andhra Pradesh State Conference in 2015. She also won awards for Best Paper in Senior category in IAPM State Conferences. Her area of interest were cytopathology and histopathology. Welcome to the stage, ma'am. Now I request ma'am to take over the session and introduce about this expert speaker.
Dr. Soumyarajan Malik, Additional Professor, AIIMS, New Delhi. He had a training in ICMR International Fellow at Omaha, USA. Awards awarded IAOP Poster Prize in 15 International Congress on Oral Pathology and Medicine, 2010, South Korea. Early Career Research Award, Grant, and DST SERB. Dr. Panna Chowdhury Memorial Award 2018. Funded projects, he has 3 funded projects completed, 3 current funded projects, books and publications, 90 research publication, 1 chapter in the book, memberships, ASH, SH, IAPM, IAP, ID, and MPAI. I request sir to start the session.
Good afternoon, everybody. So, thank you, organizer, for inviting me regarding this, the topic which is core of my heart. And there's a post-lunch session. Hope so. You people will not sleep. I'll try to make it interactive. For declaration, I have only 300 slides. They're almost all are cases. So I tried to be more case-based approach rather than a theoretical. You can interrupt me, no issues. We'll try to complete whatever the possible in 45 minutes. I'll not go beyond 45 minutes. So the way I plan this lecture, there are lots of confusion regarding people say high-grade lymphoma, low-grade lymphoma. So what's exactly terminology to be used? Because just before coming here, I was in hematocon. So the topic allotted was low-grade lymphoma. So I was surprised. The topic doesn't exist actually. It is a dead terminology. So what terminology you should use in a particular context to report? Next stage was the normal IHC, because there are Dr. Jyoti and Dr. Prasant told me many PG students are there. So I thought you first understand if lymphoma is very simple if you understand the IHCs in a proper way, how the normal express. So a little bit of slides. Then I'll come to 2 major proliferation pattern. One is nodular proliferation, one is diffuse. In diffuse, whether it is a B or T, if it is a B or T, either blastic or normal. So how the lymphoma, all this classification goes, how it is, what is the broad terminology? Everybody knows, very simple. It is NHL, HL. First, in NHL, it is B and T. In a B and T, the precursor or mature. This is the basic concept, how one should to report in a if you are looking at this, whether you are looking at the NHL or HL, if it is an NHL, HL, then of course you need a IHC to know whether B and T. And IHC plus morphology, whether it is a precursor and mature, then we'll go one by one. Next is high grade versus low grade. Many people call it a low grade lymphoma. It is a high grade lymphoma. So from onwards, whoever is go out of this hall, never use a low grade lymphoma. There is nothing called low grade lymphoma. Is there any criteria to call a low grade lymphoma? What is the grading criteria? Any of you can stand up and say me, this is the criteria for low grade lymphoma is mentioned. It is not mentioned anywhere. It is a longer back in Kiel classification, they used to call it a low grade, high grade. But it's, of course, the high grade has gone away in 2008, 2016. Again, it is back in 2022. So when to use this term high grade lymphoma, I will emphasize. There is nothing called low grade, high grade. In fact, how we decide what the clinician wants, because whatever you do in a classification, as the previous speaker was saying, all about the clinical context, how the clinician is using, right? So it is the appropriate clinical context to do. And what are the, and how pathologists look at, we look at in 2 points of view. One, what is their biology and what's their histomorphology. So in all amalgam of 3, right, clinical behavior or the biology, what we can understand from the basic test, and the histomorphology we divide. So what is this low grade and this high grade? There, when people realize we should not use this term, the term uses indolent and aggressive. So in a way back in 1995, Dan Logo first used this term indolent and aggressive to like say more of a clinical. Indolent means they never cures, very long clinical course. And you can say their survival in terms of years at least, right? So low grade is nothing better to call a indolent lymphoma, small cell lymphoma. You can say it's a small cell lymphoma. That's some way good rather than a what called low grade lymphoma. Next is your aggressive lymphoma. There are two lymphomas only, indolent and aggressive. What are indolent? Which you are in the back of the mind, you are thinking of a low grade lymphoma. Those are basically a indolent lymphomas. What are aggressive? So aggressive in the term, is it clinically say aggressive? There's somebody, let's say example, some clinician come, the huge mediastinal mass with a supravena cava syndrome. It could be a Hodgkin. Hodgkin is not an aggressive lymphoma. There's a bulky disease of 10 centimeter. It could be a follicular lymphoma for a long standing. So just because the radiologist cannot say it is aggressive, unless until indirectly they say there is some part of necrosis, right? So it is about your biological behaviors. Of course, clinically aggressive lymphomas are very short duration presentation and usually have a high LDH and high rapid growth. And the indolent lymphomas, there are slow growing lymphomas, very long durations. And then morphologically, what you look at? You look at how pleomorphism they are, or those are basically large cells, intermediate size or intermediate to large size, mitotically active, huge mitosis, pleomorphism. And if you find a necrosis, well and good, right? So these are the things which when you see, yes, large cells, high mitosis, and your necrosis with a short duration, you call this aggressive lymphoma, right? So there are two things like histomorphology. We look at the cell sizes based upon how we decide cell size, small, intermediate, and large size. I'll come back to so with examples. And clinically, they tend to grow more slowly, indolence, and fewer signs and symptoms when first diagnosed. So there are 4 photographs here. So among these photographs, this is what I mean for a, sorry, the ledger. Okay, let's come back. So this one, okay, this is a blue, red matching. Okay, so this is a small cell, this is a intermediate cell, and these two are large cell. So this photograph memorize the small cell, intermediate cell, and large cells. Small cells are indolent lymphomas. The intermediate cells, all intermediate cells are high-grade lymphomas. That's the only group. There are 5 entities comes under high-grade lymphoma. And rest all you can call a aggressive lymphoma, or you simply call a large cell lymphoma, large B cell lymphoma, maybe CD20 positive or PAX5, CD9, 79, as for the markers you have available. You just call, don't call a high-grade DLBCL to be high-grade lymphoma. Okay, so this is a small cell with respect to histiocyte nuclei. The cells are small with respect to no histiocyte, endothelial cell nuclei, no endothelial cell, normal lymphocytes. Clear? So try to look at this small cell, intermediate size, then the large cell could be much more very pleomorphic. So how what are the lymphomas which comes under small cell lymphomas? There are only 5 groups, you can say. There are at least 20 entities, indolent lymphomas or low-grade lymphomas, whatever you like to call. There are only 20 entities. What are those groups? Those are basic follicular group of lymphomas or follicular lymphoma and their varieties. Then the SLL or CLL lymphomas. Then the marginal zone group of lymphomas. Then the mantle is basically not a low grade, not a high grade, but as most of them are small cell, I keep it here only. So then in this they introduce one systemic group of lymphomas like the splenic lymphomas. Clear? So these are the entities which comes under the small lymphomas. Then comes to what are the large lymphomas. They are all whatever thing are DLBCLs, diffuse large B-cell lymphomas. In the diffuse large B-cell lymphoma group, there are at least 15. So what I like to highlight, these are new entities which are introduced. High-grade B-cell lymphoma with 11q aberration, fibrin-associated lymphoma, fluid overload lymphoma, then primary lymphoma of the immunoprivileged site like testes, CNS, these are introduced. So what basic terminology? These are large cells. If you are not able to classify apart from the upper one, rest there are 15 entities, 15 or 16. If you, these are large cell, first B, ho gaya, large B cell lymphoma. If you can classify, call a particular name. If you don't classify, then call a diffuse large B cell lymphoma, NOS, not high grade lymphoma. If you are not, you have a limited IHC, you're not able to understand, just like this is a large B cell lymphoma, or aggressive lymphoma, is a large B cell lymphoma, not HGBL. Clear? So which groups are HGBL? There are only 5 I have highlighted. One is DLBCL or HGBL with mixed BCL2, which is called double hit lymphomas, no more using the term. Next is your high-grade lymphoma, NOS. Fourth is Burkitt lymphoma. Or fifth is lymphoblastic lymphoma or blastoid mantle. So these 5 groups are called high-grade lymphoma. If you cannot classify, just like these are high-grade lymphomas, if you can do exclude Burkitt, exclude blastoid mantle, exclude lymphoblastic, exclude double hit, called HGBL NOS. Clear? So there are groups which are small. Now I'm talking only about B cell lymphomas. Small B cell lymphomas, high-grade lymphomas, 5 entities. Then rest are large B cell lymphoma, mostly including DLBCL NOS. So how to approach? So this is very nice. So we must have aware there are 2 classification systems we have. We started with 2. We merged in 2008 Real and WHO. Then WHO 4, 2, 3, 4. Then in 5 again we divide ICC and WHO. So there are lots of political issues and their own interest. We don't go, but they both are basically okay. Which one you adopt, nothing going to harm. So what this picture I taken from the ICC classification, where you have a minimal requirement like diagnosis IHC and FIS and few molecular required. Initial part, you can say, I don't call FIS is a molecular technique. It is simply the least technique you can do it. Okay. So then you can classify to these groups. Then for the prognostic point of view, you can have as much as molecular. Molecular means sequencing NGS data. Otherwise, by FIS and chromogenic in situ hybridization cyst and few Sanger sequencing, you can easily classify. For the PGs, it is a lymph node like it is a capsule, then subcapsular sinus, cortex, medulla, and paracortex. This is what the normal lymph node look like. If you understand the normal node and the IHC, then you can understand the lymphoma 50% of the thing. So how it's look like? It is a thin capsule. Then you find a cortex, like this follicles. So remember, it is a flux. You can never imagine if you see a node, you find a cortex, follicles, and rest are medulla. You will never find. 50% you don't find, depends upon how the way you are cutting the nodes, right? So what you can expect, the sinuses are patent, the follicles are variable size, and you have a secondary follicle. All 3 structure you see, and it is a probably reactive follicle. Here it is an ideal one. You can see here cortex and this medullary cords and sinuses. So normally what you look at the nodes is the capsule is okay, fine if it is a perfectly cut. Next is whether sinuses are patent or not, right? If sinuses are patent, then what about the follicle, or the secondary or follicles, or they are monomorphic? If secondary follicles, whether they are variable sized or not. If you see all these, probably you are dealing with a normal, and this follicle is always egg site, the mantle zone, and this is a germinal center, dark and light zone. So the normal IHC like CD20, it is present in the B zones, and B zones are the follicles. Then the CD3 in the interfollicular area, you can see here. And the few CD3 we expect inside the follicle. What are these? Anybody? T follicular helper cells, because few lymphomas may arise from this. What are the characteristics? And they are typically present for the germinal center markers, so like 10, BCL6, and few other marker. I'll come. So these are normally 3 present outside, only few inside the germinal center, T follicular. Then the BCL2. Many people I saw they have a tendency to do BCL2 in all lymphomas. Never do. I never do. I do only BCL2 when you have a doubt between reactive versus lymphoma. Once decided it's a lymphoma, it has no role. Except germinal center cells. They are positive in all cells and all lymphomas. They are positive in B cells, like mantle zone, marginal zone, T cells, everywhere BCL2 is positive. And in lymphoma, it's positive in follicular, in mantle, in marginal, in SLL. So how will it be helpful? It will not helpful. It will helpful only to differentiate between a reactive follicle and lymphoma. And what's the second role? In double, like to suspect whether it is a double hit or not, the so-called double hit, right? Otherwise, if you decided lymphoma, BCL2 has a no role. But the question in BCL2, normally BCL2 present all cells outside except the germinal center, because it's normally present in T cells and mantle and marginal zone. And one question, there's 2 clones of BCL2. The E17 is the better clone supposed to be, because it has a wide epitopes. Next, the CD23. It highlights your dendritic mesosphere. How it will be helpful? You have a needle core biopsy. 21 is better than 23. You are not able to identify whether it is a architecture is lost or not. Do a 23. If still the nodules are present, probably not lost. So what? This is how we are expecting in a dendritic pattern of mesosphere. Then cyclin D1. So common markers I am discussing. Cyclin D1 normally absent in all cells. Internal control, only the endothelial cells. You find endothelial cells, they are positive for cyclin D1. Ki67. Very useful, but weak access to interpret Ki67. Ki67 high in normal reactive, then they tend to absent in the indolent lymphomas or low grade, whatever, CLL, SLL, mental. Again, when they transform to aggressive, they again high. So how to, Ki is good, but interpretation is very crucial. See, it is a reactive node. You can see the distribution of Ki. It is a polar distribution. The dark zone is a high Ki, it is a low Ki. See, it is a lymphoma, follicular lymphoma, very low Ki. If follicular lymphoma goes to grade 3B, previous one, or now they are called nodular large B-cell lymphomas, they are very high. So distribution, pattern of distribution, then only you can carefully understand Ki. Next, the follicular T helper cell I call you. So these are markers like CD3 will be positive. Then there are 5 markers required. At least 2 should be positive. How many do? There's no recommendation, but you need 2. CD10, BCL6, then your PD1, ICOS, CXL13. At least you require 2. So we do 3 markers, at least 2 can come positive. So now overall, what is lymphoma? What we should not do? And what's the normal when you see a slide? Clear? So now comes to approach. How will you approach? So there are 2 basic approach in lymphomas. One is nodular proliferation, one is diffuse proliferation. Either it will go by nodules or it will go by diffuse. It is in the 90% or 95%. 5% you find a partial, whether it's a sinusoidal. Okay. So it is a nodular growth. So how to approach a nodular growth? It could be benign, it could be malignant. Somebody say benign and a nodular, yes, that is possible. What are the conditions? Like reactive hyperplasia, florid reactive hyperplasia, in situ neoplasia, progressive transformation of the germinal centers, IgG4 disease, rheumatoid arthritis. You find benign nodular proliferation, but those are all reactive. Extranodal, yes, there is one condition called pseudolymphoma. You find nodular proliferation in skins mostly occur. Then comes malignant, B and T. There is only one T cell lymphoma which can show a nodular growth. I will come. There is a T follicular helper cell lymphoma. Otherwise, all are B. So what are the B lymphomas? All lymphomas can show nodular pattern, but mostly these indolent lymphomas or low-grade lymphomas. So if you see a nodular pattern, first diagnosis is follicular. Second will be follicular only. Third will be follicular. Then think of others. Then will be your mantle, your marginal. Sometimes SLL may mix, right? So rare are like NLPHL, nodular sclerosis, then lymphoma with IRF4 rearrangement. So these are either follicular or jitne bhi follicular varieties hai. Rest are like mantle, then IRF4, then marginal zone, and then NLPHL, of course, from the NLPHL side. So what is the basic panel? So as the organizer requested, what should be the basic decisions? This panel is what we like designed by the All India AIMS New Delhi, and we practice. It may differ from institute to institute as per your understanding. So what I'll say, you saw a node, you decided now it is a node whether a reactive or follicular. First, reactive or lymphoma, the first diagnosis. So what I prefer to do 320, BCL 23, KI 67 plus minus. So 20 will show the architecture, like distribution, 3 and 20 distribution. I'm not expecting too much of 20 in the paracortical zone. Other the nodules to be CD3. Next, the CD23 or 21, whether dendritic meshwork has gone or not. Even if in needle core, I'm not expecting all dendritic meshwork should be gone, so it should be present. Next is BCL2. If it is a BCL2 positive, then I have to see whether it is a primary follicle or a cut section of the mantle zone, or it is really a secondary. So that's, if it is a normal distribution, it's okay, it's a reactive, no need to do anything. So next will be nodular lymphoma. If it is a architecture will be nodular. So what we'll do, I'll do these 7 markers at a once, like 320, because I have decided it's a lymphoma, so I have excluded BCL2. I'll not do BCL2 because it is a lymphoma for me. 320 lineage, then 523 SLL, 5 cyclin D1, 23 negative mantle, then 10 BCL6 positive follicular. So everything negative marginal. So very easy, right? Nodular nodular pattern, and these markers you can do. Sometimes these are less sensitive, then you can go for SOX11. Then we have an extended panel also. If we not able to decide, we do SOX11 for mantle. LEF is a very good marker for SLL. Then GSET, we don't have LMO2, we have a GSET. GSET for your follicular. Then MYD88, I will not suggest because we don't practice. We do sequencing for MID88 if required. We have real-time PCR and Sanger sequencer we practice if you require MID88. Clear? If a capsule is thick, looks like a Hodgkin, then we change our panel like 320, 520, not 523, sorry, it is 1530 EBV or Iberis as required. Still it is doubtful, I will come. Then we include OCT, BOB1 and CD57. So this is the indolent. So what are the soft point between reactive and follicular? It is the loss of architecture, as I told you. Next is the large interfollicular area showing lots of B cells, then densely packed follicles, pericapsular spread. So these are the soft and loss of these sinusoids. These are soft points where you can say whether it's a lymphoma. So you can see here, there is a back-to-back monomorphic follicle with pericapsular extension here. The follicles are well spread. There's a paracortical zone expansion, the reactive. So that's a uniform monomorphic follicles with absence of secondary germinal center and pericapsular spread. You can see here, appreciate the pericapsular spread. And if you do markers also helpful, like CD20, too many CD20 in the paracortical zone. CD10, BCL6, which is supposed to be confined to the germinal center, they comes in the interfollicular area. That's indication. So now come case one by one. So this is a case, everybody can say monomorphic follicles. Diagnosis? Yes. Itna to padaya. Follicular lymphoma. Very good. So you have to see it's a centrocyte and centroblast admixture. 3 negative because T zone, 20 back to back. You can see the interfollicular area also 20 positives. Then BCL2 positive in all area. Only BCL2 positive B causes because it comes in normal mantle zone, normal marginal zone, and primary follicle. So you have to prove that it is a secondary follicle. Then it's a lymphoma. Then we did CD10. CD10 is positive because CD10 never comes in others. One more marker I didn't show is the IgD. It is also very helpful for primary follicles. Clear? CD10 positive, 23. It is only dendritic pattern. So it is okay, fine. Then CD5 negative. CD5 to be interpreted with respect to CD3. Jitna CD3 hai, utna CD5, then it's fine. Without seeing a CD3, don't interpret CD5. And CD5, because it is a normal marker, which when aberrantly expressed in B, that's an abnormal, right? 5 23 negative, cyclin D1 negative, 10 positive. So it's a follicular lymphoma. So how, I'm not going to theory part because I will not able to complete other, better will concentrate on IHE part. So how, what's the new concept right now in WHO? The new concept, WHO says, don't say grading, don't do grading, grade 1, grade 2, grade 3. Everybody knows the counts. So now they are told it's not required because 90% it will know, because grade 1, grade 2, grade 3A, they will treat like one, grade 3B, they treat like DLBCL. Better you should say grade 3B is a different name, rest all same name. And clinically also few people says it has importance, few say no, ICC written, but WHO no. Our clinician sometimes ask, so you might report, but it's not required right now. So in now called classical follicular lymphoma. In classical follicular lymphoma, then the predominantly diffuse pattern follicular lymphoma, then unusual cytology, then follicular large B-cell lymphoma. It's nothing but the older grade 3B lymphoma. Next is the types. Types is pediatric type follicular, duodenal type follicular, and primary cutaneous follicular. They have in situ, very rare, extremely theoretically. आज तक मैंने एक ही केस देखा. You will never find a lymph node में मिल गया. So you do in some random nodes from some other condition, you will find. How will you diagnose? Normal reactive node. Suddenly only one follicle is very strongly BCL2 positive. So that's it. And it is no clinical importance because it is never progressed. So why it is important is to differentiate from partial involvement by follicular lymphoma. How will you differentiate? Like you will find 4-5 follicles, which is BCL2 positive with a strong CD10. That require treatment if clinician wants, but not the in situ neoplasia. Clear? Next, the duodenal type follicular lymphoma. It's present as a duodenal nodules, and the clinician during the endoscopy, they will curate it, and they're positive for normal markers. You find a normal mucosa with this follicle positive for 20, BCL6, or BCL2, CD10. So no treatment is required. So the only problem with follicular lymphoma is BCL2 negative follicular lymphoma. How to deal with that? So I think WHO is not answering. I may misinterpret those terms. ICC is better. So there are lymphomas which looks very well sorry, I don't have a photograph. So it will look like a purely follicular lymphoma, but BCL2 will be negative. Clinically lymphoma, you do, it is a BCL2 is negative. All morphological criteria lymphoma. So don't think that it is a BCL2 negative means it is a reactive. It could be a BCL2 negative follicular lymphoma where you find other translocation like mutations in TNFS4 or your 1p36 loss, right? So be cautious if it is all morphological criteria lymphoma, clinically lymphoma, only on basis of BCL2, don't decide. Pediatric type follicular lymphoma, again, normal follicular, usually they lacks BCL2. Then comes here this IRF4 rearrangement. This is basically, I will come in the, it is look like a grade 3 follicular lymphoma, mostly in the head and neck region, because as it's nodular, so I kept here. Grade 3 follicular, mostly in the necks, head and neck region, young child or adults, and they are positive for, this is not my photograph taken from the picture, I don't have a cases. All right. So they're positive for IRF MOM1, and it is a translocation also break apart for IRF MOM1. It's a very what called good prognosis. The limited stage disease, mostly Wilder ring and young adult childhoods. Next case 2, nodular, vaguely nodular, positive for 20, C negative, BCL2 positive. Diagnosis? Yes, of course, itna follicular padhane ke baad follicular nahi दूंगा, but follicular lymphoma. Mine also be, if I saw first time, I'll say follicular lymphoma. Then BCL6 negative, 10 negative. So definitely not a follicular. Low Ki lymphoma hai. Then cyclin D1, diffusely positive. Oh, sorry. Cyclin D1 diffusely. So this is a, so I told mantle can present as a nodular pattern, the mantle cell lymphoma. I'm not going details. So there are two groups of mantle, leukemic, non-leukemic. Leukemics, unfortunately, leukemic mantles are good prognosis. They are SOX hypermutated and SOX11 B cells, and the unmutated are basically bad, though it's present as a systemic one. So then one terminology called in situ mantle cell neoplasia. So what is in situ? Like in situ follicular neoplasia, in situ mantle cell, there are only one layer of cells which are positive inner aspect. If it is a more than 4-5 layer, there is a mantle zone type of mantle cell lymphoma. So it's only important. Like in situ follicular neoplasia, partial involvement by follicular lymphoma must be differentiated. In situ neoplasia should be differentiated from mantle zone type of mantle cell lymphoma because that require treatment. Clear? Case 3. So again, follicular pattern. So we have covered in a nodular, FL, follicular lymphoma and types, mantle cell lymphoma. Marginal can also present, very extremely rare. Right. So next is again nodular pattern. CD3. So I told you CD3 should not come in too much, right? Then CD4 positive, 5 positive, 7 positive, 8 negative, then 23 highlights and BCL6 positive. So this is basically a T follicular cell lymphoma. This is only one entity, T follicular cell lymphoma. Clear? Then comes the diffuse pattern. So nodule is over, now diffuse. So how to deal with diffuse? Diffuse lymphoid proliferation, almost always a lymphoma. So is there a benign condition where we find a diffuse lymphoid proliferation? Yes, there are few like viral, drug-induced, autoimmune. You find a diffuse lymphoid proliferation. If malignant, so how to say diffuse proliferation? We have decided it's a lymphoma. Then whether B cell or T cell. First 320, do 320. B cell or T cell. Then once B cell, whether blastic or mature. From morphology, intermediate size, either it is a very large or a small, right? Then monomorphic or polymorphic. If mature, monomorphic or polymorphic. Monomorphic means one type of cell. Polymorphous means you find eosinophils, you find plasma cells, you find histiocytes. Then nodal or external. So if you systematically approach, you can go down. So next come monomorphic B cells. I'm not going, I'll come T cell later. Monomorphic B cells. So pathology point of view, small cell, intermediate cell, and large cell. Diffuse B monomorphic. Now small cell, intermediate cell, large cell. Small cell, there are 5. SLL if diffuse. If it is a nodular, follicular above. If it is a diffuse, SLL will be come up. SLL, mantle, the follicular go down. Diffuse follicular, marginal, LPL. Remember these 5 only. 90% will be these 5. If intermediate size, these are called high-grade lymphomas. Intermediate cells or blastic or blastoid looking only use high-grade if it is intermediate. What are 5? Lymphoblastic, Burkitt, blastoid mantle, double hit, no triple hit lymphoma. Okay, this is an older term. And if all negative, then HGBL NOS. Similarly, large cell, if try to classify, if not, then DLBCL NOS. So there is a indolent or small cell lymphomas, that is high grade. If you write a high grade, if it comes to report to me, I understand you are meaning these 5, not the DLBL. If DLBL not able to understand, write large B cell lymphoma. Clear? So approach, same approach like small cell. If intermediate, you have to do 320 lineage, then TDT for lymphoblastic, BCL2 to rule out Burkitt in double hit. If BCL2 positive, Burkitt out. Then cyclin D1 for mantle, Ki67 of course, right? So these 5 markers, 5 differentials. Then for the diffuse type, 320 lineage, then 10 BCL6 MOM1 for your classifying GCB, ABC. Then comes the CMYC BCL2 and EBB. So this is the for what called B cells. I will come T cells later. Diffuse, small cell. 5 positive, 3 positive, cyclin D1 positive, 20 positive, 3 negative, cyclin D1 positive, 10 BCL6 negative, 5 positive, mantle cell lymphoma. Again, small cell, homogeneous. There are few clues like follicular and mantle. They are cleave cells. SLL, they are round, perfectly round cells. You can see this cell. 5 positive, 23 positive. You can see why I am saying 5 positive, because see, with respect to 3, there are more 5. There is a little bit of dim positive. Okay. 5 positive, 23 positive. Cyclin D1 negative, 10 negative, BCL negative. Diagnosis SLL. 5 positive, cyclin D1 positive, mantle. 5 23 positive, 10 BCL6, cyclin D1 negative, SLL. Then again, diffuse, 10 positive, BCL6 positive. So the diffuse variant of follicular lymphoma, negative for 5 cyclin D1 23. Clear? So both can present as a diffuse or pattern. Next comes, see, this look like a, abhi tak jitna mein tha, all previous ones, those are blue looking. Now it comes pink looking. Why looking pink? What are the nodes which can look pink? Those cells have a cytoplasm. Because nucleus will be blue, this is a cytoplasm. So T cells, marginal zone cells, and histiocyte. These lymphomas look pink, soft point. Like if you look very pink, so there's probably you are dealing with a marginal zone or a T cell lymphomas. Clear? Again, 20 positive, 3 negative, 10 BCL6 negative, follicular out, cyclin D1 negative, mantle cell out, 43. You can do, if all negative, it is a marginal zone lymphoma. Next, extranodal marginal zone, you can see here. So there is destruction of the follicles, crypts with a diffuse infiltration, 20 positive, rest all will be negative. So this is basically a extranodal marginal zone lymphoma. Then diffuse with systemic presentation. I told you, so those called splenic group of lymphomas. So there are splenic B cell lymphoma, those are indolent lymphomas, but they present as a systemic diseases. Splenic marginal zone, hairy cell, SDP, splenic B cell lymphoma, leukemia unclassifiable, splenic diffuse red pulp lymphoma, and hairy cell leukemia variant. Initially water, but in this WHO, they introduced term splenic B cell lymphoma leukemia with prominent nucleoli, SBLPN. So BPLL and hairy cell variant, they absolute, they merge in SBLPN. Clear? Rest are same, SDPRL and hairy cell leukemia variant. So we have a nice paper. I have lack of time. I have to explain. So you can go through this, our one of the article where we have suggested what are the lymphomas which involve red pulp and white pulp. For things, all indolent B cell lymphomas, white pulp, or leukemia and T cells, they are the red pulp. And we have also diagnostic approach, how we can approach a splenic lymphoma. This is beyond the things I'm not going. Now comes the intermediate group of lymphomas. So this is okay. So straight away comes to, if it is an intermediate group of lymphomas, so what we have to do? So so I told 5 things. So we have to do like come to case. We'll discuss case. It is better. So this is an intermediate group. You can say all are like opened up chromatin, multiple nucleoli. Then the stereosky appearance. Diagnosis, Burkitt. Okay. So when you think it is a Burkitt lymphoma, even if without this what called tangible body, then call a high grade lymphoma. But there are 5 diagnoses we have to do. 20 positive, 3 negative, 10 BCL6 positive. Cyclin D1 negative means blastoid mantle out. BCL2 positive, then Burkitt out. It's no more a Burkitt, no more a blastoid mantle. TDT negative, lymphoblastic lymphoma out. Clear? So now MYC is positive. Now, earlier people called double expressor lymphomas, but this terminology is no more used. You simply write MYC BCL2 positive, no double expressor. Then you do the FIS. It is important. If it is a FIS break apart, you can see here, one fusion signal, one break apart signal, MYC break apart, BCL2 also break apart. You can see here, one fusion, this is a good fusion, then one break. So this is a high grade B cell lymphoma with MYC BCL2 rearrangement. Clear? So double hit basically MYC plus BCL2. MYC BCL6 has been absolute. So what is the difference between a MYC in here and MYC in Burkitt? Here the fusion partner is no more a IGH. It is maybe anything, maybe IGH, but mostly non-IGH partner. Clear? So again, same morphology. Clear? Same 5 DDs. 20 positive, KI 100%, BCL2 positive, Burkitt out. TDT negative, lymphoblastic out. Then 10 positive, BCL6 positive, maybe Burkitt, but then we do CMYC. CMYC is normal. As BCL2 positive, Burkitt is out, but this is no more a double hit lymphoma. So it is a HGBL-NOS. Clear? जैसे DL-BCL-NOS है, ये HGBL-NOS हो गया. Again, another same morphology. See? Same morphology. 10 positive, 20 positive, 3 and BCL6, 3 negative, 34 negative, TDT negative, lymphoblastic out. Then CMYC positive, BCL2 negative, because it is in only as a 3, like 3, and KI 100%, then Iberis. Diagnosis, Burkitt. So all Burkitt lymphoma, Iberis is mandatory. Clear? Because BCL2 negative, MYC positive, KI 100%, TDT negative. So this is a Burkitt lymphoma. So we did mix IGH fusion for confirmation. So it is positive. Only one thing to remember all, Burkitt is an extranodal disease. If you are diagnosing nodal Burkitt, be careful. Then HGBL, another case, is ovarian mass, same morphology, MYC positive, 10 positive, then cyclin D1 negative, BCL2 negative. So probably Burkitt. So but we work up for this case, MYC IGH, it comes negative. So then we did 11Q abnormality. So you can see here, more than 3 signals, more than 2 signals of green and loss of 1 red signal. So this is a high-grade B-cell lymphoma with 11Q or large B-cell lymphoma with 11Q rearrangement. So this also comes in this group. So next, lastly, the blastic lymphoma, lymphoblastic. Looks like same, CD3 positive. Then, oh, I forgot to annotate. This is a TDT. TDT positive, CD3 positive. A negative marker is a CK. So whenever you have a mediastinal mass biopsy, typically without cytokeratin, never sign out lymphoblastic lymphoma because normal cells also will be positive, or it could be a thymoma. See here, same look, C positive, TDT positive, mediastinal mass, but CK is diffusely positive. So this is a thymoma, right? So this we have a good review paper in Journal of Mediastinum, how to approach a pediatric mediastinal lymphoma. So we have very clearly shown what is the normal mediastinal thymus architecture, structure, then PMBCL, HL, you can go through. So why I'm saying, see, this is the normal node and this is the thymus. So here, this is the thymus and this is the normal node. So there's a very proximity. So as normal node can also give lymphoma and thymus also can give lymphoma. So to differentiate between the two, it's very difficult. So you must have be cautious. So why? Because if you do CK, it shows such networking kind of positivity that rule out your thymoma. Okay. So another case, again, same blastic morphology, 20 positive, BCL2 positive, TDT negative, lymphoblastic out, BCL2 positive means Burkitt out, CD5 positive, then cyclin D1 positive. This is blastoid mantle. Clear? 5 lymphomas, 5 markers, one by one. Next comes the diffuse large B-cell lymphomas. So it is the easiest to diagnose, no marker required. 320 morphology, you will diagnose it. Aggressive features, see, lots of pleomorphism, that will be a generalized lymphadenopathy, short clinical course, 320 positive. Even if you don't do GCB, ABC, then it's fine. But indolent and your intermediate group, you have to do a wider panel. So, but as a practice, we do 320, 20 negative. Then we use Hans algorithm. I don't like personally, but clinician is asking, so I am doing 10 BCL6 MOM1, 10 positive. It will be a GCB type. If 10 negative, then goes to MOM1. If MOM1 positive, again, irrespective of BCL6, it will be a BC. If BCL6 positive, again, a GCB type. So other methods you can do by cell of origin, by tally methods also is irrelevant. Then short story of 1 minute. 20 years back, these cell of origin by this alleged. Then one PG student given was thesis like Hans. And they published in the next year, and the most cited till now, this is Hans algorithm. But you know, the Hans is now doing dermatopathology. He is not practice. He never practice lymphomas. And we keep in doing for 20 years. There is no result. At least till now. It is prognostically significant, but not for any other purpose. No therapy till now. So after 20 years, there are 2 groups came like one Dan Faber group, one NCI group. So they have 2 classifications, 2 different kinds of classification, because GCB or ABC are not going to help us. So they did a different classification by whole exome, whole transcriptome. They do pura whole exome sequencing, then whole transcriptome also, like gene expression profile, then the copy number variation. So they come up with a new like C1 to C5, and then this is like there are 5 groups: MCD, BN2, N1, and EZB. It is irrelevant for this method, but just to show how what the current DLBCL NOS is going ahead. So basically MCD, N1, BN2, EZB has 2 again. It corresponds to same. Like EZB is the germinal center, MCD is the your ABC type. So after 20 years, then alleged the initial paper, they told, okay, we are out of role now. So they again come back, they did a smart job. They take all the data from them, they bioinformatically analyze only by doing a 5-cell sequencing. They come a lymphoecotype. Now they want to divide by the what called, they are the other cells based upon their the other tumor infiltrating cells, other lymphocytes, T cells, histiocytes, monocytes. So this paper come very recently to classify lymphomas. This is called lymphoma ecotype. Again, diagnosis, anyone? There is a gland, let it. Again, morphologically, large cell, aggressive lymphoma, 20 positive. Again, see, cyclin D1, SOX11 positive. So basically, this is a postpartum lady with a uterus like pervaginal bleeding, and they did a biopsy from the endometrium. It turned out to be a pleomorphic mantle. So that's a mantle you cannot call a aggressive or indolent lymphomas. Again, mucosa with many cells. Even at least aggressive lymphoma, 20 positive, large B cell lymphoma. 10 negative, BCL6 negative, MOM1 positive, Iber is, you can see almost 80% of the cells. So this is basically a EBV positive large B cell lymphoma. Clear? This is a large mass. Again, polymorphous population, few large cells, positive for 20, and EBV LMP. So this is basically a lympho, and the patient treated arch of the all vanishes. Basically, this is the lymphomatoid granulomatosis. These are the subtypes. Before my time finished, I like to highlight, this is a rare entity, plasmablastic differentiation. I'll discuss this one, then we can stop. Give me, madam, just 5 minutes. Known case of nasal plasmacytoma, you can see here. The patient, so I was reporting at that time, the known case of plasmacytoma, life becomes very easy. Plasmacytoma, what happens? And also plasmacytoid morphology, CD138 positive, this is 138 positive, lambda restricted, so I send out a result compatible with plasmacytoma. The patient treated after 2 months, there are multiple nodules. The patient has multiple nodules. They again come back to us. Then they told, no, it is, they told the liver lesion, all those, they do like what called, all plasma myeloma workup, they're all negative. So then we did other markers. So these are lymphomas or the aggressive hematolymphoid malignancy with plasmacytoid differentiation. Whether it is a plasmablastic lymphoma or a plasmablastic myeloma. 20 negative, 79A positive, 5 CD5 negative, cyclin D1 negative. So how to differentiate between a plasmablastic myeloma versus lymphoma? Very few points, practical, not possible. 56 cyclin D1 negative. Madam, can I have 2 minutes? So then we further work up, it comes to be ALK1 positive. This is basically ALK positive large B-cell lymphoma. So the moral of the story, 138 negative, sorry, 20 negative, plasmablastic morphology, 138 positive. What are the possibilities? Plasmablastic lymphoma, primary effusion lymphoma, solid variant of primary effusion lymphoma, and plasmablastic myeloma. And we have to do all the markers. Like what are the markers will be helpful? One is Iber, which is more in case of plasmablastic lymphomas, less in myeloma. Then 56 cyclin D1, more in myeloma, less lymphoma. Then you have to see multiple factors, immunodeficiency, then whether it is IgM or IgG profile, then you will decide. I'll go straight forward to last case. Okay, so how to approach a T cell lymphoma? Let's say T is usually easier to do. How do whether it is a blastic or mature, nodal or extranodal, it is much required. You have to do this marker T cell panel, you have to do extensive panel. Like if it is if you think it is a T cell lymphoma,
why does she always
whether blastic or mature. If it is a mature, whether it is a ALCL looking or it is a intermediate or monomorphic looking. If ALCL looking, the panel should be 320, 1530, ALK EMA. Finish. 48 you do or don't do, don't matter. If 30 positive, ALK positive, then anaplastic, ALK positive anaplastic large cell lymphoma. 30 must come diffusely. If 30 positive, ALK negative, anaplastic large cell lymphoma, ALK negative. If not, then you have to do more markers like 320 3 positive T cell lymphoma. Then you have to do 10 BCL6 and PD1 for T follicular helper cell markers. Okay. Anyway, I am here always if because not possible to cover all lymphomas. Just like T cell lymphoma is again another lecture. So just to approach whether blastic or mature. If blastic, then 3 TDT, 320 TDT. If mature, then whether it is a ALCL looking, non-ALCL looking. Non-ALCL, there are two major things: PTCL NOS or TFH origin lymphomas. T follicular helper cell lymphoma. So to call a T follicular helper cell lymphoma, like you have to do these 5 out of 5, at least 2 comes positive. You do how much? If 2 comes positive, then it will be AITL or like a T follicular origin angioimmunoblastic type. If no dendritic meshwork, then it is a NOS. If it is a nodular, then T follicular. If everything comes negative, then PTCL NOS. Yeah. I hope I have clarified, but some lack of time. This is my own team who always inspire me. I have 2 things, like I do lymphoma and MALPATH. So these people say all are watching lymphoma with my lab guys. Were very wonderful, fantastic. I'm roaming around for last 5 days, hematocon, then here, they are taking care of everything. All molecular work, they are taking care. So I'm thankful to Rajiv and all my back team. Few Prasant knows many of them. Thank you. Again, to one more thing, this time AIMS Delhi organizing this Molecular Pathology Association of India. I am the organizing secretary. This is a very good academic with lots of molecular workshops. So you people, if you are interested, must attend. Thank you. I don't think we'll have questions.
Thank you, sir, for your very elaborate session on lymphomas. You have enlightened us on the steps of approach towards lymphomas and the current trends in lymphomas and interesting cases on lymphoma. Thank you, sir. Session is open for discussions. Any questions, please?
Cyclin D1 negative mantle cell. Yes, there are, you will find 5% of the cases of cyclin D1 negative, that could be cyclin D2 or cyclin D3 positive, but SOX11 comes in more than 95 to 96%. If cyclin D1 can come negative, but SOX11 could come positive. If SOX11 negative, you have ruled out rest other lymphomas. You are more inclined to call it like you have been LEF, you have been ESET, where those are not. Then you can go for a cyclin D2, cyclin D, but it's very 5%. But SOX11 is helpful. SOX11 plus cyclin D1, 95, 98% will be there. 1-2% will be cyclin D2 only. Means, see, mantle cell lymphoma is a cleave cell lymphoma. For my, if I'll see, if it is a diffuse growth pattern, cleave cells, I have ruled out follicular, like by doing 10 BCL6 GSET, then definitely I will go for a FIS. You should go for a FIS or SOX11. Or otherwise you do GSET LMO2 to rule out follicular, you do LEF to rule out SLL, then you can think of. Otherwise, just by doing a cyclin D1 negative, I will little bit afraid, I will write this is a small B cell lymphomas with a casus quote unquote my points. Yeah. This is expensive. You can go for SOX11, that is in $1,000 you can do SOX11. Yeah, Burkitt is a tricky. What it's again.
I'll just repeat my question so that. So, do you do fish in all cases of Burkitt's, or do you reserve it and choose?
Yes, I'm
in some
saying if a recommendation, all cases should be worked off of fish, but not possible. What to do? If it is a extranodal disease, like a mandible or a abdominal mass, young child, and all morphology, everything goes, I'll go ahead. If it is a nodal Burkitt, I will never sign out. I also suggest you also don't, because Burkitt has a separate kind of treatment. Nodal Burkitt, you must confirm. Then any unusual feature must confirm. It could be HGBL, like that ovarian case, large cell lymphoma 11q, but IHC you must do. So lymphoblastic and your blastoid mantle, all those will out. Nodal work, extranodal, classical case, mandibular or extranodal child, you can do. Hope everybody is clear. Thank you.
Any other questions from the audience side? Thank you, sir. I request Professor Dr. Vahini ma'am to honor our speaker as a token of gratitude for his valuable contribution. I would like to call Dr. Sunil Sir, Treasurer, Assistant Professor, Department of Pathology, AIIMS Mangalagiri, to felicitate the chairperson. Thank you, sir, and thank you, ma'am. We move on to the next session of the conference. The next session is on molecular pathogenesis and updates in breast cancer. I'm profoundly delighted to invite our chairperson, Dr. V. Tejaswini ma'am, Professor, Department of Pathology, NRI Medical College, Guntur, Andhra Pradesh. Ma'am has published 32 scientific articles in various national and international journals. Ma'am has awarded with Gold Medal for Young Scientist Award at 4th IAPM Andhra Pradesh chapter. Welcome you, ma'am. Up next, I would like to take an opportunity to invite our next chairperson, Professor Dr. Satyanarayana Veeragandham, sir, Head of the Pathology Department, Katuri Medical College Hospital, Guntur, Andhra Pradesh, to join us on the stage. Welcome, sir. I request our chairpersons to take over the session and introduce about the next speaker.
It's my privilege to read the biodata of Dr. Aparna Chinnam Madam. She is professor and HOD of Guntur Medical College, and she has more than 30 publications with work experience of 23 years. I welcome you, madam, for sharing your experience.
So good afternoon. I like to thank the organizers for giving me this post-lunch session. Thank you very much. So before going to my topic, molecular pathogenesis and updates in breast cancer. You know that breast cancer is a most common and deadly malignancy affecting women. It is estimated that globally 1.7 million are affected and 1 in 3 die of the disease. So it is estimated that in 2020, 70% of the cases are in the low-income countries. The risk factors commonly assessed are environmental influences, hormonal influence, and genetic imbalances. So the traditional predictive and prognostic classification systems, they're unable to reflect the biological heterogeneity of breast cancer. So with the advent of these high throughput technologies and bioinformatics, has improved the understanding of biological behavior of breast cancers, and also we has paved way for the new molecular assays. But this incorporation of these molecular assays into the clinical practice and to guide patients manage is still a challenge. So now we'll move on to the topic, molecular pathogenesis and updates in breast cancer. So the topics I will cover are the heterogeneity of carcinoma breast, molecular pathogenesis, classification, Indian scenario and a few global studies, and molecular diagnostics. Tumor heterogeneity. So tumor heterogeneity is one of the hallmarks of breast malignancy. It can be intertumor or intratumoral. Intertumor heterogeneity is observed in breast carcinoma from different individuals. Intratumor heterogeneity is due to the presence of heterogeneous cell populations within an individual tumor. Tumor heterogeneity can be in the form of clinical and histopathological heterogeneity, biomarker heterogeneity, or genetic heterogeneity. So intertumor heterogeneity is due to the histopathological, there are many morphological variants. There are 21 subtypes apart from the NOS and ILCs. So the tubular and mucinous papillary carcinomas, they don't need any chemotherapy. They have a good prognosis. Whereas the metaplastic and poorly differentiated carcinomas, they need chemotherapy and they have a poor prognosis. So the heterogeneity due to it leads to the different grades of tumor. So the biomarker heterogeneity, that response to hormonal therapy, hormonal treatment varies in ER positive and ER negative tumors. And coming to the HER2 positive tumors, only 50% of the tumors respond to targeted therapy, whereas the equivocal HER2 cases, 10 to 20% may turn amplified in fish. So androgen receptor and low Ki67 cases may show good prognosis. Coming to the genetic heterogeneity, both luminal subtypes express ER, but luminal B has a worse prognosis. Patients with breast carcinoma of the same molecular subtype and receiving identical treatments may have different clinical outcomes. They may acquire resistance to hormonal therapy eventually. So there you see frequently somatic mutations in P53, PIK3CA, and GATA3 in these cases. Coming to the intratumor heterogeneity, it can be a spatial heterogeneity or temporal heterogeneity. So morphologically distinct areas within an individual tumor can be clonal. This is called as spatial heterogeneity. Temporal heterogeneity is varying histologic IHC and molecular characteristics of the primary and metastatic tumor. So tumors with very low levels of ER, even 1% of the cells are positive, they may respond to hormonal therapies. So justifying the use of 1% cutoff for the ER/PR positivity by the ASCO guidelines. So coming to the epigenetic heterogeneity. Epigenetic heterogeneity is defined as modifications in gene expression without any change in the DNA sequence. So in breast cancer, epigenetic So cell plasticity may involve epithelial mesenchymal transition and PIK3CA expression. So tumors arise from a single cell due to the either initial driver mutations initially, and later on they are added upon by passenger mutations. The tumor microenvironment, it influences the sensitivity of the tumor cells to growth inhibitors. So these 4 mechanisms, they play a role in tumor heterogeneity. Next, going to the molecular pathogenesis of breast cancer. So 1/3 to 1/4 of the breast cancers are due to this familial breast cancer syndromes, and BRCA1 and BRCA2 are responsible for 80 to 90% of the single gene mutations in familial breast cancers. So this BRCA1, majority of the cancers are triple negative breast cancers, and it is also responsible for ovarian cancers and pancreatic and prostatic cancers. Whereas BRCA2 is majority of the cancers are ER positive, luminal type, and this is responsible for ovarian cancers and also for male breast cancers. TP53, in these mutations, usually associated with Li-Fraumeni syndrome, is majority of the cancers are HER2 enriched. So this P10, STK11 and CDH1 and PALB2, these are responsible for only 1% of the familial breast cancers. And CDH1, this is associated with lobular carcinoma and also diffuse gastric cancer. And these genes are broadly classified as high penetrance genes and moderate penetrance. Whereas BRCA1, BRCA2, 53 and P10, PALB2, they are all high penetrance genes that show a 4-fold increased risk. And moderate penetrance genes are ATM genes and CHEK2 genes. So this breast till menopause, it undergoes many cycles of proliferation and involution, thus paving way for the replicative errors. So a multitude of genes play a role in breast cancer development, and breast cancer always develops in a hormonal milieu, which favors development of mutational clones. So this mammary, the genes are involved are the genes involved in the mammary gland development like FGFR2, TBX3, and genes involved in maintaining the telomeric length like TART, and growth factors which are involved in, they may play a role in tumor aggressiveness and metastasis like NTN4 and FOXP1, and genes involved in cell cycle regulation and tumor suppressors and genes involved in apoptosis like TP53, NOTCH2, CCND1, CDKN2A, and the genes coding for ER receptors like ESR1 genes, and genes involved in DNA repair like BRCA1, BRCA2, CHEK2, RAD51, PALB2, and BRIP1. All these genes play a role in the development of breast cancer. So this BRCA1 is a DNA repair or tumor suppressor gene. Whenever there are double-stranded breaks in the DNA, it repairs the DNA by homologous recombination. It also plays a role in genomic stability through various mechanisms, like it repairs DNA through RAD50 and NBS genes, and it regulates transcription through c-MYC and ETF1 genes, and it relaxes the chromatin structure, thus making the DNA favorable for repair through HDAC and RB genes, and it ubiquitinates the proteins through BARD1 and BAP1 mechanism, and it regulates cell cycle through CHEK1 and CHEK2 genes. So whenever there is the DNA damage in wild type BRCA1, the DNA can be repaired through a p53 independent mechanism or a p53 dependent mechanism. When p53 independent mechanism is through ATM. So whenever there is a DNA damage, there will be BRCA1 phosphorylation, and this recruits the complex including other genes like BRCA2, RAD, and BARD. Thus a complex is formed. It activates the checkpoints. So there is repair of the DNA damage. If they through p53 dependent, it directly activates the checkpoint activators. So mutant BRCA1 or BRCA2, the complex formation is defective and it may lead to chromosomal instability. And if the checkpoint function is intact, it may activate the checkpoints and there can be cell cycle arrest. If the checkpoint arrest is also at fault, it leads to genomic errors and breast tumor development. So this is another mechanism. Whenever there are double-stranded breaks, the mRNA complex will be activated and it in turn activates the ATM. ATM phosphorylates the mRNA complex, and this mRNA has both exonuclease and endonuclease activity. And this activation of the ATM leads to many downstream signaling pathways activation, which can result in either in apoptosis, or it can result in cell cycle arrest, or sometimes the DNA is repaired, it can lead to cell proliferation, and it can also lead to chromatin relaxation or DNA repair. So not only the DNA, the RNAs also play a role in tumorigenesis. So the long non-coding RNAs, they mediate cell proliferation, and microRNAs and circular RNAs, they play a role in apoptosis, cell signaling, and expression of ER receptors. DROSA and DICER are the microRNAs, they are associated with breast cancer progression, behavior, and outcome. So these DROSA and DICER, they act as rulers and scissors in the DNA proliferation. So according to this Mittal et al. Study, so this is Indian scenario. Out of 275 breast cancers, 35% are triple negative, and mutations in BRCA1 and BRCA2 are 46 and 19%. 34% of the mutations are in non-BRCA genes. According to another study by Muhammad Shah Qadri, so BRCA genes mutations contributed to 88% and non-BRCA genes to 11.9%. Non-BRCA genes usually involved are TP53, BRIP1, PALB2, and 18. So 17.3% are variants of unknown significance. According to this Abhanil study, the variants of unknown significance mutations are poorly defined in the Indian population. So in their study, there is a high prevalence of VUS, 15.7%, even in high penetrance genes. According to the Verma and et al. Studies, the studies from India are showing relatively higher prevalence of BRCA1 2 mutations as compared to the global data. So according to this similar study by Singh et al. And Chadda et al., the prevalence of 25 and 18% of non-BRCA mutations are seen. So the characteristic common variant of mutation is 68, in the position 68, which is a deletion. And it is most commonly seen in Western and Southern Indias, whereas in Western India, only this at position 5074, you'll see a deletion. So these are some of the common deletions and insertions or substitutions seen in the Indian population, of which the 68 to 69 deletion is the commonest. And there are some substitutions and there are very few insertions. So these are the common mutations seen in the CHEK2 and 53 genes. So according to now I'll move on to some global studies. According to Toss et al., the most common breast cancer susceptibility genes are BRCA1, 2, ATM, and CHEK2. A high rate of bilaterality is observed with ATM and CHEK2 mutation carriers. So 64% of CHEK2 tumors are luminal A-like and 56% of ATM tumors are luminal B-like. Moreover, 21% of CHEK2 related invasive tumors showed a lobular carcinoma. So the 63% of ATM mutation carriers and 64% of CHEK2 mutation carriers presented a positive family history. In the significance is contralateral mastectomy should be considered and discussed with ATM and CHEK2 mutation carriers at the first diagnosis of breast cancer. So according to this Alessandro study, mammography is the gold standard technique, but it will miss the lesions in early stages. So microRNAs present in numerous body fluids might represent a new line of research in breast cancer biomarkers, especially the oncomicroRNAs. So 34 microRNAs were dysregulated in breast cancer, of which microRNA 155 is a promising diagnostic biomarker for this patient population. So why should we go for molecular? So a proportion of ER positive tumors do not respond to hormonal therapy, indicating that other genes and pathways are involved in determining the response and behavior of these tumors. HER2 positive breast cancers are aggressive tumors with poor outcome, but associated with a response to HER2 targeted therapy. But the response to anti-HER2 therapy appears variable, and some tumors recur despite treatment, whereas more than 40% of HER2 positive patients survive without anti-HER2 therapy. So coming to the molecular taxonomy. So this is so breast cancers arise through several pathways. So we'll see a stepwise acquisition of many driver mutations and passenger mutations in these pathways. The most common pathway is the ER positive pathway. So in this, you will see, apart from the germline BRCA2 mutations, you will see 1q gain and 16q loss, and you will see a definite precursor lesions in this ER positive pathway. There is flat epithelial atypia and ADH. In this process, you will also see PIK3CA mutation. This always results in a ER positive cases. The least common pathway is the leads to triple negative cancers. In this, you will see a germline BRCA1 mutation and P53 mutations, and the precursor lesions are morphologically normal, but they may show P53 signature. This is similar to the P53 signature you will see in stick in which result in high-grade serous carcinomas. So with BRCA1 inactivation, it results in a triple negative cancers. The other pathway is HER2 enriched pathway. Here there is no definite precursor lesion. So these molecular subtypes, when you look into the prevalence and their morphological features, the luminal cases, they're around 40 to 55%. And their the most common mutation is the PIK3CA mutation. Coming to the morphology, they are tubular, lobular, mucinous, or papillary, and they affect only older women, men, and there is complete response to therapy is around 10%. Metastasis is more common to bone. The relapse pattern is low rates over many years, and in these tumors, luminal tumors, if there is bone metastasis also, the patients can be managed on anti-estrogen therapy even for 10 years or more. Whereas coming to the luminal triple negative cancers, their prevalence is around 50%. They are also called as basal-like because sometimes they may be positive for CK56, and the most common mutation is PIK3CA mutation. Usually they are not identified. The triple negative breast cancers, they may affect young women and women of African lineage, and BRCA1 mutation is carriers. The response to therapy may be around 30%. The metastasis pattern, all the viscera are common, and relapse early peak at less than 80 years. The late recurrence is there, and survival with metastasis is rare. Coming to the specific mutations according to the morphology. So the lobular carcinomas, apart from the conventional mutations seen in the carcinomas of the breast, you can also see E-cadherin loss and P10 loss. P10 loss, it increases the AKT phosphorylation and induces cell proliferation. According to the gene expression profiling, these lobular carcinomas are subtyped as reactive like immune related and proliferative. The proliferative tumors have worse prognosis, whereas the immune related tumors have a good prognosis. Coming to the mutations, the CDH is common in 63% of lobular carcinomas, whereas it is seen only in 2% of the conventional duct cell carcinomas. GATA3 is seen only in 5% of lobular carcinomas, where it is 20% in conventional and NOS type carcinomas. Coming to the secretory carcinomas, you can see a balanced translocation between 12 and 15, leading to a ETV6 NTRK3 fusion gene. Mucoepidermoid carcinomas, there is a translocations between 11 and 9, which lead to a fusion gene of MECT1 and MEM2. Coming to the adenoid cystic carcinoma, it sits in the basal group just like the triple negatives, but it has an indolent course. It can show MYB NF1B translocations or fusion genes. Coming to the ethnic cell carcinoma, you'll see germline mutations in MLH and MS1. Adenomyotheliomas, you'll see PIK3CA mutation. It leads to ER positive adenomyotheliomas, and if you see HRAS Q61, it leads to ER negative adenomyothelioma. Tall cell carcinoma, just like gliomas, you'll see an IDH mutation. Coming to the mucinous carcinoma, which has a good prognosis, you'll see low level of genetic instabilities. There is no 1Q gain or 116 loss, as you see in BRCA2 luminal cancers. You'll see PIK3CA and TP53 are also less frequent, but the fusion genes with RFC4 and LPP may be seen as specific mutations in mucinous carcinomas. Going to the invasive micropapillary, you'll see high cyclin D1 expression, high proliferation rates, and mic amplification. Coming to the triple negative breast cancers, the overall prevalence is around 15%. They cannot be treated by endocrine or anti-HER2 therapies. They can only be treated by a conventional chemotherapy. They are characterized by high proliferative activity, high mutation rates, deficiency of DNA damage repair, and increased immunological infiltrates. And you'll see areas of geographic necrosis. This coming to the mutations, PIK3CA is around only 10 to 20%, and TP53 is 50 to 80%. So according to the, they are again classified into basal-like and non-basal-like. Basal-like is again classified as BL1 and BL2. Their non-basal is classified as mesenchymal, luminal androgen receptor positive types, mesenchymal stem-like, immunomodulatory, claudin low, basal-like immune activated, and highest response to neoadjuvant chemo is seen in BL1 and least is seen in luminal androgen receptor positive types. So according to the Zonoda PK et al. Study, among all the molecular subtypes of breast cancer, luminal A is the commonest, followed by triple negative, luminal B, and HER2 enriched subtypes. The overall prevalence of TNBCs is India is high compared to other regions of the world. Differentiating TNBCs from other molecular subtypes is important to guide the therapeutic management of breast cancer. So you have started a journey from the traditional practice, and now you are embracing the complexity of a molecular classification with updates. So the traditional practice always included grading the tumor or indicating the prognosis depending upon the tumor size, nodal status, and lymphovascular invasion. Later on, you are using IHC markers, and now you have gone to the multi-gene testing. So updates on biomarkers in carcinoma of the breast. So according to this Kimberley studies, still the expert panel continues to recommend ER/PR testing of invasive breast cancers by validated IHC. But breast cancer samples with 1% to 100% of the tumor nuclei positive should be interpreted as ER positive. Samples with 1% positivity should be reported using a new reporting category, ER low positive, with a recommended comment. So a sample is considered negative if less than 1% or 0% of the tumor nuclei are immunoreactive. The status of the control should be reported for cells with 0 to 10% staining. Testing of duct cell carcinoma in situ for ER is recommended, whereas TR is considered optional. According to this Andreas study, endocrine treatment is one of the most effective therapies for estrogen receptor positive cancers, but most tumors, 50% will develop resistance to endocrine therapy. So several molecular mechanisms of endocrine resistance have been identified, including alterations in the ESR1 gene or in the PIK3CA-mTOR pathway and CCND1 amplification. So the CDK4/6 mTOR PIK3 inhibitors have shown to improve the efficacy of endocrine treatment, and new promising approaches are being developed. So this is how we used to report the HER2 3+. It has a benefit from anti-HER2 agents, and 2+ as equivocal. It has a possible benefit. So whenever you say a HER2 of 2 score equivocal, you used to subject the tissue for a fish. So this is how HER2 was reported 3+, strong, intense, complete circumferential staining within more than 10% of the tumor cells. This is how the fish reporting is modified from 2007 to 2018. So sorry, this is IHC still. So this is fish in 2007. If you are using a double probe, HER2 sub-17 ratio should be more than 2.2, but this is decreased to 2 is enough to call as positive in 2013. But in 2018, the positive group has again 4 categories. If you are using a double probe, the ratio of 2 is enough, and average if you are using a single probe, average HER2 copy number should be more than 4. And if the double probe ratio is 2 and average HER2 copy number is less than 4, with concurrent IHC is 3+, then it is also considered as positive. And HER2 group ratio is 2, but HER2 copy number is more than 6 also, and IHC is equivocal also, it is considered positive. And HER2 ratio is less than 2, and copy number is more than 6, and a concurrent IHC is 3+ is also considered as positive, and HER2 sub-2 ratio is less than 2. The copy number ratio is between 4 and 6, but if the IHC is 3+, it is also considered as positive as per the 2018 ASCO guidelines. There is no equivocal category in 2018 ASCO guidelines. What are the caveats in this IHCs? Inter and intra-observer variability is a major concern. For ER and HER2, the several studies have reported discrepancies of up to 20%. So most challenging is inconsistency of Ki-67 because it depends upon selection, subjectivity of visual estimation, method and areas of the evaluation. So efforts to standardize scoring resulted in considerable improvements, but the Ki-67 is not currently included in the ASCO CAP guidelines for routine clinical use. So according to the Meenakshi Rao et al. Study, mammoglobin, GCDFP15, GATA3 are traditional IHC markers utilized to recognize metastasis, but they are also seen in primary tumors. Of these 3, GATA3 seems to be higher sensitive, and increased staining scores are seen in primary breast carcinoma, metastatic, and also in triple-negative breast cancers. So according to this Pallavi study, the PD1 and PDL1 pathways represent an adaptive immune resistance mechanism that is exhibited by the tumor cell. So the PDL1 expression showed a positive correlation with the tumor of higher grades. It was significantly higher among breast cancers with medullary features as compared to the NOS and types and papillary types. Its expression was found to be the highest in triple-negative breast cancer subtypes. It is a potential target for immunotherapy, especially in triple-negative breast cancer cases, which lack specific targeted therapies. So coming to the molecular diagnostics. What are the indications for going into a molecular diagnostics? So different molecular subtypes are associated with different clinical outcomes. there is prognostic relevance of molecular classification to know the metastatic propensity, to identify signatures associated with prognosis, and to estimate the response to therapy. So according to this study, there are many multi-gene assays for commercial assays are available, like Oncotype DX, MammaPrint, ProSigna, and breast cancer index, and also very many companion tests to detect PIK3CA and NTRK fusion genes. So the MammaTyper is a novel reverse transcriptase quantitative PCR-based in vitro diagnostic test, which quantifies the mRNA expression of the 4 key marker genes, ERB2, ESR1, PGR, and MKA67. You can use core needle biopsies with at least 20% of the tumor cells, and you can use formalin-fixed paraffin-embedded tissues. So one study has compared this all these molecular assays, EndoPredict, Oncotype, MammaPrint, ProSigna, and MammaTyper. So in MammaTyper, the advantage is it is certified, and type of assay is only tests only 4 genes, and you can use formalin-fixed paraffin-embedded tissues. The technique is RT-qPCR, and some of the tests like MammaPrint and ProSigna, they use microarray. This is applicable in any lab, MammaTyper, whereas this Oncotype you can't apply in any lab. You need special equipment, and indications can be diagnostic, prognostic, or predictive. So all the subtypes are according to the guidelines. You can subtype the breast cancers. So in the data also, you can trace back the data. All these EndoPredict or Oncotype, you can't trace back the data. So they have concluded that MammaTyper is the best type of molecular assay according to their study. So there is another molecular assay, that is Blueprint 80 gene molecular subtyping. This also correlates its results with IHC testing. It usually tests 80 genes. 50 genes compose the luminal type profile, and 4 genes compose the HER2 type profile, and 28 genes compose the basal type profile, but 10 genes are overlapping between the 3 types. The significance is it correlates with the molecular typing with the IHC results. So coming to the circulating tumor cells, the circulating tumor cells are the cells that detach from a primary tumor and circulate in the bloodstream. They are seen in 26% of the metastatic breast tumors. So this CTC count is an independent predictor of poor survival or treatment resistance and early recurrence in some studies. The practical application of CTCs based on liquid biopsies is limited by significant molecular and functional heterogeneity of these cells. They include variability at the protein level like HER2 or ER, and gene level, PIK3CA levels, and epithelial mesenchymal transition. So during the process of this epithelial mesenchymal transition, which is thought to precede metastasis, the tumor cells lose the epithelial characters and acquire mesenchymal properties like motility and invasiveness. The presence of EMTs in CTCs indicate a poor prognosis. Heterogeneity in the circulating tumor cells represents one of the mechanisms of resistance to endocrine therapy. So due to insufficient clinical evidence, the ASCO guidelines as of now, they do not recommend changing therapy solely on the basis of CTC counts for monitoring the treatment. So the role of liquid biopsies is sometimes in analysis of the bulk tumors, you may miss some minor clones, which can be overcome by circulating free DNA and circulating tumor cells. So liquid biopsies allow the assessment of inaccessible metastatic tumors, but also monitor the dynamic changes in the tumor genome. The ctDNA has a potential use in both early and metastatic breast cancers. It can also identify minimal residual disease that correlated more accurately with genetic alterations in metastatic rather than primary tumors. According to this Paloma 3 study, early changes in PIK3CA ctDNA levels could predict response to the CDK4/6 inhibitors in advanced ER-positive cancers. Liquid biopsies may help in the selection of patients with metastatic ER positive cases for further endocrine therapy. The ESR mutation responds better with fulvestrant than exemestane. No difference is found in ESR negative cases. According to this Mazzutelli C. et al. Study, the future potential applications of liquid biopsies include identifying minimal residual disease, early detection of recurrence, and monitoring treatment response in various cancer types. The LB represents a promising non-invasive diagnostic tool with potential applications in breast cancer, diagnosis, treatment, and management. So these are some of the biomarkers for survival, but their role is uncertain. Growth and proliferation by surviving NGAL and K67, invasion and metastasis by P53, MMP9, SK1, BCR3, epithelial and mesenchymal transition is by WNT5A or PA3. So immune response can be estimated by PDL1. The therapy resistance is through PST, S3, KLK10. And the survival is estimated by microRNA 574 or microRNA 660 or PVL3 and PVL4. So this is so the old way of reporting patients' tissue sample, seeing under the microscope and looking at the morphology. But the new way is you take the patient sample of blood sample and estimate the proteomics and genomics, and looking at a microarray images, you will diagnose the disease. So these are some of the expansions of the genes. This may be useful for the postgraduates. BARD is BRCA1 associated ring domain. CHEK2 is checkpoint kinase 2. PALB is partner and localizer of BRCA2. ATM is ataxia telangiectasia mutated. ATR is ataxia telangiectasia and RAD3 related. mTOR is mammalian target of rapamycin. STK11 is serine threonine kinase. PIK3CA is phosphatidyl inositol kinase 3. P10 is phosphatase and tensin homolog. TERT is telomerase reverse transcriptase. The take-home message is breast cancer comprises a diverse spectrum of diseases with distinct presentation and biological behavior. Its response to therapy varies widely. In the era of precision medicine, molecular testing has become important, but it is still in evolution. Proper incorporation of molecular tests into clinical practice remains a challenge. So we still have a long way to go. So I acknowledge Samsirao sir and Prasad Uma madam. And these are my references. Thank you very much for your patient listening.
Thank you, madam. You are enlightened in depth of the heterogeneity of the breast lesions to molecular genetics. Mostly it is a research oriented the topic in depth madam covered. Now the topic is open for the discussion, or any points can ask by PGs, especially PGs, because you are more nearer to the near future. In depth you have to follow. Any questions from PGs? Senior PGs? I think everyone super saturated brains post lunch. Any questions, ma'am?
I request our chairpersons to honor her speaker for her valuable contribution. I request Dr. Josna ma'am, organizing secretary of the conference, to felicitate the chairpersons. Thank you, ma'am. Thank you, sir, and thank you, ma'am. The next session is on the topic diagnostic and molecular updates in pediatric brain tumors. For this, I would like to invite our chairperson, Dr. B. Tulasi Satyendra, sir, consultant pathologist, quantum specialty diagnostics, Visakhapatnam, Andhra Pradesh. Sir has multiple publications in national and international journals. Sir has received first prize for oral paper presentation and medical quiz competition at AIS MOC Durgapur in 2016. Sir has been qualified for Bruce Davis Gold Medal for Palliative Medicine in 2010. We welcome you, sir. I request sir to take over the session and introduce the speaker of the event.
Good evening, one and all. I take the pride and privilege in introducing our next speaker for the session on pediatric brain tumors. After all these brainstorming sessions in this mega feast, this is an apt topic. So I introduce Dr. Shriji Chakrabarti, who is an fellow in neuropathology from NIMHANS and is a fellow in Royal College of Pathology. He's a specialist registrar in diagnostic neuropathology, and his present affiliation is with Royal Preston Hospital, UK. He has undergone training in certificate course in bioinformatics from Manipal Institute of Life Sciences, and he has contributed several chapters in two textbooks and has approximately 50 publications in various peer-reviewed journals and books. He is one of few of which are included in WHO CNS5 publication and Osborne's Brain. So I request Dr. Shriji Chakrabarti to take on to this, carry forward the session. Thank you.
Uh, Good evening, all of you. Is my screen visible? Yeah, I can see it. It's visible now. Good evening, all of you. Sorry?
It's visible and audible.
Yes. Okay. Thank you so much. Good evening, all of you from UK. It's 9 degrees outside here, and India and South Africa match is going on. So I have been given this topic, pediatric brain tumors, molecular and diagnostic updates. As you can see from this photograph, there are so many entities. It's almost 1/3 of the book. And I have around 30-40 minutes, and this is the last session. So it's the going will be a little tough, and I'll try to go as smoothly as possible and as fast as possible so that you all can carry on with the rest of your evening. So So the learning objectives for this session would be to know about the classification and the diagnostic approaches with updates. Now this session will be divided into diagnostic approaches for gliomas, glioneuronal tumors, ependymomas, embryonal tumors, and some other tumors. Now, at the very beginning, I'll want to clarify one thing is that I will not be touching upon the genetic tumor syndromes because it would be better if it's in a separate session, because otherwise this will make it too lengthy. So I will stick with these. There may be some lesions I may have skipped out, so forgive me for that, and I may have skipped it out for a particular reason. Either it's too common or too rare and wouldn't require much of my input from my side. So let's get on with it. So if we have to classify the gliomas, they are classified as circumscribed and diffuse. The diffuse are further classified as low and high grade. I'm not going to read out all the names. You can see it on the slide. So these would include pilocytic astrocytoma, pleomorphic xanthoastrocytoma, SEGA, diffuse astrocytomas with different fusions, mutations, angiocentric glioma, plenty, and the high-grade gliomas, which are again of 4 different types. Glioneuronal tumors, most of you know about these tumors. The most common among these would be ganglioglioma and DNET. The others are uncommon and some are rare. The most confusing part is the ependymomas and embryonal tumors. I have not touched upon subependymomas or myxopapillary ependymomas. They are usually not very common in pediatric age group. So I'll stick only to the ependymomas. And in the embryonal tumors are a big category. So they are classified into medulloblastoma, atypical teratoid rhabdoid tumor, cribriform neuroepithelial tumor, embryonal tumor with multi-layered rosettes, neuroblastoma, and CNS tumor with beak or internal tandem duplication. Next is the pineal and the choroid plexus tumors, of which the newest entity is the desmoplastic myxoid tumor of the pineal region. Then comes the cellular tumors. Among craniopharyngiomas, adamantinomatous is more common in children rather than the papillary one. And then we have pituitary blastoma, Ewing sarcoma, chordoma. Only the poorly differentiated variant is common in children, and the germ cell tumors. I'll not be touching upon Ewing sarcomas and teratomas because these are frequently encountered in your practice, so you will be knowing how to deal with them. So since we are rushed for time and it's the last session, I'll be a little quick. And if you feel have any questions, you can always ask me later on. I'm not using too much of text, but it would be mostly flowcharts. So we have seen this. The grading of these tumors, I have already mentioned it before. So the circumscribed astrocytic tumors are grade 1. Low grade are definitely grade 1, and the high grades are all grade 4. So to start with, if radiology report is available or the scan is available for you to review, and the tumor is diffuse or circumscribed, then you can classify it accordingly and decide upon the differentials. If radiology is not available and you are in a doubt whether this is a circumscribed or diffuse tumor, the immunomarker which you can do is neurofilament protein. If you find axons within the tumor substance, then it's a diffuse tumor. That means the tumor has infiltrated the brain parenchyma and the axons are entrapped in it. Whereas in a circumscribed tumor, the tumor has a pushing margin rather than infiltrating the brain. So you won't find any axons within the tumor substance. So that's a good way to distinguish between circumscribed and diffuse tumors. You can use it in any tumor of the brain. Now going by location, so if we stick to predominantly infratentorial and supratentorial, so you have a tumor which has pyloid cytoplasmic processes, biphasic morphology with hypo and hypercellular areas, eosinophilic granular bodies, Rosenthal fibers, POP giant cells, and everyone knows. Mitotic activity may or may not be present. There may be some endothelial proliferation around the cystic areas in the tumor. There may be some infarct type necrosis, but these don't make it a high-grade tumor. And with this classical morphology, this would be a pilocytic astrocytoma. At this point, you wouldn't need any immunos as such. And if you just want to confirm your diagnosis, you can go for a BRAF fusion testing. If there is brisk mitosis and necrosis, there is no cutoff for brisk mitosis, then it would be a PA with histological features of anaplasia. If you see a monophasic pattern, I mean, no hypo or hypocellular areas, and you have angiocentric arrangement of the tumor cells, myxoid background, without any EGBs and Rosenthal fibers, it would be best called as a pyelomyxoid astrocytoma. Now coming to the supratentorial compartment, if you find reticulin and there are large cells, do a stain which is reticulin. And if the tumor is reticulin rich, there are xanthoma cells, spindle cells, pleomorphic cells, then and shows glial and neuronal markers positive. You can use any one, GFAP, OLIC2, synaptophysin, any one. Then it's a PXA. If it's reticulin poor, and there are three kinds of cells, fibrillary astrocytes, gemstocytes, ganglioid astrocytes, with pleomorphism, but no xanthoma cells, infiltration, lymphocytes, mast cells, and it is TTF1 positive, then it's a subependymal giant cell astrocytoma. Now they are associated with tuberous sclerosis complex. Again, reticulin poor, but rhabdoid cells and epithelioid cells with stout cytoplasmic processes abutting the blood vessels, and some trabeculae pattern, some high-grade features, and positive for both GFAP and EMA. This can create a confusion with ependymomas, and you need to do further testing to confirm this. So we'll get on with this in the next slide. So that's a SEGA, and that's how a pleomorphic xanthoastrocytoma looks with these xanthoma cells. Now, I was talking about astroblastoma. This would be one of the histological pictures for the same. And these are the various genetic alterations with the prognosis mentioned next to it. So pilocytic astrocytoma, as I said, would have BRAF fusion. Same for pyelomyxoid astrocytoma. SEGA will have TS1, TS2 mutation, and there would be activation of the mTOR pathway. And if the mTOR pathway is activated, there is a monoclonal antibody for the same. Now, pleomorphic xanthoastrocytoma would be characterized by BRAF mutation. If there is mitosis and necrosis, there is a cutoff for mitotic count, and then it would favor a grade 3. And to confirm this, one needs to do a CDKN2AB deletion study. As you can see, the prognosis is mentioned here. Even astroblastoma, as I said, one has to go for MN1, BEN2 fusion to confirm the diagnosis. But if you're pretty sure with the morphology and if you've excluded ependymoma, you can very well call it an astroblastoma. But since it's a tumor with high-grade histology, with recurrence, progression, and prognosis can be worse if there are high-grade features, it's better to go for a fusion testing to confirm the diagnosis. Now, if I go by location, if you have a diffuse kind of pattern with low-grade histology, what to call it would further depend upon RNA fusion studies. If you have a monomorphic oligo-like fibrillary pattern, oligo-like cells, fibrillary pattern, some pleomorphic cells, some dysmorphic neurons, some, but no high-grade features. One needs to go for CD34 and BRAF if they are positive. One has to further confirm it with FISH and RNA fusion. I'll come to what the diagnosis would be. Then is the tumor with angiocentric pattern with fibrillary astrocytes, but no high-grade features. CD34 positive, EMA dot-like positive again can mimic an ependymoma. Go for a RNA fusion. So as I was talking about diffuse low-grade gliomas, they would be further categorized depending upon their NGS and fusion studies. It can be categorized as MYB1 altered or MAPK pathway altered. Both have excellent prognosis. Now, the one with oligo-like cells, calcification, and some pleomorphic tumor cells, it's best to go for a FISH, and there won't be any 1p19q co-deletion because this tumor does mimic an oligodendroglioma. So FISH is required for confirmation. Then you can always go for BRAF mutation. Again, this is a good prognostically good, and it's amenable to resection. And angiocentric glioma is the next one, and that will have the characteristic MYB-QKI fusion, and excision alone is curative. So this is how you can come to the conclusion for the low-grade gliomas. This is an example of an angiocentric glioma where you can see fibrillary astrocytes, some angiocentric pattern. Again, plenty. You have very oligo-like histological features. So best to go for FISH, at least FISH for 1p19q, and excluded and rest you can cover it up with the histology and immunohistochemical workup. Now comes the nasty ones. If it's a midline location and there is mitosis, necrosis, and microvascular proliferation, but in some of these tumors, since these are midline in location and the surgeons send us a stereotactic biopsy or a small piece of specimen, you may or may not find high-grade features because that would be, again, depending upon the sampling. Just do 3 markers, H3K27M, H3K27ME3, and H3G34R. If it's midline, you can stick only to H3K27M and ME3. If H3K27M is positive, ME3 is lost, and there is no staining for G34R, you can safely call it diffuse midline glioma, H3K7 altered. If there is mitosis, necrosis, and microvascular proliferation, again, do the same stains. Go for, and if you find that H3K27M is negative, ME3 is retained, H3G34 is negative, go for NGS and RNA fusion. If only G34R is positive, then you have a diffuse hemispheric glioma, H3G34R mutant. You can further confirm it with NGS, but this is not required actually. And this is these are the various alterations which you can see. If none of the staining is positive, then the another differential which you can consider is the infantile type hemispheric glioma. Now, all these tumors have poor prognosis around 12 months or 18 months, out of which infant type hemispheric glioma has a better prognosis, maybe stretched on to 2 to 3 years, of which the ones with ALK1 fusion are the better ones. So this is how you can further, you can go about with the diagnosis for these tumors. This is just a summary of the same. Next, coming to mixed glioneuronal tumors. These are the various types. All of them are grade 1, except for diffuse leptomeningeal glioneuronal tumor. There is no grading assigned to it. Going by age group, if it's an infant, solid cystic, supratentorial, leptomeningeal, and superficial cortex location, fasciculated appearance, desmoplastic appearance with lot of reticulin calcification, both ganglion and glial components are there, then you can safely call it desmoplastic infantile ganglioma. If only glial component, it's an astrocytoma. So the choice of immunomarkers again is dependent upon you. Whatever is available in your department, you can use it. There is no hard and fast rule. For age group children and young adults, supratentorial cortical solid cystic in appearance, fibrillary glial cells, dysmorphic ganglion cells, perivascular lymphocytic cuffing, EGBs, calcification. It's ganglioglioma. And the best immunomarker would be CD34 because that picks up the dysmorphic ganglion cells very well. The next would be only a tumor which has only ganglion cells in it, and that would be called as a gangliocytoma. Moving on to the next category. Again, location. If it's intraparenchymal and in the forebrain, sheets of oligolytic cells, pennies on a plate, giant cells, clusters of pleomorphic nuclei. So again, this has a very characteristic appearance and would be OLIC2 and synaptophysin positive. You can call it diffuse glioneuronal tumor with oligodendroglioma-like features and nuclear clusters. So this can mimic a plenty or an oligodendroglioma, but the presence of ganglion cells will give away the diagnosis, which is not present in plenty and oligodendroglioma. Next, if it's a leptomeningeal-based intraventricular intraparenchymal with mucoid and microcystic areas, again, oligo-like morphology with ganglion cells, neuronal differentiation, and rare high-grade features. This is a diffuse leptomeningeal glioneuronal tumor. So this tumor is present mostly in the leptomeninges, can infiltrate into the ventricles and also the brain and the spinal cord. I'll show you the photographs of this. Now, DGONC has characteristic monosomy 4 of monosomy of chromosome 14, whereas diffuse leptomeningeal glioneuronal tumor has characteristic BRAF fusion, and you can further confirm your diagnosis with methylation profiling. This is how DGONC looks like, very oligo-like appearance, positive for GFAP, synaptophysin, MAP2, and neuronal markers. Now coming to the leptomeningeal tumor, this, as you can see, the tumor is present in the subarachnoid space. It's a hyperintense, and this is the appearance of it histologically, and that's how the immunos look, where all glial and neuronal markers are positive. These are the characteristic genetic alterations and their prognosis. So all the glioneuronal tumors except for the leptomeningeal glioneuronal tumor all have excellent prognosis. Next comes to the DNETs, myxoid glioneuronal tumors. Again, the classification is based, or the diagnosis will be based, approach will be based on the location. So if it's supratentorial and cortical and you have multinodular pattern axons perpendicular to the cortical surface, some oligo-like cells, floating neurons, and myxoid background. Whereas if it is in the septum pellucidum, sheets of oligo-like cells, some myxoid stroma, floating neurons, neurocytic rosettes, supratentorial intraparenchymal, you have papillae, and these papillae are lined by glial cells, and in the interpapillary areas there are neurocytes, whereas the next category would be mostly common in the fourth ventricle, but can also be present in the supra and infratentorial compartment, including the spinal cord and midline. These will have neurocytic rosettes and glial component adjacent to it. So you do your glial and neuronal markers, and you can arrive at the diagnosis easily. So here, this category of tumors will entirely be based on location, and then you choose your immunomarkers, study the pattern, and reach your diagnosis. Further, NGS, FISH, or methylation profiling is not very important or for diagnosis because you can pick them up. If you are stuck, obviously, you're most welcome to go ahead with the further tests, but you can reach this. Of these, the DNETs are pretty common, and rest of them are uncommon. This is how a DNET looks. These are the floating axons, and these are the these are the floating neurons, and these are the floating axon, and you have the oligo-like cells. This is a myxoid glioneuronal tumor. Again, almost similarly, it looks similar to DNET, but this does not have floating neurons, but instead it has neurocytes and astrocytes. This is a papillary glioneuronal tumor where you can find hyalinized fibrovascular cores and some tumor cells encasing these cores. If you do an immunohistochemistry, you will find that they stain for glial markers, for example, GFAP and the OLIC2. And in the interpapillary region, you will find tumor cells which stain for neuronal markers. That's what would be a papillary glioneuronal tumor. Whereas this is a rosette-forming glioneuronal tumor where the tumor cells are arranged in neurocytic rosettes. And these are neurocytic rosettes, so that's why they will be positive for synaptophysin. And the rest of the tumor component will be positive for GFAP, which will be away from the tumor. It can be both distinct or intermingled with each other. So the closest differential for this is papillary glioneuronal. So if you see papillary pattern or perivascular rosetting or pattern, if you do a GFAP, if it is lined by GFAP positive cells, it's papillary glioneuronal tumor. But if it's lined by synaptophysin positive cells, then it's a rosette-forming glioneuronal tumor. These are the various characteristic genetic alterations in all of them, and they all have excellent prognosis. Surgery alone is curative, except for if in DNET the tumor is not excised properly or incompletely, then there is a possibility of recurrence with epilepsy. Now comes the little confusing tumors, which are ependymomas and embryonal tumors. We'll go with the ependymomas first. Still, of late, it was easy to diagnose ependymomas based just only on GFAP and EMA, and just call them grade 2 or grade 3 based upon their histology and presence or absence of high-grade features. But over a period of a decade or so, research has shown that they are a heterogeneous group of tumors, and they all have different molecular signatures. So they have been classified into 3, that is supratentorial, posterior fossa, and spinal. Now, all of them have perivascular pseudorosettes, GFAP positivity, and EMA dot-like positivity. There may be some variation in histology, but overall they would be characterized by rosettes. So if you have a tumor like this, and you have done the initial 2 markers and they have come out to be positive, and if it's supratentorial, just go for cyclin D1, and if you have P65 or L1-CAM, you can go for it. These tumors will also harbor Zrela fusion, and this would be a supratentorial ependymoma, ZAFTA fusion positive. So you can arrive at the diagnosis only with this. You don't need further workup. But for this, you would need further fusion studies, and this would be a YAP1 fusion supratentorial ependymoma. Now, distinguishing between these two is necessary because the ZAFTA fusion one has a poorer prognosis. If it's in a posterior fossa, do H3K27ME3. If it's lost, and there are no copy number variations on NGS on methylation profiling, then you can safely call it posterior fossa A type ependymoma. If ME3 is retained and copy number variations are present, it is posterior fossa B type. And again, distinguishing between these two is important because the posterior fossa B type has a poorer prognosis. Now, coming to the spinal ones, if there is loss of chromosome 22, then it's a spinal ependymoma 2. Now, you may not need to do a chromosome 22 loss study if you can rule out this one, which is if you do FISH, it will have MECAN amplification. So if you find a spinal ependymoma with lots of high-grade features, go for FISH. If it shows MECAN amplification, then it will be an MECAN amplified ependymoma. If it is not showing MECAN amplification, then you can safely call it spinal ependymoma grade 3 in view of the mitosis and necrosis. And finally, all these can also be picked on methylation array. But overall, I think you can get to the bottom of the diagnosis only with immunohistochemistry and FISH, and in only one case you may need to do the fusion studies. Coming to embryonal tumors, location, these are the various locations possible. We'll start with the posterior fossa. You're all aware of this. These will have sheets of small round cells, nodules, very high-grade histology, and that would be an medulloblastoma. Now, that's where the trouble comes, and you have so many categories of medulloblastoma, and all these categories need to be classified because the prognosis is very, very different for all of them. Now, in your lab, if you don't have methylation profiling and you have only immunohistochemistry, beta-catenin is usually present in all histopathology departments, but you need to get hold of YAP1 and GAB1. Now, if you have beta-catenin positive nuclear, then it's a WNT activated, whereas if it is cytoplasmic, it can be any of these three. Now, the YAP1 is positive for WNT and SHH activated. GAB1 is positive only in the SHH activated, whereas P53 is positive only in SHH activated, which is TP53 mutant. So with this pattern, you can arrive at a conclusion of what kind of medulloblastoma it would be. And but as you know, immunohistochemistry does throws up challenges and surprises. And in that case, you may have to resort to methylation profiling. So as I was telling, these 4 immunomarkers are important. And that's where the prognosis differs. And these are the various other copy number variations of chromosomes which may be possible. Now, if it's a WNT, non-WNT, non-SHH medulloblastoma, one has to do a MECAN amplification. If it's present, it has a very poor prognosis. Similarly, it can also be seen in SHH activated TP53 mutant. If there is a MEC amplification, again, it has a poor prognosis. So MECAN amplification study is required. So basically immunohistochemistry and FISH, if possible, methylation array, or else you can safely give out the diagnosis. Histological subtypes are not very helpful because there are lots of overlaps between the histology and the molecular subtypes. Now, next, coming to the other tumors. So if it's located anywhere in the neuroaxis, it has epithelioid cells, rhabdoid cells, intraplasmocytoplasmic inclusions, mitosis and necrosis, and it will be positive for glial, mesenchymal, neuronal, and epithelial markers. You can choose any marker you wish to, but it will characteristically show loss of INI1 staining and BRG1 staining. Everyone is aware of this tumor. This is atypical teratoid rhabdoid tumor. If it's a periventricular, And the tumor cells are cuboidal, medium-sized. They are arranged in strands, cribriform network, true rosettes. EMA is positive. GFAP is variable. Tyrosinase and neuronal markers are positive. There is loss of INI1. This is a CRINET, that is cribriform neuroepithelial tumor. Now coming to the cerebral hemisphere, multilayered true rosettes with neuronal markers being positive, LIN28 being positive, CD99 being positive, and has alterations such as C19MC alteration, DICER1 mutation. This would be an embryonal tumor with multi-layered rosettes. I'll show you the photographs in the forthcoming slides. So if you have multi-layered rosettes and if you have synaptophysin and CD99 in your department with LIN28, you can safely diagnose this tumor. Again, poorly differentiated cells, some homozygous rosettes, mitosis, necrosis, and these are the markers which would be positive, of which the characteristic one would be TTF1. And you can safely arrive at the diagnosis of CNS neuroblastoma, FOXR2 activated. Now, this is a very uncommon or a rare tumor, pretty baffling histology. You can get any kind of pattern from sheaths to cribriform to perivascular rosettes to epinemal-like look, oligo-like look, or a glioma-like look. And these are the immunomarkers which would be positive: CD56, OLIG2, GFAP, and BCOR would show nuclear positivity. If you don't have BCOR, it's best to go for BCOR tandem duplication study, and this would be the tumor respective to that kind of molecular alteration. This is how a CRINET looks with loss of INI1 and tyrosinase being positive. This is how embryonal tumor with multi-layered rosettes looks, quite aggressive histology and multi-layered rosettes. And as I was speaking about BCOR, so you can see there are so many different histological patterns to it. So it would be positive for BCOR, nuclear, and CD56 synaptophysin, and even GFAP. And this will have necrosis in some areas. This is the prognostic chart. So as you can see, none of these tumors are very good, of which, and in many cases, the data is insufficient to let us know what would be, but cribriform neuroepithelial tumor has a long-term survival. So if you have fallen asleep, please pinch yourself. I am getting close. I think I have another 10 minutes to go.
Yes, sir.
Yeah. Now, these are the tumors, pineal tumors, choroid plexus tumors. You all have read about it, dealt with it. I'll go through them quickly, of which the mostly important ones would be a pineoblastoma and desmoplastic myxoid tumor of the pineal region. So actually, there are no definite immunomarkers which can tell you difference between a pineocytoma or a pineal parenchymal tumor with intermediate differentiation. So these are the markers which are positive. But PTPR and pineoblastoma, PTPR will be CD56 positive, and pineoblastoma, which you can mistake for other embryonal tumors, it's better to go for INI1 and BRG1. They would be retained. LIN28A would be negative. This is just to exclude an epinemal tumor with multi-layered rosettes, whereas the desmoplastic myxoid tumor of the pineal region has a characteristic histology I'll show you in the forthcoming slides. And these are the various other mutations which would be present. So important to understand here is the cytology. If it's very bland, nice rosettes, go for pineocytoma. Again, more densely cellular rosettes here and there presence, not very frequent. It would be grade 2 bar 3 PPD ID. And if you don't find any rosettes, it's just sheets of small cells with high grade histology. it would be a pineoblastoma. If it's a papillary pattern, you can safely go for a pineal tumor of the papillary region. And differentiating between them is important because, as you can see, the outcome of survival of these tumors are very different. So papillary pattern, and you have neuronal markers being positive and some glial markers, not in the tumor cells, but in the intervening parenchyma. This would be a papillary tumor of the pineal region. Again, cords of cells, some hyalinized stroma, desmoplasia. Again, a lot of desmoplasia cords, some mitotic activity. This would be a myxoid tumor of the pineal region. And that's how the GFAP, Mason trichrome showing the desmoplasia, and Alcian blue showing the myxoid background. So you can see these are GFAP positive, EMA being positive in the perinuclear region. INI1 is retained. So we are getting close to the session. Just hold on for a couple of more minutes. Choroid plexus papilloma, these group of tumors. So you can easily diagnose a choroid plexus papilloma. The trouble comes with atypical and the carcinomas. Atypical, there are mitotic cutoff criteria, which is mentioned here in the table. But the biggest problem is whether this is a choroid plexus carcinoma or a metastatic carcinoma. Again, you have to correlate with histology, clinical features, CT scan of the thorax, abdomen, and pelvis, look for any primary tumors. And then you can do certain group of immunohistochemistry to find out what this tumor is. However, a Vimentin and an S100 would be negative in a epithelial malignancy, whereas it would be positive in a choroid plexus carcinoma, and that's how you can arrive at a diagnosis. Just to rule out the other tumors, you need to do an INI1, which will be retained in this. Cellular tumors, very easy. Sorry. All of you have seen adamantinomatous craniopharyngioma. It's a common MD exam slide. So would be your medulloblastoma, GBM, obviously not a pediatric tumor. Pilocytic astrocytoma is an MD exam slide. SEGA is an MD exam slide. And you can differentiate between these two based only on histology. But if you have some problem, then you can go for BRAF immunostaining. So the BRAF will be positive in papillary craniopharyngioma, and beta-catenin will show nuclear positivity in adamantinomatous craniopharyngioma. Both have excellent prognosis. Now, pituitary blastoma, though this is a pediatric tumor, but it's more in the endocrine group. Just to touch upon it, this is a rare triphasic tumor. There would be a component of blastemal cells, adenohypophyseal cells, and Rathke's pouch epithelium. And the different types of cells will show different immunohistochemical patterns. Since this shows ACTH, this patients will present with Cushing syndrome, and the epithelial cells will also be positive for CAM 5.2 and EMA. This will have DICER1 alteration, which is very characteristic for this tumor. So this would be a pituitary blastoma. Chordoma, all of you have seen chordomas in your practice. Mostly it will be in the skull base. But the one which is common in children is the poorly differentiated chordoma, unfortunately. And based on the location, you can narrow it down to this entity. So it will be mostly in the skull base rather than in the sacrococcygeal region. Now, to differentiate it from other three types, that is chordoma, chondroid chordoma, and dedifferentiated chordoma, the poorly differentiated one will have loss of INI1, whereas in the previous three, it will be retained. Rest of the markers, which is brachyury, PAN-CK, EMA, S100, will be positive in all four of them. So the only way to differentiate it from the other chordomas is the loss of INI1. And the histology, as you can see, is not very characteristic. Again, solid tumor with some vacuolated cells. You won't find any physalis cells, but a high degree of mitosis and necrosis. So you can see here, INI1 is lost, and this is brachyury, which is showing SMARC B1, nuclear positivity. Differentiating between them is important because the poorly differentiated one has a median overall survival of 48 months. So take-home messages, basically, once you get a tumor, list out the differentials based on the location and use markers wisely. We here don't tend to do GFAP much because if we can figure out if it's a glial tumor or then we don't do a GFAP. I mean, it is not true that in UK we do have free hand over any number of immunomarkers. We don't have. We do have to follow certain departmental guidelines and NICE guidelines set up centrally. So yes, if for difficult tumors, we use it judiciously. Otherwise, we use it wisely. So the markers which we prefer for glial tumor here is more of an GFAP. We don't tend to use much of OLIC2. For neuronal markers, again, it depends from department to department, but most of the consultants prefer to use NEU-N and synaptophysin. But for dysmorphic neurons, the best marker is CD34. However, chromogranin A can also be positive in that. Most neuropathology departments would have HTK27M, G34R, BRAF immuno, STK27ME3, INI1, BRG1. These are the essential markers. And these will help you to arrive at a diagnosis easily. And many other markers such as YAP1 and GAP1 are important for centers who do a lot of pediatric brain tumors. Now, if you have a diagnostic dilemma, then go for NGS and RNA fusion studies. And the last resort will be methylation profiling. There are around 16 neuropathology centers here in UK, and pediatric neuropathology is done again by a limited number of centers. Now, since this is a pediatric case, the government or NHS has given us free hand to use any number of markers and molecular tests. So essentially, all cases go for all kinds of immunos, NGS, RNA fusion, and methylation profiling because we don't want to land up in trouble. Now, suppose the case comes to a adult neuropathologist. I mean, neuropathologist dealing with adult cases who does not have access to everything. He would do the initial workup and then send it to the main center for further workup and confirmation. But as I've shown that most of these tumors can be picked up on location immunohistochemistry and some basic FISH and NGS. So NGS, RNA fusion, and methylation profiling is required not only for diagnosis, prognosis, but also for targeted therapy. Methylation profiling is mostly useful for high-grade tumors and for diagnosis and in some cases for prognostication, obviously. So it's better to do methylation profiling for high-grade tumors. You don't want to miss out if any subgroup of an high-grade tumor has a better prognosis. That would be good for the parents and the children. So it's better to go for it. Yeah, with this, I finish my presentation. I think I've stuck to my time. Maybe I've overstepped by 5 minutes, I suppose. I'm sorry I had to go fast because this lecture, this topic was too extensive. I would be happy to give away the presentation if it's of any benefit to the audience, especially the postgraduate students. I mean, I'm free to take questions. Thank you. That was just a cartoon. Sorry, I'm not able to hear anything.
Sir, can you hear us, sir?
Yes, now I can hear you. Thank you.
Thank you, Dr. Shriji, for presenting such a wonderful presentation. And I hope this will be very beneficial for the audience up here. And now this session is open for questions, if any. I thank you, sir, for once again for this presentation.
Thank you. Thank you.
Sir, we request you to add some token of gratitude, which will be sent to you by the post, sir.
Yeah, thank you so much. Thank you so much for the opportunity. The organizing chairperson, the technical team, the scientific committee, thank you for contacting me and giving me an excellent opportunity to present such a rather difficult topic, actually. I hope I have been able to do some justice.
Thank you, sir. Now I would like to call upon Dr. Arundhati Ma'am, Associate Professor, Department of Pathology, AIMS, Mumbai, to felicitate the chairperson.
తీసేయాలా బ్యాక్గ్రౌండ్ పెట్టాలి బ్యానర్ పెట్టాలా తీసేయాలి బ్యానర్ పెట్టాలి పేరు ఎవరిది ఇప్పుడు నెక్స్ట్ ఇది నెట్వర్క్ వైఫై ఇది హాట్స్పాట్ తో నడుస్తుంది ఇదే ఇంకా ఆడిటోరియం వైఫై ఏ హాట్స్పాట్
Sir, thank you, ma'am. Up next is recent diagnostic and molecular updates in other disease biomarkers.
ఆడిటోరియం వైఫై రిఫ్రెష్ అవుతుందని హాట్స్పాట్ కనెక్ట్
Dr. Rajshekar Raghupathi, sir, Assistant Professor, Department of Neurosurgery, AIMS, Mumbai. Sir has multiple publications in various reputed national and international journals. Sir is the recipient of several awards, including Best Paper, Best Outgoing Student in Surgery, and Gold Medal in various MBBS subjects. His area of interest are skull-based neurosurgery, skull-based meningiomas, spinal lesions, vascular neurosurgery, and epilepsy surgery. Welcome, sir. I request sir to take over the session and introduce about the next expert speaker.
Thank you, ma'am. Now I invite Dr. Shilpa Rao, Associate Professor, Finance, Bangalore, to speak on the topic of adult diffuse gliomas. Ma'am is a recipient of various national and international awards for her excellent research work, and she has published various book chapters and publications, research articles in national and international journals. And she is currently organizing a funded project on analysis of mitochondrial alternations in glioblastoma such development. So may I request Dr. Shilpa Rao to start her presentation.
ఇక్కడ రిపీట్ అవ్వట్లేదు అతను పెడతాడు
Session, and you will all be so tired. So I will try to cut down whatever I was going to present and keep it very basic and simple so that we finish. I'll try to finish in half an hour. Will not take 45 minutes. So I'll be dealing about recent diagnostic and molecular updates in adult glioma. Before going into the update in adult gliomas itself, it is important to know how we have evolved into the current 2021 classification. So if you can see this stepwise evolution,
మళ్ళీ రీస్టార్ట్ చేయాలి
see
ప్రాసెసర్
that the first
కరెంట్ పోయింది ఎప్పటిదాకా
classification was in
మొత్తం
1920.
పిక్సెల్స్ అక్కడ
Based
ఇక్కడ
on the histological resemblance of the tumor cells to the normal counterpart. Then came up the WHO editions. Then the molecular was introduced in the revised 4th edition. And currently we are in the 5th edition, that is the 2021 classification of CNS tumors. So why I'm dealing with major changes is because all these changes will somehow or the other be applicable to the adult gliomas. So in WHO CNS file itself, there is a change in the tumor taxonomy. Tumor grading has changed. There is a lot of restructuring of tumor groups. Lot of new tumor types have been introduced. Very importantly, we have the terminology such as NOS and NEC which are introduced, not otherwise specified and not elsewhere classified. And very important thing is to note that in diagnosis of some tumors, DNA methylation profiling has been made essential. It is recommended to report the CNS tumors in a layered format where you have the pathology, you have the molecular, and then you have the integrated diagnosis. So what do we mean by changing the CNS tumor taxonomy? Limit ourselves to adult type. You do need genetic testing. It may be in the form of biopsy, but you do need to test them to give a specific diagnosis like astrocytoma, IDH method, or glioblastoma, IDH wild. And no longer we use the terms entity variant. All these tumors are tumor types and we have subtypes. So the term entity is replaced by type and variant is replaced by subtype. Coming to change in tumor grading, again it is applicable to all the CNS tumors. There is a change from the Roman to Arabic numerals because there was a lot of transcription errors when the Roman numerals were used. And we now call everything as NSW2 grade to distinguish it from the others. So within tumor types, we now have grades, not giving it separate names. What do we mean by that? We do not call grade 3 astrocytoma as an anaplastic astrocytoma. We do not call grade 3 ependymoma as anaplastic ependymoma. Everything is now termed as its tumor type followed by the grade which will become a subtype. So we don't have anaplastic astrocytoma, we don't have anaplastic oligodendroglioma. There is no anaplastic ependymoma, but anaplastic meningioma is still there. And there is a combined histological and molecular grading. What do we mean? In astrocytoma IDH mutant itself, CDKN2AB homozygous deletion upgrades the tumor. Glioblastoma IDH wild type can also be diagnosed based on certain molecular alterations, which I will be discussing later. There are certain tumors where grades are not assigned, and similar to other systemic malignancies, where WHO has recommended that mitosis be counted per millimeter square, not per 10 ppm. So I told you there are two important terminologies that we need to know. This is very important because most of the centers may not have the molecular testing available. So what you need to do is, if you are diagnosing based on only histology, you need to use this terminology called as NOS, which stands for not otherwise specified, where all the tests that are required for making a diagnosis as recommended by the WHO is not available. Then you can use the term NOS. That means that the particular tumor needs to be tested at a highest level for further molecular alteration. But when do we use NEC? NEC is used when you have done all the tests, but you are not able to arrive at a specific diagnosis, which is in the WHO. Then you can give the NEC terminology, which is a very rare event. We will not be using NEC terminology. Most often, what we will be using is the NOS. So all of us need to know about the NOS. And skip the gene. Then very important and useful part in the new WHO is they have introduced what are essential and desirable diagnostic criteria. So if you have that doubt at any point of time, just open the WHO book, see what are the essential criteria, see if your tumor fits in with those essential criteria, and you can go ahead with the diagnosis. Desirable diagnostic criteria are not must to have. They will only support your diagnosis, but essential criteria are always required to give a specific diagnosis. Now, if we look at the WHO CNS5 classification after going through what are the major changes in a very simplified way, this is how the entire classification looks like. We have a whole group of glioma, gliorenal, and neuronal tumors, in which most of which has been covered by Dr. Srijit in the previous talk. And then we have these again pediatric tumors which have been covered. In the adults, you see mainly the non-sheath meningiomas, other mesenchymal tumors, hematolymphoid tumors, germ cell, tumors of the cellular region, which mostly include the pituitary tumor, and also CNS is a major site for medicine. So what we are going to concentrate here today is the adult type diffuse glioma. Glioma means, the term itself means that these are tumors which arise from glial cells. So glial cells can be of astrocytic nature, oligodendroglial nature, or ependymal. Those which arise from the ependymal cells are ependymoma. Those which arise from astrocytic and oligodendroglial, they are oligodendrocyte-like cells, can be diffusely infiltrating or they can be circumscribed. Again, circumscribed has been dealt with in the previous talk. Diffuse gliomas in the 2021 classification are now recognized separately as adult type and pediatric type. So till the previous classification, these were all combined together, but now it is very well known that the adult type diffuse gliomas are driven by IDH, whereas the pediatric type diffuse gliomas are driven by other molecular alterations. Hence the distinct categories of adult type and pediatric type. So that is the change that has happened from 2016 to 2021 classification. We will look more in detail about the adult type diffuse glioma. So you have three types of adult type diffuse glioma: astrocytoma IDH mutant, oligodendroglioma IDH mutant and 1p19q4 deleted, and glioblastoma IDH wild. So what is a very important thing to notice here is all the astrocytomas are by definition IDH mutant only. You do not have a IDH wild type astrocytoma. And all the glioblastomas are IDH wild type. You do not have an IDH mutant glioblastoma. So this is a change that has happened from the previous classification. So whenever you have an IDH mutant tumor, even if it has the features of microvascular proliferation necrosis, it will become an astrocytoma grade 4. You should not call it glioblastoma anymore. So those become the subtypes. In astrocytoma, you have three subtypes, grade 2, 3, 4. In oligodendroglioma, you have only grade 2 and 3. There is no grade 4 in oligodendroglioma. So to diagnose these tumors, what are the simple markers that we have to use? So first of all, you should have the clinical details, radiological details, and on histology or morphology should be very good. After that, you need to test for IDH, ATRX mutation, and 1p19q coordination. So we look at these little bit in more detail. What is IDH? It is isocitrate dehydrogenase, which is an enzyme which converts isocitrate to alpha ketoglutarate. Normally, that is what happens. we call it IDH wild type.
This one because of the
You cannot So in that case, you can see there is a R134G, which is not picked up by IMG, picked up on sequence. So we have a R134G. That is the non-canonical mutation. In these cases, you need to look for the mutation by sequencing. Okay. So till the previous classification, all these were known. Slight change in the terminology happened. You need to do the IDH 1B93 correlation. But now for grading, you have to also do FISH for CDKN2AB homozygous deletion. Okay. So why? Because a lot of studies did find that presence of CDKN2AB homozygous deletion in astrocytoma IDH mutant tumors tends to have a worse prognosis. So this CDKN2AB homozygous deletion, it actually results in an uncontrolled activation because it encodes for tumor suppressor genes. However, the frequency is not very high. You need to know that it increases with the grade of the tumor. So how do we assess? Again, we can do it by FISH, but here you should not see any red signal because we are interested in homozygous. Heterozygous will not count. We are interested in the homozygous deletion. So, irrespective of the histological feature, if there is CDKN2AB homozygous deletion, then the tumor becomes CNS WHO grade 4. Okay. So, in grade 2 and grade 3, you should not have CDKN2AB homozygous deletion. In grade 4, you will have CDKN2AB homozygous deletion. So, if there is an astrocytic tumor which is IDH mutant, ATRX loss, has say only 2 to 3 mitosis per 10 hyperfield, no MVP, no necrosis, then you will do CDKN2AB. If it is deleted, even though there is no MVP necrosis, it will be a grade 4 tumor. So, to just summarize how we approach tumor, which is IDH mutant. So, you have histology, you do IDH, ATRX, 1P19 correlation where required, CDKN2AB where required. So, what are the platforms? IDH1 R135H can be detected by IC, ATRX, P53KS67 by IC. For the rare IDH1-2 mutations, you need to go for sequencing, and these two can be detected by simple FISH technique. When do we call it something as wild type? When you have also shown that it is not having a rare mutation. So that was all about the IDH mutant adult type diffuse melanoma. The third type is the glioblastoma IDH wild type. What happened again? Previous classification had the IDH wild type astrocytoma group, but a lot of studies did find that these IDH wild type astrocytomas actually behaved like a grade 4 tumor. They were not behaving like a grade 2 or grade 3. There were certain molecular alterations which did play a role. So, taking into consideration these molecular alterations, now it is recommended that whenever you have a diffusely infiltrating adult glioma, and it is not having MVP necrosis, but it is IDH wild type, then you need to test for these molecular alterations. If one of these is present, then it becomes a glioblastoma IDH wild. What are the 3 molecular alterations? EGFR amplification, gain of chromosome 7, loss of chromosome 10, and third promoter mutation. So all of these may not be present. Even if one molecular alteration is present, that is enough. So here goes the WHO criteria for glioblastoma IDH wild type. It should be a wild type for IDH, diffusely infiltrating tumor. Histologically, you can diagnose by multivascular proliferation or necrosis. In its absence, either third promoter mutation, EGFR amplification, or gain of chromosome 7, loss of telomeres. So histologically, you may see these endothelial proliferation, which look like glomerulus, so called as also glomeruloid proliferation. Or you can see necrosis, this very nice palisading necrosis can be there, or you can have large area of geographic necrosis. For EGFR, again, we can use a simple FISH technique. Here we don't look for deletion, we look for amplification. So the ratio to set7 should be more than 2. Similarly, we can also test for gain of chromosome 7 or loss of chromosome 10. On the other hand, third promoter mutation, you need to do DNA sequencing. Remember that a third promoter mutation is not specific to glioblastoma. It can be present in oligodendrogliomas as well. There it does not confer the poor prognosis. Only when you have an IDH wild type diffusely infiltrating astrocytic tumor, it does make sense. So one molecular alteration cannot be taken as a diagnostic marker. It should be taken in the context of your histology and the clinical finding. So one exemption to the rule of doing sequencing is if you have a GBM IDH wild type in a patient who is 55 years and above, you can call it wild type without doing sequencing. Because the incidence has been found to be less than 1%. So if the patient is 55 years and above, just do IDH for There is another molecular testing that is NGMT promoter, which is important not for diagnosis but for prognosis. Suppose you have some patient who has GBM and they want to know how the patient is going to respond to treatment. So all these patients are treated with the chemotherapeutic agent called as temozolomide. So how this temozolomide works is it causes break, okay, and causes cell death, the DNA break. Whereas the MGMT in its normal functioning state will cause the repair. So the cell death is avoided and the effect of the chemotherapeutic agent is lost. Hence, if the MGMT is silenced by the promoter methylation that happens within the tumor itself, then it cannot repair the cell. So the temozolomide is effective and the patient's tumor will respond well to chemotherapy. So if the patient's attenders or your oncologist is asking you for any specific test in all these high-grade gliomas, MGMT promoter methylation is very essential. There are three subtypes of IDH wild type GBM. One is reticular glioblastoma, second is gliosarcoma, and the third is giant cell glioblastoma. So the name itself tells you that these reticular glioblastoma cells are resembling more of epithelial cells. They don't have the glial nature much. They are also located on the surface, so more often they are confused for a metastatic tumor. But as pathologists, we should be aware that this is the type of GBM. And one molecular alteration which is very important in these tumors is BRAF mutation, which is you know about that mutation with a lot of other tumors in the body. And the significant slide that you have targeted there. Hello. Giant cell GBM, again as the name suggests, you will have a lot of these pleomorphic multinucleated giant cells. And gliosarcoma is a bifacial tumor where you have the glial cells interspersed amongst the sarcomatous cells. So how can you prove it? You can do a GFP stain, only the glial cells will be positive, whereas the mesenchymal cells will already be negative. So all these are basically IDH wild type glioblastoma. So don't get confused that there are some other tumor type. They are all under the broad type of glioblastoma IDH wild. So because I have told you a lot of things, I think it would be appropriate for you to wake up now and see this flowchart, which is very important. It's what you will be doing day in and day out if you'll be dealing with neuropathology biopsies. So if you have a grade 2 or grade 3 diffusely infiltrating tumor on histopathology, as I told you, you will do IHC first with IH, KTRX, P3, and KF67. Let us first take the group of tumors which are IH positive on IHC. If they show ATRX loss and P53 positive, you will call it astrocytoma IH. Then to accurately grade it, you would require to do CTGFP, homozytes deletion. If it is deleted, it will become a grade 4 tumor. If it is not related, it will remain as a grade 2 or 3 depending. On the other hand, the ATRX contains negative tumors which are 1p19 deleted will be called oligodendroglioma, IDH mutant and 1p19 deleted. If it is not co-deleted, it will be again astrocytoma IDH mutant, and then you have to follow the same path. So the IDH positive tumor, it is easy to follow the path. The problem comes when you have an IDH negative tumor. Okay, so if you have an IDH negative tumor, the initial steps will be same, but since you don't have IDH positivity, you will have to go for sequencing to identify the rare mutation. So if it is mutant again on sequencing, you are safe because you follow the same path that we discussed in the earlier slide. The problem comes when it is wild type even on sequencing. Then you have to start thinking of the glioblastoma identified, for which you need to do these 3 tests and prove either one to be present. Also remember that we keep talking about adult type leukocytoma and pediatric type leukocytoma. It doesn't mean that adult type and pediatric type are limited to those age groups. So the pediatric type gliomas can occur in adult. The adult type diffuse gliomas can occur in pediatric. It's just that they're more common in adult and they're more common in pediatric. So if you have a 23-year-old patient and if you do testing only for, if you think only in lines of adult type diffuse glioma, you will miss out the pediatric type diffuse glioma. Okay. So the histone mutations testing should also be done in adult patients. It does not mean that they are exclusive. Please remember that. That is a common notion that people have, that these molecular alterations are restricted to those age groups. It's not true. So now when we have an IGX wild type tumor, which is ATRX loss, the first thing you need to do is rule out the histone mutant tumors because they also have ATRX mutation. The other arm is like your oligodendroglioma, which will show multi-nucleotide production. So what I want to emphasize in this slide is this group. Once you have an IGX wild type group, you have to do a lot of, you have to start thinking laterally, don't go in one direction. So again, midline tumors, which could be in the thalamus, which could be in the brainstem or the spinal cord. We need to always test for H3K27M, ME3, and EGIP. All these are IC markers which can be easily performed. So if it is showing M positivity, it will become a H3K27M mutant. If it is showing EGIP overexpression, then that is also another tumor type. And then you can have the NOS category when you are not able to categorize with whatever IHCs you have. So these are the 3 very important slides. I hope it is clear for whoever is listening. Okay, how we approach the diffuse glioma adult type, and there can be an overlap with the pediatric age group as well. If we have to deal with other adult gliomas, we have dealt with adult type diffuse glioma. So a lot of, again, if you see ependiomas, there are tumors which do occur in the adult category as well. Meningioma is another group of tumor which does occur in the adult group. If we had this talk earlier, I would definitely dealt with those, but I think now all of you are exhausted. I don't want to bombard you with more. Just the final message that I want to drive home to all of you is, it may seem very complicated that we are doing a lot of molecular testing. You may feel, why is it all required? But we have to think from patient point of view. A lot of these molecular alterations are targetable, although not in routine practice. A lot of these drugs are in clinical trials, and it is essential for us to look for these molecular alterations. Okay, so I will stop the talk here.
Thank you, madam. That is an excellent summary of the current standards in adult glioma classification. And I request audience to ask any questions.
Logo.
Yes, please. Mike, please.
Hello. You go down. Down look. Well.
I wanted to ask about the IGH1 expression. Is there a cutoff value for IGH1 expression? That is my first question. Okay. And second is regarding loss of attract. So basically, if it is IGH mutant glioma, so some literature says that even 10% loss can be taken as attract loss. So, but it's not given in WHO. WHO says only about 353 mutations. More than 10%. So
ఇటు నుంచి వెళ్ళు అటు వెళ్ళి మళ్ళీ వైర్లను
we can go for 1P94 prediction, and based on that, we can decide. But is there a cutoff for attracts loss?
Okay, so IDH, you generally don't have any problem. It will always be positive in the tumor cells, wherever you have tumor cells. And if the surgeon has given you the infiltrating front, you will find fewer tumor cells. If you have the bulk of the tumor in which you are doing IDH, it will always be definitely positive. So there is usually no problem with IDH. The problem comes with ATRX. It is a very sensitive IHC marker. So a lot of times it is dependent on how well the tissue is fixed. It is a very sensitive marker. So what you need to do in such cases is, if you have majority of the tumor cells, more than 50-60%. Again, it is not given in any book, it is only out of experience. If you have more than 50% or 60% of tumor cells showing loss of expression, then you can take it. Otherwise, you have to advise 1P93 as you said. So it does give problems, ATRX especially.
The reason why I asked for the IDH one is we are getting a lot of blocks from outside. So
Okay.
basically the processing is not optimum.
Okay.
And because of that, we have heterogeneous expression of IDH one in a lot of cases. So that is the reason why, because we expect it to be diffused, but if it is a heterogeneous expression, how do you go about it? Should you suggest for a molecular?
I don't think so. Once you see IDH mutation in even few cells, it means that you are listening.
Thank you, ma'am.
Any other question from the audience, sir?
Ma'am, what is your take about IDH2 in cases of wild type on preliminary cases rather than going for sequencing IDH2 by IHC?
There is no IHC specifically available for IDH2. We have to go for sequencing.
Okay.
We have to do sequencing to identify the IDH2.
The R172 that's one.
None of us are using.
Okay.
And it's quite rare. Even when you have IDH1 R132 negative, when you try to do the sequencing, most of the mutations come in IDH1. So the IDH2 R172S, KW, all that you get are very rare.
Ma'am, just one more doubt.
Okay.
This is regarding glioblastoma. Does OLIC2 have any role in glioblastoma?
So like I showed you in the flow chart, if it's a young patient or a adolescent, young adult till 30-40 years, we do practice doing OLIC2. It's a good marker. It helps you pick up a lot of unexpected tumors. If it is positive, it will not help you. When it is negative, you need to start thinking that it is not a typical adult type diffuse glioma. You may be dealing with a pediatric type diffuse glioma. The histone HCG34RV tumors are OLIC2 negative, although they are diffuse infiltrating, their ATRX loss, but they will be OLIC2 negative. So a simple IHC marker like OLIC2 can give you a big clue. Even if you don't have the histone marker IHC available with you, by just seeing these markers being positive, it could suggest. And sometimes in a small biopsy in the spinal cord, you will have a problem with a pyrocystic astrocytoma or an epidermal. Again, OLIC2s are negative in epidermal. So it again helps you. So personally, yeah, I like the marker and we do this.
Thank you, ma'am.
QR code ఉంది అది డిస్ప్లే చేయాలి నీకు ఎట్లా పంపించాలి
So regarding prognostication,
WhatsApp,
is the histology materials.
Yeah,
In the sense that even though it is benign,
number చెప్పు
IDH wild type,
9347
two
086
grades of IDH
16
mutant will have similar prognostication.
Almost similar.
Almost similar. Thank you. Thank you. With this, we conclude this session. Thank you.
I request Dr. Rajshekar Ekapati sir to honor our speaker for her timely contribution.
Thank you, sir, and thank you, ma'am. I request Dr. Sunil, sir, Treasurer and Assistant Professor, Department of Pathology, AIMS number 3, to felicitate the chairperson.
కెమెరా పోయింది మన బ్యాటరీ అయిపోయింది కెమెరాలో. ఆ కెమెరా అంటున్నా కెమెరా అంటున్నా.
Thank you, sir. Finally, importantly, we are stepping into the final session of the conference. Now, I feel privileged to invite our seasoned scholar, Dr. Kumar Reddy Panyada, PhD.
We'll start the quiz. We'll show the QR code. Once everybody joins, then they can.
అదే ఇప్పుడే పెట్టిండు క్యూఆర్ కోడ్ అని.
So, few instructions. Please join the quiz from an area with a strong internet connection. If your internet connection is slow here, you can go out.
ఇప్పుడే చెప్తున్నాను.
Otherwise, you can't get the answers properly. And for PG and PG, this is only for PG and UG level. If you enter the name and registration number in the name, like if your name is Ramu and your registration number is 8MG074, enter your name as Ramu-074 before joining, and then QR code will be displayed here, and the link also will be sent. Who are in the offline group, link will be sent. Online group also will be sent.
షేర్ చేసి
4 marks per question, and if any negative mark is there, for 1 negative mark for wrong question. So 30 seconds per question. 50 questions, 30 seconds per question. 4 marks for positive answer, correct answer. Negative mark for one negative mark.
पंपिना
इसमें
मेरा रिसेंट ऐप्स में व्हाट्सएप में गौतम भाई बोल के चार्ट रहता है, वो ओपन करो, ओपन करके इसमें क्यूआर कोड है वो कर दो.
Google Lens.
अरे क्रोम में देखा. अरे
Send the link and QR code also to offline and online link. Only UG and PG should participate, so registration number is still valid. Now, vendors can look at the ones. Everybody stand in.
Wait, what's on the
Link up.
సులభం క్యూఆర్ కోడ్ ఇది పేర్లు గిట్లా మొత్తం రిస్టార్ట్ చేయాలి ప్రాసెస్. క్యూఆర్ అయితే వర్క్ అవుతుంది, జాయిన్ అయిపోతారు చాలా మంది. ఇప్పుడు లేదా ప్రజెంటేషన్
Online delegates, please join the link. Offline delegates, where the connection is not here, can go also.
రీస్టార్ట్ చేయొచ్చా ఇప్పుడు? ఇది అయిపోయినాక చేసే ఇంకేం వర్క్ లేదా లాస్టే కదా అవసరం లేదు. అయితే చెయ్యి, రీస్టార్ట్ చెయ్యి. వాలిడేటరీ ఫంక్షన్కి ఏవో ఒక ఇమేజెస్ ఉంటాయి పెట్టేవి లాస్ట్. ఇప్పుడు కాదు, నేను క్విజ్ స్టార్ట్ చేశాక చేసి. బాగానే ఉంది.
అంటే కరెక్ట్ గా మీకు
31 people
ఈవెంట్ అతను గోడ లేదంటే మన గోడ దగ్గర పెట్టారు బాక్స్
45 కి స్టార్ట్ చేద్దాం అసలు.
Now I feel privileged to invite
45 కి స్టార్ట్ చేద్దాం.
Dr.
Reddy Panyala, PhD and grade 2 scientist in field applications, for taking up the session on the topic role of nucleic acid sequencing in the detection of liquid and solid malignancies using NGS and DNA sequencing. For this session, I also request Mr. Chaitanya Vegi, Product Specialist, Clinical Sequencing Division, to join us for the same. In addition, I also request Mr. Manoj Kumar sir, Assistant Manager, MES India, to join us for this session. First, our speakers to take over the session.
Organizing committee, especially Dr. Joseph. And I'm field application scientist from Pathology Scientific. In this session, we are covering role of detection and sequencing of nucleic acids in the clinical application, is more focused on in cancer therapeutics. And in this session, from the thermo picture, we are covering digital picture, capillary electrophoresis, both standard sequencing and fragment analysis, covered by me. And my colleague Chaitanya will be covering on NGS applications. And this is today's session's agenda, like where will be like covering for digital picture, see capillary electrophoresis, including both standard sequencing and fragment analysis. We all know that we have now entered the era of precision medicine, where using these advanced technologies, which are enabling like us understanding in various biomarkers of cancers, through which we are focusing on the targeted therapeutics, and which further we can use drugs specific to the gene of specific gene signature based cancer illness. Of course, there is some of the key factors which are involved and which play major role in the clinical applications when we develop a specific marker or specific method to diagnosis or something like that. When it has to reach from the bedside to the bedside, there are some key factors like sensitivity of the assay or the method which we are using, and the fastness, the turnaround time, the TAT, and robustness of the method and assays, and the maximum utility of the sample, whatever the sample we are undergoing for the testing, the utility of that particular amount of the even the sample also plays major role, and the cost effectiveness, it is a plays also a very crucial role, and precision accuracy and both reproducibility of the precise and accurate also the results also plays a major role, and finally and very important is easy workflow. That means even the very basic technician should have the particular methods or assays which are developed in the precision medicine. We all know that in the past and even now there are like a lot of cancer detection monitoring that is being done on tissue biopsies, but the tissue biopsies we all know that having some lot of limitations like reveal the tumor heterogeneity, and is an invasive method and time consuming and costly this one, and difficulty in accessing human evaluation. Like each time we cannot take a biopsy whenever we want, right? And real-time monitoring also very much difficult in this. That's why where we are most of the clinicians and the scientists moving towards the liquid biopsies. Liquid biopsies, nothing but a blood test that detects the cancer cells or cancer cells DNA which is circulating in the generally we call it as circulating tumor DNA or in short ctDNA. And for just like our healthy cells, even the cancer cells do die. And when they are replaced. When these dead cells break down and then they release from the tumors into the bloodstream, and this liquid biopsy detects the small pieces of DNA from these particular tumor cells, and it will be analyzed for the categorizing or specifically studying the cancer markers. And coming to there are many positive side of these liquid biopsies where it is easy to collect the sample because it is non-invasive and real-time monitoring is possible and wherever we want. Like for example, in early stage of cancers and during the treatment, every time we can access these particular samples. And potentially, these are the potentially reflect human heterogeneity also. Like in the tissue biopsies, we may not take a proper exact place of the human point. Sorry. Whereas this liquid biopsy exactly reflects the heterogeneity of the tumor. And the major drawback of the liquid biopsy is the highly diluted sample, because like the sample very low amount of this cancer DNA will be available, and to detect these particular cancer markers, we need to have very high sensitive methods or the detection instruments. And thankfully, like our thermofisher have a very sensitive instruments like digital PCR sequencers, thymus sequencing, and next generation sequencer, which have a very high sensitivity in detecting these particular markers. Firstly, I'll start with the digital PCR. I'll briefly explain about the PCRs, and I think the PCRs can be broadly categorized into three different categories, like a bulk PCR, which can be leverage like our end-time PCR data to conclude whether the sample is positive or negative in the particular sample. And the real-time PCR is depending on the quantitative standards to do any quantitation of particular gene of interest, and they are depending on quantitative standards, and you will get only relative quantity of that particular data. Whereas the digital PCR is depending on the absolute quantity. It doesn't require any quantitative standards, and it will use the actual quantity of the gene of interest, whatever the target, nucleic acid targets. In brief, what happens in the digital PCR, the bulk reaction, the bulk PCR reaction, we are distributing into multiples of microchambers. For example, if you see this particular chamber, this is a single sample distributed into 20,000 plus micro chambers. That means each chamber acts as each PCR tool. That means wherever the sample will go and bind. If you see this blue fluorescence indicator, that is the chamber for the positive cell line, where nucleic acid. Whereas the black or low intensity chambers represent the negative chambers or the low intensity chambers. Once this particular after the PCR completion, you will see the graph, like all the negative chambers which are all negative for the targets will be in the bottom level, and all the events, all the chambers which are positive for the particular nucleic acid targets will be detected above the threshold. And if you see, the digital PCR is quickly becoming the new gold standard in research nucleic acid quantification. And if you see these are the comparison of liquid biopsy versus tissue biopsy, and among the digital PCR data and the real-time PCR data. If you see this, like particularly these three samples, like these are actually 20 events, that means 20 nucleotide targets are positive for this particular sample in the liquid biopsy, whereas real-time PCR detected negative. But the same sample, when we have analyzed under the biopsy, like a biopsy sample, in the both digital PCR and real-time PCR is detected positive. That means what I want to say is in liquid biopsy, since it is a diluted sample, even the digital PCR can pick up the lowest percentage of the frequencies. And these are the different Examples of the allelic frequency mutants, like for example, diverse mutants, the resistance where the allelic frequencies and loop frequencies, and all these can be done in the multiplexing using the digital pixel. Even 1% of the mutation allelic frequency can also be detected using the digital pixel. The workflow of the digital pixel is very much similar to the real-time pixel. You will just set up your reaction, just like your primers and probe plates, and you will load the plate. We'll call it as map 16 plate. Then we will load the plate into the digital pixel, which can be done like the pixel assay, pixel amplification analysis within the same software. And the absolute Q digital pixel assays like positive issues like it is very cost effective and single tube assay, and it is quality wise it is very chemistry formulated that whatever the Tachman chemistry which are using the real time pixel can be updated in the digital pixel. These high sensitivity, like I said, 0.1% mutant allelic mutants are also allelic frequencies also can be detected using digital pixel. In the past, it is like less than 2 hours. Like actually, it will take 90 minutes of the time to complete the digital pixel. And these are the several already from the thermal picture already pre-designed. For example, EGFR and KRAS, NRAS, and different other studies. It is already you can check the thermal picture website for these particular assets. Even if you want, you can customize your own. You can design your own panels and probe, and it will be supported by the thermal picture scientific. And these are the different publications using the digital picture among this. Using the same digital picture, which is supported by the thermal picture on the worldwide. And these are the different installations, filler diameters installed, launched in the market. And most of the cases, like in biopharma and academics, are highly using this, then followed by the clinical and applied methods. And now moving to capillary electrophoresis, which includes Sanger sequencing and fragment analysis by the thermal picture. We call it as capillary electrophoresis because the same instrument can do both Sanger sequencing and capillary electrophoresis. Workflow Sanger sequencing is like it is outlined here. First we do the PCR amplification followed by the PCR cleanup. Then cycle sequencing. Then cycle sequencing cleanup, and this particular cycle sequencing cleanup material will be subjected to the capillary electrophoresis in the instrument. Then the instrument will run and data will be analyzed. And the same thing like fragment analysis also have a similar kind of workflow, but there won't be any cycle sequencing. We label the primers and we run the PCR, and based on the product size, the data will be like the fragment test will be analyzed and the data will be generated. The starting from the entire workflow, the reagent starting from the PCR amplification, PCR cleanup, cycle sequencing, and including the instrumentation and the software, entire will be like entire end-to-end applications, and the reagents will be supplied by the thermal picture. We won't need any like that particular reagents. Of course, our instruments are like open instrument. You can use any third-party reagent, but we do provide starting end-to-end consumables and the reagents. And these are the different areas in oncology and inherited diseases where Sanger sequencing as well as fragment analysis we have the application for this particular this thing. Here in the coming slides, I am covering just a few of the assays applications of this CE. And these are the description of for example, MSI testing, like where MMR mismatch repair deficiencies will be detected, and NGS confirmation and SMB genotyping. Like NGS confirmation, discovery-based genomic research, just like next generation sequence, we find out novel genomic novel variants and new unexpected variants and other sequence anomalies. Investigators look for ways to ways to verify these new discoveries using orthogonal methods such as Sanger sequencing, whether these particular variants are really playing a role in cancer therapeutics. Yes. For that, the gold standard, like standard sequence will play gold standard in the verifying these particular sequences, mutations or like findings which are observed by the next generation sequence. And minor variant finder is one of our like application in this particular application, standard sequencing, where it can detect even 5% mutation. That's variation also it can be detected. If you see this, for this we have like forward and reverse sequencing of the same samples and as well as the controls. What it is that this particular software is free of cost. No need to worry software separately. Like what it is that it will compare the control sample sequencing versus your tumor samples. Then wherever if the minor variant observed, if it is above 5%, it will get detected and captured, and the software itself it will analyze and it will give you the data. And this is a study where we have we have done like different standards of different frequency mutations like 50%, 10%, 5%, and we went up to 2.5% using the three different genetic analyzers of 6 Studio Plex, 3500 XL, and 6 Studio. These are different variants of our Thermo Fisher. So what has that? All the dilutions it has detected, even the 5%, even 2.5% also does detect. All the instruments have detected these particular allelic sequences, but what we generally feel that the detection at 2.5% concentration, it may not detect like ability to fall whether it is really effective variant or not. That's why we stick to 5% abundancy. So we recommend that even if the instrument will detect the variant allele, if it is more as low as 5%. And this the properties like this value properties of this NGS confirmation is NGS can be provided like allelic information from solid tumors, but at a large expense. Whereas standard sequence is very cheaper compared to the NGS and very user friendly method. And the advantage of standard sequence including simple workflow, and the data analysis also will be done in any of the pre-approved like available softwares and with the Thermo Fisher software itself. And the second application where the standard sequence or the fragment analysis can be done is macrosatellite instability. Like microsatellite, actually, like historically, MSI has been used to screen for actually Lynch syndrome, a dominant hereditary cancer propensity. And but recently, MSI status has been like rediscovered as a biomarker for the immunotherapeutic response, making MSI as status and increasingly relevant tool in genetic and immuno-oncology. So what is that? Particularly, like I will just brief about this particular this thing. Microsatellites or they short repetitive sequences scattered throughout the genome. It happens, and sometimes what happens because of this MMR pathway, that mismatch repair pathway disturbs. So it won't have the if something is going on in replication errors, it cannot be repaired. So what happens? These repeats will be like included or deleted. That time what happens that it can be like elongated or the shortened this particular sequence. So, but particularly this MSI assay, so what happens? It will include 35 MSI markers, including Bethesda markers, and 2 sample ID markers to match the samples. And it has 4 hours of DNA result on instrument work and with less than 1 hour on answer like analysis part. So then it will the software itself automatically calls whether it is unstable and stable this sample. So workflow is like PCR sample preparation, fluorescent PCR, and fragment analysis preparation and analysis on the instrument, and the data analysis less than near to 5 minutes. So it has included all these markers, including MSI markers proprietary to applied by Thermo Fisher, and include 2 sample identification models. So in all the instruments like 3500, 3500 XL, and 6 Studio and 6 Studio Plex are compatible for these assays. Once it is done, like this is an assay like observation study. It's a study which there 255 samples, research samples were included. along like colorectal cancer, gastric, endometrial, and lung cancer specific samples are included. The normal, when you observe this normal and tumor versus samples, if you see the graphs, like these are the normal sample peaks, and if you see this particular graph and it is also having adjacent one more peak, that means it is deletion like before. Like for example, if it is 200 base pair product, it may be like 180 base pair. So that means the allele frequency is having like deletion, like some amount of this particular whichever is normal the allele frequency as well as the insertion of the MSI repeats products. And the software will automatically detect. There is no use of controls in this. Like a normal range of fragment size will be compared with the fragment size arraying due to the microsatellite instability, and the software itself will call whether it is unstable or stable. Particular MSM
Welcome,
50-30
ma'am.
minutes అంతే.
With equal pressure, I like to invite Dr. Jyoti Verma ma'am, Co-Organizing Secretary and Assistant Professor, Department of Pathology, AIMS Mangalore, onto the stage. Welcome, ma'am. I cordially invite Dr. Sunil sir, Treasurer and Assistant Professor, Department of Pathology, AIMS Mangalore, to join us on the dais. Welcome, sir. Talents and skills are the crops that are nurtured, grew, and given all possible opportunities to grow and bloom. Following the old tradition, now it's time to acknowledge and encourage the talent of the presenters for their academic excellence by prize distribution ceremony. I request Dr. Josna ma'am, Organizing Secretary, to announce the winners of Best Proposed Papers. And I request our respected Dean Examination, Professor Dr. Desa Ramohan sir, to honor winners with their prizes.
Good evening to all. The first profit paper goes to FOP 11, Dr. Shushma. Second profit paper goes to
Bro, payment now. ఏం పాటలు కాదు, ఓన్లీ బీజిఎం పెట్టి అంతే. నిజంగా కొత్త చేసినావు ఈవెంట్ నువ్వు మధ్యలో
డిస్ట్రిబ్యూషన్ కదా ఇది.
best profit paper.
కాన్ఫరెన్స్ బ్యాక్డ్రాప్ పెట్టేసి ఫొటోస్ లో మొత్తం
NRI Medical College.
ఫోటోలు అట్లా రాదు. నిద్ర ముఖాలు మొత్తం పోవాలన్నా సౌండ్ పెంచు. అవునండి యాక్షన్ సౌండ్ పెంచు. పెంచు సౌండ్. నిద్ర ముఖాలు మొత్తం
Third prize goes to FOP 21, Dr. Vivek Nair, Assistant Professor, Malabar Cancer Center. Title is Depth of Invasion and Tumor-Infiltrating Lymphocyte as Predictor of Lymph node Metastasis in Early Squamous Cell Carcinoma.
కొంచెం గట్టి కుదు.
slide for best poster presentation. So all the postgraduate has back first, second, and third position. The first prize goes to PG primary signet ring cell carcinoma of the cervix, rare age report. That is by Dr. Sinduruti Priyanka, Subhati Medical College, Karnuli.
ఏమంటాడట లైక్ అసలుకి మధ్యలో ఎట్లా పెట్టారు అవార్డ్ టైంలో కూడా మ్యూజిక్ అంటారు
Economics postgraduate poster. Best poster and also postgraduate poster.
ఎవరు బ్యాటర్? హలో. నెక్స్ట్ శృతీక్ష 9082.
I request all the junior residents of Pathology Department to join us onto the rise.
92.
Hello. Again, what of plan to live? Please continue to live.
We acknowledge our compounder for sparing her time with us for the past 2 days and past 1 week she is struggling with us. So thank you so much for coming.
అప్పన్నా ఈమె ఎన్ఆర్ఐ కాలేజ్ రెడ్ సార్ పింక్ సార్. హలో.
Faculty, senior residents and postgraduates to join us on the rise for the group photograph.
ఓకే, ఆయన నాకు నాకు అర్థమైంది. అంటే నాకు ఇప్పటికీ ఇట్లా 1 వీక్ అని ఒక 10 స్టార్ట్ అయిపోయిందా.
నాకు అర్థమైంది. నేను అందుకే అర్థం చేసుకొని నేను కూడా ఏం మాట్లాడలే కదా ఇన్ని రోజులు. కానీ మరీ ఇక ఇంట్లో తిట్టించుకోవాలని తెలుసుకోవద్దు కదా నేను కూడా. ఇప్పుడు నేను ఇచ్చేసి అన్ని ఇచ్చేసిన కానీ ఇప్పుడు 80% పే చేసిన నార్మల్ అడ్వాన్స్ 50% ఇచ్చి మనం తీసుకున్న తర్వాత ఇంకో 50% ఇస్తారు నార్మల్ వేరే వాళ్ళు. నేను 80% పేమెంట్ నమ్మకంతో చేసేసిన ఆల్రెడీ. ఇప్పుడు కనీసం ఇప్పుడు ఎంగేజ్మెంట్ తెచ్చేసినా ఏమో అనుకుంటారు. ఒక్కటి కూడా ఇంటికి రాకపోతే ఎట్లుంటుంది చెప్పు.
I request Dr. Sunil sir, Treasurer, to announce the winners of online quiz competition, and I request our respected Dean Examinations Professor Dr. Reza Ramohan sir to honor the winners with their prizes.
Okay, thank you.
First prize goes to Bellamkonda Monica, registration number of 92.
Okay.
The points are 94 points here.
పర్లేదు అంటే నేను మస్తు రోజులు అయిన వాడు నీకు కాల్ చేసినప్పుడు ఇన్ని రోజులు నేను నీకు 1.5 year అవుతుంది. మా ఇంటికి ఏ కావాలి మాకు ఆల్మోస్ట్ మై వాళ్ళ బాగున్నాడు కదా దగ్గర సతీష్ అన్న ఆయన దగ్గర తీపిస్తాం ఈసారి కూడా తీపించడం కానీ ఈయన మాకు తెలిసిన వాళ్ళు కదా ఏం ఉంటాడు కొంచెం కంఫర్ట్ ఉంటుంది తొందరగా వచ్చేస్తే అని చెప్పేసి అన్నా. చెప్తే సరే అని అన్నారు. అయితే ఈ మధ్యలో పెళ్లి లేకుండా నేను ఇవ్వండి ఫోటోగ్రఫీ అంటే అది ఒప్పుకున్న తర్వాత
మనం క్వశ్చన్ చేయకపోయినా కూడా వాళ్ళకే వచ్చింది ఫస్ట్.
1.5 year అయింది. 1 year అయితే 4 నెలల ఐడీలన్నీ తీసుకుంటాం మేము.
బెల్లంకొండ మౌనిక
అయితే 3 నెలలు రా మేము డిలే చేసిన కోసం వెళ్తుంది డిలే
అయితే
ఇతర అయ్యేసరికి
కాదు
డాడీ కొంచెం
I request Professor Dr. Reza, APMC observer, to share few words about the conference. Very good evening to one and all. So whenever there is a conference, there are two important things that we remember. One is the hospitality and also the food and the academic sessions. That is the most important. The academic sessions in this conference were really excellent. So each and everything, even the faculty members had a lot to learn from. And we can see how hard they have worked to get all these speakers online and offline. And I know how difficult it is to organize a conference. And in a short time, they were able to do it. And I really congratulate all the members, especially Dr. Josna, Dr. Jyoti. They were continuously, they were connecting with me and asking me what should I do, and they were asking me a little bit of advice. But I think basically they are all really good at it. So I really congratulate them, and I think we all should give them a standing ovation. Please, can you stand and give them a standing ovation? Thank you, ma'am. Your words are real boost to us to conduct the conferences in the near future. Now we are resuming back to the scientific session. I request Mr. Manoj Kumar sir, Assistant Manager, Miss India, to join us on the dais for the session.
డైరెక్ట్ గా ముందు మండలాలు ఇండైరెక్ట్ ముందు మండలాలు
సైంటిఫిక్ లేదు పొక్కలేదు ఇంకా ఒకటే చిన్న నాకు తెలిసిన బిట్ ఒకటి ఉన్నది కదా దాని గురించి అది చెప్పలేదు బిట్ లేదు ఏం లేదు అయిపోయింది నువ్వు పంపించిన దాంట్లో 3 పీపీటీలు ఉన్నాయా 2 పీపీటీలే ఒక పీపీటీ ఉంది క్లోజ్ చేసేద్దాం అన్నారు అదే లేట్ అవుతుంది వ్యాలిడిటీ పోస్ట్ లో వ్యాలిడిటీ పెట్టుకుందాం అని చెప్పేసి ఓ ఎవరు లేరు బ్రో కావాలంటే ఫోటోలు ఇస్తాను వెళ్ళిపో ఎందుకు ఇదంతా బ్రో చేంజ్ పోడియం ల్యాప్టాప్ స్విచ్
Good evening, all. I am Manoj Kumar from Medical Electronics System. It's a 25 years research company for total embryology purpose. And we have a automated sperm analyzer here. Why we need computer assisted automated sperm analysis and what way it helps?
Okay.
So before going to start the topic, I would like to discuss. So India is still lagging to include that India is still lagging to include that automated sperm analysis in WHO reference because WHO is not recommending net servers for reference ranges at all. So there are small countries like Japan, European countries, they are doing that markets, but we have a lot of problems and lot of people still there, but we are not getting into the WHO manner. And one person from Hyderabad, Dr. Tulai is proposing that India has not participated in WHO semen examination, causing that there is no standard data available in the country. So these are all matters just for there are intra and inter deviations will be there, and interpersonal deviations in the MRI report are subject to parameters and hours of testing protocol will be there. If you want to do the manual sum analysis, it takes 45 minutes to 1 hour will be there. There are is the sum analysis report overview. The subject to parameters most of the time not giving enough information to them. So everybody is giving complete and concentration. Other than that, we have the also for the clinicians and patients. More policy, more complete and more finding the normal morphology is very difficult to find out. So we are abnormal morphology. Normal we are seeing other persons they are seeing that is abnormal. There are a lot of variations will be there. And most of the time, most towards the female factors.
వైజాగ్ వెళ్తే నాకు విజయవాడ రావచ్చు మళ్ళీ హైదరాబాద్ మా ఊరు
These are all the indications
వైజాగ్ వెళ్తే మాకు అసలు రాదు
subject one impossible to do the standardization and highly variable and these are all the sum analysis report overview. Accurate object reports are available. Access all the parameters in the sum sample automated system as per the WHO. More detailed parameters about the mobility velocity microscope, how we are going to find out that 24 micron per second. In our system, we are transmitting via velocity. That's how much speed it is moving. Reports for the mobility parameters.
బ్రేక్ రాజా
So that automated system working fast and accurate eliminated operator error for manual methods. Accurate report relates to the appropriate clinical decisions to the gynecologist. The need of objective report because the WHO keep updating their manual for last 2 decades of the system. Now previously we have WHO 4 and WHO 5, now we have WHO 6. There are a lot of different changes will be there. And it should be helpful for the couple who are testing for latest WHO